Bismillahirrahmanirrahim. Assalamu alaikum. Today we are going to start the first session of this symposium, and this session is focusing mainly on functional bowel disorders, and along with that, there is one talk on colorectal carcinoma. And to chair the session, I would like to invite Dr. Shahzad Riaz, who is consultant gastroenterologist at Shifa International Hospital. Dr. Adil Nasir, who is head of department at Ayub Teaching Hospital. He is consultant gastroenterologist. And Dr. Habib Jadoon, he is also consultant gastroenterologist at Aptabad. Our first talk is by Bilal Nasir, and he is going to talk about chronic constipation and evacuation disorders.
Bismillahirrahmanirrahim. Thank you for the organizing committee for inviting me to discuss this important topic which we came across in our day-to-day practice, chronic constipation and evacuation disorder. This is an old saying that no organ in the body is so misunderstood, so slandered and maltreated as the colon. It's not true at this era, as we have a better diagnostic tools and we have better understanding of the colon, and we have better diagnostic modalities to reach a diagnosis and have a better management. Constipation is a polysymptomatic multifactorial disorder, one of the most common GI disorder which we came across in our day-to-day practice. 15 to 20% of the population is estimated to be affected with this. More prevalent in women, elderly and non-Caucasian population, constipation, and it has a substantial burden on the healthcare resources. This is very important that usually when we say constipation, the physician thinks that it is the bowel movements less than 3 weeks per, less than 3 bowel movements per week. We say that this is constipation. But considering the patient perspective, if patient starts training, they say it is constipation, sometime hard and lumpy stool, incomplete emptying, and even abdominal fullness and blotting. So there is variable and various presentation which patients tell you. So it's very important that you should ask the patient that what he says about constipation, what he thinks that this is constipation. So due to this variable presentation, the Rome-4 criteria has been established for the diagnosis of chronic constipation. And for the chronic constipation, it is important that the symptoms should last for 3 months and symptom onset should be at least for 6 months. And 2 out of these criteria should be there to label that patient as a chronic constipation. So in more than 20, at least 25% of the defecation, he has straining, lumpy or hard stool, sensation of incomplete evacuation, sensation of anorectal obstruction and blockage, manual maneuver to facilitate defecation, or less than 3 defecation per week. So if patient says that out of these 2 symptoms and more than 25% of the defecation, and these symptoms persist for 3 months, we label that patient as chronic constipation. This Bristol stool chart, it should be in our clinic so that we should we should ask the consistency of the stool and the shape of the stool, and because generally the description would be variable. So type 1 to type 3, we consider that these are the patients who have chronic constipation. These are the constipated stools. Rome-4 functional GI disorder classify chronic constipation into 4 subclasses. This is functional constipation, irritable bowel syndrome with constipation, opioid-induced constipation, and functional GI disorder, functional defecatory disorders. There is another way of classifying constipation is the primary constipation or secondary constipation. In primary, we have slow transit constipation, evacuation disorders, and IBS-C. But in secondary, it can be drug-induced, the commonly opioid-induced constipation, the patient can have a dietary issue like he's taking poor fiber intake, and there can be behavior, endocrine or metabolic pathologies which can lead to constipation. We are primarily discussing the primary constipation in this talk. Slow transit constipation, it is commonly due to the muscular issue like myopathy, neuropathy, and it can be associated with evacuatory disorder. Like patient starts with evacuatory disorder and later on he has slow transit constipation, or sometimes patient have slow transit constipation and then later on it develop this evacuation disorder. In evacuation disorder, we have anorectal dysfunction or structural disorder like patient can have rectocele, or there can be intussusception or rectal prolapse. IBS-C, again, if patient have pain and he has this hard stool, then we can say that this patient is suffering from IBS constipation. We will be discussing these two things in detail in our subsequent talk. To know about defecation, we should at least know what is the normal anorectal function. So I used to say to my patient that for a effective defecation, it's an example of a tube of a toothpaste, because it has to be full. You have to know it is full. You have got to squeeze it and take the lid off, and you have get to put the lid back and when finished. We replicate it with the rectum, that the rectum should be full. Patient should have an urge for defecation. He should have an effective rectal pressure, and then there is the proper relaxation of the sphincters or anal canal, and after that there should be the closure of the anal sphincters. So this is the normal normally normally we should have this thing. And normally when we have in this cartoon, we say that these are the internal anal sphincter, external anal sphincter. The internal anal sphincter is basically contracted in the resting tone. And when we have the rectum is empty, the internal anal sphincter is closed. But as we have a mass movement, it causes rectal distension, leading to rectal ano inhibitory reflux. This is very important reflux because it causes the internal sphincter relaxation. And whenever there is internal anal sphincter relaxation, we have an urge for defecation. And in response to this urge for defecation, the anorectal perception and voluntarily external anal sphincter contracted. So this reflex is absent. If this reflex is absent, it means there is something wrong with the plexus, these parasympathetic fibers, and this is true with the Hirschsprung's disease, because these patients doesn't have any sensation of or urge for defecation, and ultimately they end up in a large rectums. Normal physiology, if we say that there are, as we have already discussed, there is internal anal sphincter and external anal sphincter, and we have the puborectalis muscle is there, which is normally present there. And in normal defecation, when there is rectal distension and all the reflux mechanisms starts, there is rectal distension, the contact diaphragm and the contract diaphragm, abdominal muscle, rectal muscles, they contracted, relaxation of the external anal sphincter, and lately the puborectalis muscle relaxes, and the stool passes through smoothly through the anal canal. Diagnostic workup for chronic constipation, we would say that this is the history is very important. You should define that whether it is fulfilling the criteria of chronic constipation. The clinical examination to rule out all the secondary causes as well as any abdominal mass. Digital rectal examination is is an excellent tool so that we can assess the tone of the muscle, we can assess the tone of the sphincters, we can assess any fecal impaction, and also when we ask the patient to push or bear down, we can also have a rough estimation of the perineal descent, whether this is a normal perineal descent or not, and we can at least anticipate that this patient might be suffering from some dysenergic defecation. The investigations, their list of investigation, the colonic transit studies, anorectal manometry, balloon expulsion test, rectal barostat test, defecography, and MRI pelvis. We'll be discussing in one by one. Colonic transit study, there are three ways of doing this test. One is the radio opaque marker, in which we ask the patient to take a capsule. This is a radio opaque capsule which contains 25 rings or beads. And after taking with meal, we do the radiograph after on the fifth day. There are two different methods. Some people says that they give multiple capsule at day 0, day 1, day 3, or we can give a single capsule and we do a radiograph after 5 days. If there is 20% reduction, 20% retention of these radiopaque markers in the colon, we say that this is a slow transit in through the colon. This is a newer modality, the wireless capsule. We ask the patient to take the capsule, he swallow it, he has to wear down a recorder with his vest, and he has to keep it for 5 days or till the capsule is evacuated. We measure with this capsule the pH, the temperature, and the pressure. And with this capsule, we can measure the gastric emptying time as well. We can say that we can measure the transit through the small gut, and as well as the colonic transit, the transition through the colon can be measured. Then is the scintigraphy, in which we ask the patient to take the indium labeled this sandwich, and we take different pictures at different time with the gamma camera. And in the slow transit, you see there is retention of a lot of meal is there. So we can say that this is a slow transit study. In anorectal manometry, we have the basic equipment we required is this micro transducer catheter. This is solid state catheter. We need a balloon to hold it and do the different maneuvers. We need a software based this machine, and we have to place the catheter through the anal canal into the rectum. And when we place the catheter into the rectum, the one transducer should be outside the anal canal, and that would tell us about the atmospheric pressure, which is low. And the other transducer, one transducer should be in the rectum, and that would be telling about the rectal pressure. Rest of the 5 or 6, depending upon the what catheter you have to place it into the anal canal. And as I have told you that normally we have the internal anal sphincter which is contracted. So the resting tone would be like this. When we ask the patient to squeeze, in squeeze, what patient do is he contract his external anal sphincter. So with the external anal sphincter contraction, we can clearly see there is rise in the pressures, and this is normal anorectal manometry. Balloon expulsion test, often used in combination with manometry. Simple office based test. It's identify the impaired evacuation. The time required to expel the balloon depend on the method used. Usually what we do is we put a 50 ml fluid or air into the balloon, and we ask the patient to evacuate it. And normally patient can evacuate it in 1 to 2 minutes. If it is more than 2 minutes, we say that there is some evacuated disorder. But problem with this test is that we cannot diagnose that this is a dysenergic defecation, because there are multiple issues, social issues, and the sensation of the stool. It is a simulated stool, so it is very difficult to assess that on this single test. But we can have assessment, and we can proceed with the different other modalities. Rectal barostat, in which what we do is we place a large bag, we filled it, we filled big bag, and we can have a pressure. That thing is basically to diagnose the sensitivity of the rectum. Sometimes we have hyposensitive rectum, and patient does not perceive the stool, so it is, and then there is a rectal impaction, and then this dysenergic mechanism started and patient have a difficulty in passing the stool. Evacuation proctography is another real-time anatomical dynamic study of act of simulated defecation. It involves fluoroscopic imaging of the process rate and completeness of the rectal emptying. So it is, again, we need a machine, and we ask the patient a new stool we put in into the rectum, and we ask him to evacuate it. Whether it is evacuating properly or not, we will see it on real-time images. I'm skipping through this. MR defibrilography, a newer modality, not readily available, but we can assess that as on an MRI machine. We again produce a new stool and ask the patient to defecate on a while we are performing different images, and we can assess any structural abnormality on this as well, not only the functional abnormality. This is the anorectal manometry, the normal defecatory process. This is the resting tone. When we ask the patient to strain to defecate, there would be a decrease in the significant decrease in the anal tone. So this is the normal normal defecatory maneuver. In dysenergic defecation, what we have is there are multiple factors, there can be problem with the sphincters, there can be problem with the puborectalis muscle, there can be a problem with the rectal hypersensitivity, and simultaneously there would be incoordination or dysenergic coordination or paradoxical increase in the sphincteric pressure when patient is bearing down. These are the different, these are the conventional manometry. I have just put it to better understanding that normally what is going on when there is a rise in the rectal pressure, the anal pressure start decreasing. But if there is rise in rectal pressure and the anal pressure start increasing, we label it as a dysenergy, and this is type 1. And in type 2, generally there is no rise in the rectal pressure, but there is a rise in the anal pressure, and we label it as a type 2. Similarly, type 3, there is poor relaxation of the internal anal sphincter rather than the rectal pressure. The problem is with the anal canal. There is impaired relaxation. These are the 4 different type of defecatory disorders. This dysenergic defecation. On high resolution manometry, where we have colors, what we ask the patient to push, and there is a good increase in the rectal pressure, but simultaneously there is strong increase in anal pressure. So this is again a dysenergic defecation type 1. In type 4, we ask the patient to bear down, no increase in the interrectal pressure generated, and there is no sphincteric relaxation. So this is type 4. There are different other structural abnormalities, like patient can have intussusception, which can be diagnosed on this defecography. There can be rectocele, and this is the normal rectum, which we fill the rectum, and this is the mega rectum that can be on defecography. In summary, symptom diaries and digital rectal examination can provide useful assessment of the sphincter pressure, presence of dysenergy, and fecal impaction. Anorectal manometry with rectal sensory testing is the preferred method for diagnosis of dysenergia and abnormal rectal sensation. The balloon expulsion test can confirm impaired evacuation, but by itself is not diagnostic. And there is good evidence to support the use of these physiological tests and to define the underlying pathophysiology in subject with constipation and guide to a better treatment. With this, I'll thank you for your patience.
Thank you, Dr. Bilal Nasir, for such an excellent talk on functional constipation and different anorectal dysfunctions. And I think this is a very poorly understood subject among the gastroenterologists, because most of the time, every constipation is being treated on the same lines. Our next talk is by Dr. Jonathan Sutton. He's consultant gastroenterologist at Wales, UK, and he's pioneer in fecal microbial transplantation. And this is a recorded lecture, and he's going to talk about probiotics and fecal microbial transplantation.
Okay, ladies and gentlemen, thank you very much for your kind invitation to talk at this prestigious meeting. I'm Dr. Jonathan Sutton. I'm a consultant physician in Bangor in North Wales in the UK. The topic I've been given is probiotics and FMT. Confessions, I'm not going to talk about probiotics, but I am going to talk about FMT. There's quite a lot to try and get through in 20 minutes, so please bear with me. There is a humour to giving faeces to patients which can't be ignored, and I get lots of reaction to that. Alternative titles for this talk could be Toying with Human Motions, but unfortunately this has already been taken in a publication in the Journal of Gastroenterology back in 2004, so we're left unfortunately with a fairly dull title. The overview of the session, I'm going to talk to you about why this topic is important. I'm going to give you a case presentation to discuss why the kind of patients I'm treating with this technique. We're going to talk a little about recurrent Clostridium difficile, why FMT works, and then we'll talk a little bit about practicality of delivering FMT, and then right at the end we'll try and talk a little bit about the potential therapeutic areas for FMT. So why? I've spent the last probably 6-7 years at various meetings talking about FMT. There are lots of reasons. I think we shouldn't lose sight of the main one, that actually having chronic diarrhea for patients is a pretty bad thing. They don't like it. It affects their quality of life. And I think we should be aware of this. There's also lots of talk now in the literature about microbiome research and modifying the microbiome for health. And this is one of the areas which comes up time and time again. And it's important to have a bit of knowledge about this. The other thing with patients we shouldn't forget is that FMT is actually quite a serious illness. It does kill patients in significant numbers. Now, this slide shows you the 21 most common cancers in the UK and their mortality rates, with the best being at the bottom and the worst being at the top. Sorry, the other way around. Sorry, the best at the top, worst at the bottom. And if you plot C. diff on this graph, it comes down quite low. Okay, so it kills significant numbers of elderly patients. And we shouldn't lose sight of this. Also, we do need to be aware that although this is a fairly out there technique in many ways, the public are on board with this and are aware of it. Okay, so there's lots of stuff on the internet. If you're brave enough to Google FMT, you will find all sorts of websites talking about it, giving you examples of how to do it. This particular site shows as a YouTube video giving fairly graphic description of how to administer an FMT to yourself to, quote, cure your ulcerative colitis. And then all other science websites are aware of this case. Okay, so we need to be aware of it clinically as well. Case history, I'm going to give you a case history of one of my patients who I treated early on when I was doing this. It's a 76-year-old man who was admitted to his local hospital with actually a community-acquired pneumonia. He was managed in intensive care because he was so poorly. He had a cardiac arrest on intensive care, had a coronary angioplasty, and subsequently developed acute renal failure. This guy's having a really torrid time in hospital. He ends up on hemodialysis. He then ultimately develops C. diff diarrhea. He was given 14 days of metronidazole, which helped his symptoms but recurred on stopping. So he was therefore given a further 14-day course of vancomycin, which again, things got better but worse. He then had, for reasons I don't fully understand, another 28 days of vancomycin and metronidazole. And then this still didn't cure his problem, and he ended up on fidaxomicin, which by this stage was probably too little too late. And again, lo and behold, he ended up with diarrhea. So he was referred to me. I just started doing FMT transplants, so I brought him across and chat with him. Now, at this stage, I was using donor from the relatives. So his wife had spectrum, had long-term antibiotics, so she couldn't be done. His daughter had recurrent tonsillitis. He had 2 grandchildren, but even I drew the line at using his grandchildren to deliver FMT to him. And we opted to use some frozen material, and I'll explain that to you after. 8 months after the transplant, when I reviewed him, he had no further diarrhea. So Clostridium is difficult and obstinate to culture, which is why it gets its name, and it's also difficult and obstinate to get rid of, partly because it's a spore-foring organism, which is what causes some of the problems. It can be a minor part of your background microbiota, but as you know, causes diarrhea when the other flora is wiped out by antibiotic use. Causes recurrent diarrhea is when you get complete resolution of symptoms and only for them to reappear when the treatment is stopped. And if you look at molecular methods, probably about 50% of what we consider to be relapses are actually reinfections. Most patients you have will respond very well to your initial antibiotic therapy. Approximately 25% will then have a recurrence. And once you start to have a recurrence, you're much, much more likely to develop further recurrences. So first recurrence, 25%, 35 to 45% of those will have a second recurrence. And then once you get beyond that, it gets higher and higher and higher. And this is what demonstrated in the case. Okay, and what you do with these people is quite difficult. People give long courses or tapered courses or pulsed courses of vancomycin and hope this will deal with the spores, and it does sometimes have an effect. But we can use fecal transplant now. I'm going to argue in this talk that fecal transplant is a very good evidence-based, therefore we should use it. History, interesting, it goes back a long time. In the 4th century in China, they were using it to treat food poisoning and other GI complaints. It was also given as a yellow soup in the 16th century to cure various abdominal complaints, but clearly for obvious reasons, if you get yellow soup, it didn't really catch on particularly well, so nothing much happened. Okay, you roll the clock forward to 1958 in the States, in Denver, and this gentleman, Professor Eisman, treated 4 patients of his who had pseudomembranous colitis, and he had found this or seen the association between antibiotic use and pseudomembranous colitis, and therefore hypothesized that this would be possibly due to the bugs being lost, and therefore giving it back as a stool might help. And indeed, he cured 4 patients doing this. Didn't really catch on. Nothing much happened. There's probably lots of new antibiotics to play with at the time, and therefore people didn't want to be messing with feces. So nothing much happened. We roll the clock forward to 1991 in the Bronx in New York. Dr. Lawrence Brantz, gastroenterologist, rediscovered FMT, although initially he thought he'd found a novel idea. He produced a significant case series showing very good, very impressive cure rates of over 90%. This didn't really catch on either, because the argument was there's no evidence base for this. There's no randomized trial data, and there are various pockets of people around the world who may have been doing sort of a few FMT or having an interest in FMT, but it didn't really catch on because of lack of data. This all changed in 2013 when this paper, a seminal paper in the New England Journal of Medicine, showed that FMT did indeed work on a randomized controlled trial. And actually what they did is an open label trial. It's quite difficult, clearly quite difficult to blind for giving feces, and there were 3 arms to the study of vancomycin plus bowel lavage plus FMT, and then there's a standard vancomycin arm and also standard vancomycin plus bowel prep. And if we look at the results of this trial, you can see after the first donation, over 81% of your patients are cured. If they didn't cure, you'd give them a second donor feces from a different donor, and that will take your cure rate to nearly 94%. And actually comparing this with the other arms of the trial show clearly that FMT is having a great effect. The reason is for this is, if you look at the biodiversity, this is your healthy population of donors, and this is your patients prior to infusion, and this is after infusion. So you can see clearly there is a large improvement in their biome. The trial was stopped early because all the patients had got better. The success rate of 80%. Okay, so why does it work? Okay, when we talk about this, normally we talk about dysbiosis. Giving antibiotics perturbs the microbiota. Often this is transient, but if C. diff gets in, it becomes persistent, and giving FMT restores the biodiversity, disrupts the dysbiosis, and allows clearance. Okay. One way of describing it to patients is that what I would do is say that this is your gut biome is like a green, lush lawn. Okay, you've got lots of healthy grass. If you give antibiotics, you can damage this lawn, causing holes to appear for things to get in. And if you then try and cure that, you can do it 2 ways. You can give antibiotics, which is basically like burning it all off and hoping it grows back. Or you can give FMT, which is basically like returfing your microbiota. Okay, so clearly it works. Okay, we know it works. Why? Why is it not more commonly used? there's probably some obvious reasons why people don't use it. This is a study of UK physicians who treat C. diff diarrhea. 130 cases, 130 patients, physicians, sorry, 100% said they treated recurrent C. diff, 20% had treated a patient with FMT, 65% had neither offered nor referred for FMT to another. Of those, the biggest argument they've not seen a suitable patient. But actually, when you look at the trial, they had seen patients with 2 or more recurrences, and 56% of these people had seen 3 or 4 recurrences, 3 or more recurrences. So they've clearly seen patients who would be suitable for FMT. The other argument is it's too unappealing for patients. So that's the biggest slice. And then logistical barriers, which is possibly a reasonable explanation, and too unappealing for doctors. And I would argue perhaps these are the more honest people amongst the thing. One person seems to be worried about how he's going to get paid for it, which is again, it is an issue that needs addressing. The evidence-based barriers that they were looking at is in terms of favours use. They thought there was a good evidence base. They thought risk benefit was in the favour of giving it. Overall cost was there. Antimicrobial resistance benefits and patient safety all felt improved. What they felt less comfortable with is they didn't think patients would accept it. They thought donor selection would be difficult, which is true, and availability of prepared feces, which we'll get onto a bit later, hopefully. And then obviously the logistics of actually physically doing this and having someone local who can provide it. So patient attitude is what I always get. So clinicians always tell me that patients will not let me do this to them. It is wrong. Patients are more than happy to have this done. These are patients who have had recurrent diarrhea for many months, often are thoroughly fed up with being treated with antibiotics that don't work and actually want FMT. So this is a study to demonstrate this is a healthy volunteers, not C. diff patients. So these are people sat around in outpatient clinics with two potential scenarios. First of all, they are suffering with C. diff, and it talks about what that involves. And they have 2 treatment options. They can either have a further course of antibiotics with a success rate quoted at around 65%, or you can have antibiotics plus full reconstitution with a success rate of 90%, but it doesn't tell you what that is. Second scenario is exactly the same scenario, but this time they can clean about what a full reconstitution actually means and possible routes of administration. Scenario 1, 85% would choose floor reconstitution, which makes sense, doesn't it? Because it works better. But interestingly, in scenario 2, still, most people would choose floor reconstitution, even knowing exactly what it is. And this would increase to over 94% if it was what was recommended by the doctor. Okay. We'll talk briefly about safety now. Most of the data is retrospective, which is a problem, and this will hopefully change as it becomes more common and registries are formed. Minor symptoms in the abdomen are quite common afterwards. So people get bloated, feel a bit crampy, abdominal pains, that kind of thing. So that usually settles very quickly. There are serious potential risks. So some related to the mode of administration, so the normal risks of a colonoscopy, for example, or a nasogastric tube insertion, that kind of thing. There's a risk of transmitting effective agents, or even effective agents we're not yet aware of, which is possible if you look at the example of blood transfusion, Hep C, for example, that kind of thing. And then we also know there's an association with gut health and chronic diseases, and certainly autoimmune diseases. And is there potential for causing an autoimmune disease in a patient by altering the microbiome? And the answer to that is we don't know yet. What I would say on that score is if you're treating elderly patients, frail patients with chronic diarrhea from C. diff, I think the risk to benefit ratio is far in favour of the benefit. That might alter if you're treating young, healthy people with or young people with inflammatory bowel disease, for example, where you might give recurrent FMTs over a period of time. That might change that. We don't know. Okay, so we locally must have had 2 relapses. Tapered vancomycin, although these days I wouldn't bother with tapered vancomycin. If they have 2 relapses and they're still symptomatic, I would treat them. We opted to use colonoscopy as a preferred method. mainly because I had access to it and it somehow felt safer. I'll explain maybe that's not the case. Referred to these relatives as donors initially because we thought it'd be easier to find. And these, I'm not going to go through these in great detail, but this is donor selection. So they have to do a pre-donation screen about risky behaviours, etc. They have to have a normal BMI. They should have bowel symptoms, etc. This kind of thing. They then have screening bloods done and stool tests done. Actually, now we also test for COVID as well. If you're doing it locally, this method, you would need some specialist equipment, household blender. You would then say like this. This is what we do. This is me and my colleagues getting ready to do it. Filter it through a filter. This is, you end up with the product here, and this is the patient. For the patient, we continue vancomycin until about 48 hours prior to the procedure. This is to make sure that C. diff levels are potentially lower, and they might be. We give full bowel prep, do a colonoscopy to terminalium, and put 500 mils of slurry in the intestine. I give loperamide immediately in the room after the procedure, and then bed rest for 6 hours, and then repeat loperamide at that point as well to try and hold the material in the bowel so it can engraft. The issue is finding donors can be quite tricky. It can be difficult to find donors who fulfill all the criteria. It takes time to perform the screening, and it's pretty messy to prepare the stool as well. In fairness, there are alternatives. You can use prepared frozen material if it's available to you. I'm not sure what the situation in Pakistan is, but certainly in the UK, there's now a stool bank which we can access material from. And frozen seems to work as well as fresh. How you give it, there are various ways of doing it. You can give it the top end by a nasogastric tube, which at the moment it tends to be what I do. You can also give a nasovaginal tube, although it's more difficult to place. It's in the literature, but I would strongly advocate against giving it through an OGD, because my risk is you've got a patient lying on a left lateral position with a scope holding open their lower esophageal sphincter and their pylorus, and then you pour feces into the small intestine. My worry is that with the air from an endoscopy in there, they are just literally going to vomit it straight back up, and the risk of aspiration and death is high, and I would advocate against it. NG tube actually is very good. You have the patient sat up, give a smaller volume, and the patient tolerated very well in my experience. Capsules, or so-called crapsules, are available, but they're still early days, and they take quite a lot of capsules to treat the patients. You can give it either via enema or colonoscopy. The success rate from lower GI is better, 93%. Upper GI is still high, 81, 82%, but is not as effective as the upper. But you have to weigh that off against how stable the patient is for a colonoscopy. Okay, so I think we have to be sensitive about it. The future. So I haven't really got a lot of time. It's quite a short session. These are things that are allegedly treatable by FMT, and we've discussed C. diff infection. There isn't really a defined diagnosis of dysbiosis, and therefore I think it's difficult to do that. IBS, the evidence seems to be it often makes it worse, not better, which is quite interesting. Autism, there is very little evidence. There is some emerging evidence for treating chronic infections, so CRE, VRE infections. Decolonization is possibly quite effective way of doing it. Inflammatory is interesting. Crohn's disease is limited evidence. Ulcerative colitis, there is some emerging evidence from randomized trials that colitis could be improved. There is currently a pilot study in the UK being completed called Stop Colitis, but they're yet to publish. But I think this, in gastroenterology terms, this could be the next area of interest, but it's too early days. Governance. So I think this is the future. Certainly in the UK, we are moving more and more to using banked stool material now. So there are places in the UK who will screen the material, screen the donors, prepare the material, and send it to you. This improves your traceability. Every donation is aliquoted, so they are able to go back and check. We have a register of who received what from whom. It allows a look-back exercise if there's problems. And it also means that the material is prepared in a standardized way. This would lead to a registry which would actually give us more information about long-term side effects and efficacy, and also will be a tool for research for other indications. So in summary, I'm going to argue that FMT is now an established treatment for recurrent C. diff diarrhea. Uptake has been slow. Novelty of FMT is a barrier. Guidelines which do exist now offer a framework, evidence-based framework, but I think governance is critical, and a national approach to material preparation would be beneficial. Okay, so that ends my talk. Thank you very much for your time. I hope to be with you linked in on the call, so if there's any further questions, I'll be happy to answer them. Best wishes.
This was an excellent talk by Dr. Jonathan Schuttel, who made us aware about the fecal microbial transplantation. We have done few cases of fecal microbial transplantation at our unit, few for IBD and 2 cases for recurrent CDA infection. And the results were promising, but every time I asked my technician to perform this procedure, my whole department tend not to perform this procedure because it's a bit untidy. So we need a large scale, national scale study on this role of fecal microbial transplantation in our setup as well. Our next talk is also a recorded lecture by Dr. Ayub Mali, who is consultant gastroenterologist at MH Rawalpindi. And he is going to talk about management of common anorectal disorders.
Bismillah ar-Rahman ar-Rahim. I am Dr. Ayub Ashraf. I am working as a consultant colorectal surgeon at Combined Military Hospital, Rawalpindi. I welcome you all to PSG 2021. And today we will be discussing the management of common anorectal disorders. Unfortunately, this had to be a video lecture, and we couldn't do a face-to-face interaction because of the prevailing COVID situation. But we are where we are. So today I'm going to discuss the management of hemorrhoids, anal fissure, pruritus ani, anal stenosis, and sexually transmitted diseases. So coming on to the hemorrhoids. The hemorrhoids are distended vascular anal cushions. These could either be internal hemorrhoids or external hemorrhoids, depending on whether they originate from above or below the dentate line. The internal hemorrhoids generally cause bleeding, whereas the external hemorrhoids generally are quite painful. The external ones are synonymous with perianal hematomas. They generally do not require aggressive management, and they settle with conservative treatment, leaving a skin tag behind. Of more concern are the internal hemorrhoids, which are classically 3 in number and are located at 4, 7, and 11 o'clock position, which corresponds to the terminal branches of superior rectal artery. Gallagher et al. Classified hemorrhoids into 4 grades. Grade 1 hemorrhoids were those which bled but did not prolapse through the anal orifice. Grade 2 hemorrhoids are a bit advanced. They prolapse on defecation, but then they reduce spontaneously. Grade 3 hemorrhoids are the ones that prolapse during defecation. They come out, but they do not reduce spontaneously, and they have to be pushed back inside. Grade 4 are hemorrhoids which remain constantly prolapsed. This classification is very important as the management of hemorrhoid disease depends on this classification. So this is picturestic representation of hemorrhoids, prolapse hemorrhoids. You can see prolapse at 1 o'clock, 3 o'clock, and 7 o'clock position. So the classical symptoms of hemorrhoids are bleeding, prolapse, discharge, itching, and feeling of a lump. It is noteworthy to mention here that bleeding, that pain is not a feature of hemorrhoid disease. Diagnosis is achieved by history and clinical examination. It is important to exclude malignancy while examining hemorrhoids because colorectal cancer can be confused with hemorrhoid disease. So as I said that the treatment of hemorrhoid disease depends on the grade of hemorrhoids. So grade 1 were those which did not prolapse. They can be managed by dietary modifications, such as improving the bulk in the diet by giving fiber. This can also be given in the form of external fiber like ispagola husk. Phlebotonics are drugs that improve the vascular tone, the venous tone, and stabilize the capillary permeability, thereby increasing the lymphatic drainage. They improve the symptoms of hemorrhoids like pruritus, bleeding, and leakage, but do not resolve pain if at all it is present with hemorrhoids. The most commonly used phlebotonic is Deflon. For first degree hemorrhoids, the classical management is with dietary changes and phlebotonics. Invasive management is generally not considered unless there is no improvement with conservative measures. First degree hemorrhoids can also be managed with rubber band ligation and sclerotherapy, which is injection of a sclerosing agent into the hemorrhoid. Second degree hemorrhoids, for second degree hemorrhoids, the mainstream management is rubber band ligation and injection sclerotherapy. So with rubber band ligation, up to 68% patients do get a 5-year disease-free interval. But there is obviously a risk of secondary hemorrhage. What rubber band ligation does is that it strangulates part of a hemorrhoid, leaving behind an ulcer, which heals with fibrosis, thereby causing contraction and reduction in size of the hemorrhoids. In most patients, rubber band ligation has to be done in 3 sessions, which is normally done up to 2 to 3 months apart. Sclerotherapy is also one of the methods of treatment of second degree hemorrhoids. The most commonly used sclerosing agent is 5% phenol in almond oil. There are certain disadvantages of this procedure, such as an anterior injection into the prostate can cause chemical prostatitis, which is quite a crippling disease. And then inadvertent intravenous injection can lead to embolism, which can also be fatal. Third degree hemorrhoids are generally managed by excisional hemorrhoidectomy, which can be done by open or closed technique. In excisional hemorrhoidectomy, the distended anal cushion is removed altogether. Another method of treatment of third degree hemorrhoid is stapled hemorrhoidopexy. So what happens in stapled hemorrhoidopexy is that the hemorrhoids are not actually removed. They are actually repositioned because a circumferential mucosectomy is carried out above the hemorrhoids, which then heals with fibrosis, and it sort of pushes or takes the hemorrhoids higher up. So it is sort of synonymous with the rectoanal repositioning of hemorrhoids. Another method of treatment of third-degree hemorrhoids is hemorrhoidal artery ligation and or transhemorrhoidal dearteriorization. This is generally combined with rectoanal repositioning. So a Doppler proctoscope is used, and terminal branches of the superior rectal artery, which number to around 6 to 10, they are ligated with this Doppler proctoscope. And the basis of this treatment is that as the arterial inflow is ligated, the anal cushion, which is distended, it reduces in size. For fourth degree hemorrhoids, the treatment generally available is open hemorrhoidectomy. So next, we are coming on to the anal fissure, which is an ulcer in the squamous epithelium of the anal canal. It's most commonly caused by hard feces, and it can be classified as acute or chronic. Basing on the duration of symptoms, acute is generally with less than 6 weeks duration. It could be superficial or deep. Deep ones are those where the internal sphincter fibers are visible. It could be posterior or interior, depending on the location. So this is a picture of a chronic anal fissure. You can clearly see the internal sphincter muscle fibers visible. So the symptom of anal fissure is severe excruciating pain during defecation. Diagnosis is generally achieved by clinical examination. So coming on to the management of anal fissure, the first line management is dietary changes, and dietary changes alone. Increasing liquid in diet, stool softeners, and facilitating regular bowel movement alone results in healing of almost 50% of the cases. It can be combined with topical application of 0.4% GTN ointment, which is applied twice daily for up to 8 weeks. Diltiazem, which is a calcium channel blocker, also provides smooth muscle relaxation and relieves the spasm of the internal sphincter, which sort of helps in the fissure healing. It has got a better side effect profile than glyceryl trinitrate, which causes quite severe headaches. So these ointments, for the use of these ointments, the patients have to be quite compliant, which is not the case with almost 25% of our patient population. Botulinum toxin injection is an alternative for these people. So up to 100 international units of botulinum toxin is injected at 2 points in the intersphincteric plane, which causes paralysis of the internal sphincter. This leads to improvement of symptoms in 2 weeks' time and fissure healing in almost 6 to 8 weeks' time. Botulinum toxin can cause temporary flatus incontinence, which settles as the effect of botulinum toxin wears off. So for resistant cases, there are surgical options like anal dilatation, forefinger dilatation was described previously, but this results in disruption of internal and external anal sphincter and is a cause of loss of continence. Lateral internal sphincterotomy is also a procedure for cases which do not respond to medical treatment, but again, quite a lot of cases come back with incontinence. Fissurectomy is excision of the fissure base, which is carried out in chronic anal fissures, which it can be combined with botulinum toxin injection. Anal advancement flap is another technique whereby the fissure is covered with a VY flap. So perianal itch is quite a frequent symptom, and it could be because of fecal leakage. So a good assessment of patients with pruritus ani is important, as some of the causes of pruritus ani may require an operation to treat them. Some of the causes are listed here. There could be neoplastic causes, infective causes, then other benign aerorectal conditions such as hemorrhoids, fistula, or fissure, or prolapse, they can cause quite intractable pruritus ani. Then there could be some dermatological conditions as well. The management is quite challenging. If there is an underlying pathology, it has to be treated. Good hygiene has to be maintained. There is an itch scratch cycle. So the patients should be instructed not to scratch, as this leads to further injury of the perianal skin and exacerbates pruritus ani. Reducing of flatulence by lowering dietary fiber intake and probiotics. Then stool solidifying agents are used if the stools are very loose. Water should be used for cleaning, and rubbing should be avoided. Antihistamines also have got some role, and there is also role of steroids in some cases. So now coming on to anal stenosis, which is abnormal narrowing of the anal canal with physical obstruction at that level. So we must differentiate it from anal canal spasm, in which it's a functional abnormality and no mechanical obstruction is present. So these are some of the causes of anal stenosis. So the most noteworthy cause is post-surgical, and the operation is hemorrhoidectomy. So anal stenosis presents with constipation, decreased stool caliber, difficulty in voiding, and with the need for excessive straining, tenesmus, and bleeding. So management is treatment of the underlying cause, stool bulking, anal dilatations. Hagar's dilators are used in resistant cases. Lateral internal sphincterotomy is carried out. Cases which do not respond to the above, stricturoplasty with the flap procedures can be done. And in desperate cases where the patient's quality of life is severely compromised, colostomy can be undertaken. So now coming on to the sexually transmitted diseases, the signs and symptoms of sexually transmitted diseases are diarrhea, bleeding, tenesmus, and ulceration. So the STDs can be classified as the ones causing proctitis, causing ulcer formation, and those that present with fistula. So this is a picture representation of anal warts in a previous surgical scar. So here I have given a table where the STDs are classified as viral and bacterial, and their respective symptoms, proctological findings, the laboratory diagnostic criteria, and treatment is given. Mostly it's the medical management and there's almost no surgical role in the management of sexually transmitted diseases. So I thank you all for your patient listening. And if there are any questions, I'm reachable at my email address, which is ayubmallhi@gmail.com. Please feel free to contact, and thank you.
Thank you, Dr. Ayub, for the nice talk. And our next talk is ileus and pseudo-obstruction, what should we do, by Dr. Mehnaz Shafi. Dr. Mehnaz Shafi is a professor of medicine, and she is head of department GI, MD Anderson Cancer Center, Houston.
Assalamu alaikum. Thank you very much for inviting me to give this talk. And I would like to thank the PSG management for having me here. I'm actually from Pindi in Islamabad, and I grew up here, so I have very fond memories, and it's a pleasure to be back here. I actually just reached the city this morning. So the topic I was given is ileus and pseudo-obstruction, what to do. By way of background, I'm a gastroenterologist in a cancer hospital, and we see actually quite a lot of motility problems there. So will I move this from here? So this is Houston, MD Anderson Cancer Center. Ileus is defined as transient cessation of coordinated bowel motility, which prevents effective transit of intestinal contents and tolerance of oral intake. The most common cause of ileus is post-operative, although it is associated with electrolyte abnormalities and various medications, as we'll discuss. If you look at the X-ray on my left, it shows a classical picture of an ileus where you see dilated bowel, both large and small bowel loops, and you cannot see a transition point to suggest a mechanical obstruction. The arrow points towards air in the large bowel. The picture on the right is another example. The picture on the left is an example of an old man in his 80s who presented with severe hypokalemia, and which resulted in this ileus pattern, which was corrected by a conservative measurement and replenishing of electrolytes. On the right, you see another picture, which is classic for ileus, where the dark arrow points to small bowel and the clear arrow to large bowel. Air you can see throughout without any pinched off area. This was in a post-operative patient. So post-operative ileus, as you can imagine, is iatrogenic. It happens because of surgery. There's a transient inhibition of gastrointestinal motility, and it is multifactorial. It involves pharmacological issues such as opioids, anesthetics that are given. It impairs the neural function transiently, and it also has immune-mediated properties. The neural phase is two-phase, so there's an early phase activation where the efferent nerves are affected. This is a short period immediately post-operative. A later phase is inflammatory, which starts 3 to 6 hours after surgery and can last for several days. It also depends on what surgery is being done. Typically, prolonged ileus is seen most in bowel surgeries. This is a schematic of the neurological function that we see, where we have mucosa, submucosa, circular muscles, myenteric plexus, and we have seen this diagram since medical school, where it shows synaptic functions and the role of acetylcholine in exciting and nitrous oxide VIP ATP in relaxation of the bowel. So typically, it's considered ileus if about 5 days have occurred after laparotomy and the patient still does not have adequate bowel sounds. This happens in about 40% of patients in the United States. As you can imagine, after laparoscopic surgery, the recovery from post-op ileus is faster, and it can be seen, if it's seen 3 days out after laparoscopic surgery, it's considered post-op ileus. What surgery does, it impacts the sympathetic system more actively than the parasympathetic and causes delay in motility of the gut. There's of course associated tissue trauma with surgery and release of prostaglandins, nitric oxides, and cytokines. The management of post-op ileus is to first differentiate it from mechanical obstruction. This is key because the management is very different. Typically, a CT scan imaging helps with this. Overwhelmingly, the management is conservative, and most patients do not need more than bowel rest, NG tube placement, and staying NPO. There is need for using neostigmine has been the one agent that's shown to decrease post-op ileus, and it is used in patients who may be not responding to conservative measures. Endoscopic decompression of air through colon decompression has been done, as well as surgery for those who develop complications such as peritonitis or, in extreme cases, perforations because of non-resolving ileus. This is another picture of post-op ileus. I wanted to show that because this patient also has ascites, so it can be confusing and may be suggestive of mechanical obstruction. But if you see the black arrow, it points to the transverse colon, which is dilated, and the clear arrows show the small bowel. On the flanks, you can see fluid, which is also seen on the CT scan. So it's important to differentiate it from other area etiology that may be causing distension. What we know is that minimizing intestinal trauma during surgery is helpful. The kind of anesthesia used also has an impact, so that mid-thoracic epidural anesthesia is associated with less post-op morbidity from ileus. Opioids, minimizing the need for opioids in pain management helps. Other drugs that have been tried include propranolol, which is a beta receptor antagonist, which has not shown much benefit in clinical trials, as well as alpha receptor antagonists, again, not particularly useful. The one agent that has shown benefit is neostigmine, which is an acetylcholine cholinesterase inhibitor, and it causes an increase in release of choline and parasympathetic activity in the gut wall. Prokinetic agents such as metoclopramide and cisapride have not shown benefit and are not recommended. About 10 years ago, alvenopan and methylnaltrexone, which are mu opioid receptor antagonists, were used and have been shown to be beneficial. Some management overlaps with the next topic that I'm going to talk about. So I'll move on to acute pseudocolonic obstruction. This is commonly known as Ogilvie syndrome, and this is dilation of the colon due to an adynamic bowel. Again, there's absence of mechanical obstruction. It tends to be acute onset, and most commonly we see the cecum and the ascending colon being involved. This is not a common condition. It's usually seen in the elderly who also have other comorbidities such as immobility, electrolyte disturbances, polypharmacy, including opioid use. This is an example of acute dilation, and you can see a very dilated colon with no hostra and really effaced bowel. The physical exam is quite remarkable in these patients. They have a tympanic abdomen, distended abdomen, and absence of or minimal bowel sounds. So what are the etiologies of this? It can be post-surgical. It can have other surgical procedures such as a lumbar puncture. Trauma, particularly retroperitoneal trauma, is associated with obstruction, spinal cord injury. As I mentioned earlier, age, also sepsis, neurological disorders, of course, thyroid problems and electrolyte problems. A host of medications can cause this, so important to look at that in the elderly. So particularly of importance is opioids and antidepressants, which can cause this, cardiac ischemia, recent surgery, and again, chronic neurological problems such as MS or even Hirschsprungs. So there's interruption of the autonomic nervous supply to the colon. This results in absence of smooth muscle activity. And in untreated cases, it can cause significant morbidity. It can lead to a toxic megacolon, bowel ischemia, and even perforation. This is the guidelines from gastrointestinal endoscopy from about 10 years ago, where they recommended how should acute colonic distension be managed. So first, you would want to see, is there any sign of ischemia or perforation or cecal volvulus? So somebody with really an acute abdomen, if so, then they need surgery. If they do not have that, then you think, is there mechanical obstruction present? And of course, if there's mechanical obstruction, the management is different. If there's a volvulus or if they may still need surgery. But we are talking here of pseudo obstruction. So if they do not have mechanical obstruction, then we are thinking of pseudo colonic obstruction. And the recommendation is to give conservative management for 24 hours with close monitoring. Conservative management is keeping the patient NPO, giving a nasogastric tube, a rectal tube, avoid incriminating medications, such as opioids wherever possible, calcium channel blockers wherever possible, and to treat reversible causes such as correcting fluids and electrolytes. If there's success, then that's good, and you can consider giving low dose laxative of some sort. If there's not a response, then neostigmine should be considered. And this has been shown consistently to improve acute distension after conservative if has not responded. If there's not been a good response, then colonic decompression should be considered. Colonic decompression is actually very safe, and it has been shown to be helpful. Again, in case of non-response, surgical option remains. The role of endoscopy in the management of patients with known and suspected pseudo-obstruction and colonic obstruction is absolutely present. This is a study where they looked at what are the predictors of response. So they looked at 151 patients who had acute pseudo-obstruction. And in 77%, they found that there was spontaneous resolution of symptoms. They got better with conservative treatment. So what happened to the non-resolvers, those whose obstruction did not resolve? A half of them got neostigmine, and about less than half of those got a colonic decompression. 2 underwent surgery. What they found was that spontaneous resolution was less likely if patients were taking narcotics. And if those who received neostigmine, they had 89% had prompt evacuation. So the take-home message here is neostigmine is a good thing to use if conservative management is not working. And another option remains is colonic decompression, which is also effective. Surgery should be considered when there are peritonitis signs. This is a New England Journal article from 1999, which looked at what was the response to neostigmine versus placebo, and again showed overwhelmingly a positive response to giving this in acute colonic decompression. What about chronic pseudocolonic obstruction? So this is a complex topic, difficult to treat, difficult to diagnose, and it presents as continuous or intermittent symptoms of bowel obstruction in the absence of a fixed luminal lesion. Again, there's intestinal dysfunction. It can present as symptoms of bowel obstruction. It is associated with severe gastrointestinal dysmotility, which may be diffuse and not just limited to the large bowel. It involves neuropathy, myopathy, mesenchymopathy. It is rare, and therefore you have to have a high clinical suspicion to think of that. A lot of cases are seen actually in children, and pediatric cases about 1,400,000 live births. The acquired version is more common in adults, and it can be seen with autonomic system problems such as stroke or encephalitis. It can be seen in diabetics, paraneoplastic syndromes. Radiation can cause it. Smooth muscle problems such as scleroderma, amyloidosis can cause it. So again, it's hard to diagnose. The symptoms are not specific and they overlap with other GI symptoms. Many times this can be confused with gastroparesis, with delayed gastric emptying, with functional constipation, cyclical vomiting, drug toxicity, or endocrine problems. This is a comparison of use of alvinaprin in phase 3 trials to see the efficacy of it. And they looked at patients both whether they had small or large bowel dysfunction to begin with, and gave alvinaprin either 6 milligrams or 12 milligrams. And overwhelmingly, they showed that there was a benefit in use of this in patients. What about methyl naltrexone for the use of and pseudocolonic obstruction? This is only be done in case reports, and it is not a approved indication used sporadically. What about colonic decompression in these patients? And so this was a retrospective study that I liked, where they looked at decompression in patients, and they did colonic decompression in 61 patients, and out of those, about 47, so close to half, had complete resolution of pseudo-obstruction, compared to about 20% of patients who underwent standard medical therapy. So colonic decompression was useful. They did not find any difference in the extent of colonic thickening in these patients, and they found that the 30-day readmission rate was 15% in the colonic decompression versus 26% in the standard medical therapy group. This again points towards efficacy in using colonic decompression. So again, talking about neostigmine, anticholinesterase, the thing to be aware about this is that it can cause side effects. So it should be given where you have telemetry and the patient's being monitored. It can cause bradycardia, asystole, and so patients have to be monitored. In case there's toxicity, this can be reversed with atropine. And I think we covered some of this. I wanted to show this diagram of Ogilvy's, where they did this in 2018. This was published had 48 patients who had Ogilvy's, and they looked at how they responded to neostigmine. And as you can see, most people resolved conservatively, and those who got neostigmine had a positive response. They found that there was a correlation between bowel management between narcotic dose and how difficult the Ogilvy was to manage. So again, the take-home message is narcotics can worsen both acute and chronic pseudo-obstruction. So in summary, the management should first include preventive measures. If you can do limited surgery with thoracic and spinal analgesia, if you can minimize use of opioids, you minimize injury during surgery, that helps. A majority of patients respond to conservative measurements. For those who don't, consider neostigmine or or colonic decompression. There have been cases where PEGs have been used to decompress chronic pseudo-obstruction, and in those who develop peritoneal signs, surgery should be considered. So with that, I'll stop and thank you for your attention.
Thank you, ma'am. And our next talk is by Dr. Martin Freeman. He's a very famous guy in gastroenterology. He's professor of medicine, consultant gastroenterologist, and hepatologist. Director, pancreatobiliary endoscopy, University of Minnesota, USA. And he's going to talk about chronic pancreatitis, role of total pancreatectomy with islet cell autotransplantation. And there is also an announcement from the management that everyone in this area and outside should be wearing the mask, and mask should be covering the nose as well, because it's our social responsibility to save others. Thank you.
Well, hopefully you can hear me. Don't know if I'm live or going to show the, if you want, I can show the presentation by shared screen. Let's, yeah, can you hear me?
Yes, sir, we can hear you.
Okay.
Dr. Freeman, is it okay if we run your presentation, which you have sent, and you can remain on the line for the question answers from the audience? Because we seem to be having some connection problems. We're not hearing you.
Oh, you can't. Okay, can you hear me if I talk live?
Yeah, now we can.
Okay.
We can hear you now.
Okay.
Yeah, I think. Can you see our screen?
Yes. Okay,
so,
well, I'll just, can you hear me if I talk over it?
yes, we can hear you now.
Okay, well then, if you don't mind, I'll just back up a couple of slides. Because
yeah.
So
all
what
right.
the main issue with chronic pancreatitis, so you're hearing me okay now?
Yeah, we're okay now. We're
Great.
good.
So main issue with chronic pancreatitis is pain, and the mechanisms were thought to be originally mostly pancreatic duct obstruction and local, but now we know that there's also a big component of central sensitization and neuropathic pain. So trying to sort those out and treat both of them can be difficult. Treatments have involved alcohol, smoking cessation, pancreatic enzymes, antioxidant vitamins, analgesics, spinal cord stimulators, pain clinic, ERCP, SWAL, and surgery. It's very important to use adjunctive therapies, which is outpatient IV fluids, dietitian consult, and we have all our patients see a registered dietitian. when they're severe, they need enteral nutrition, health psychology, and pain clinics, I think, are very important to manage this disease. Endoscopic therapy includes ERCP, ESWL, and endoscopic ultrasound increasingly to access and drain pancreatic ducts. There's so many aspects of endoscopic therapy now that really are all listed here, but they involve duct decompression and stone extraction by ERCP, EUS guided duct access and therapy, endoscopic pseudocyst drainage, biliary stricture, and to a lesser degree, EUS guided celiac plexus block. What is commonly thought is that stenting pancreatic ducts is the main thing we do. It's actually the least effective thing we do endoscopically, as it's rarely durable. If you're going to do it, turns out larger stents are better than smaller stents. Although in this young patient with stricturing disease from hereditary pancreatitis, even if you're temporarily effective, it's very unlikely that you will resolve the problem even with endless repetitive stenting. The other alternative, though, to try to treat dominant strictures is to place multiple stents instead of a single stent, and that's been shown to improve outcome. Although again, if it's progressive disease, chance of long-term resolution without stents is not very good. The new agent is the fully covered metal stent, which seems promising, but it obstructs side branches and can induce strictures at the upper extent of the stent. So I'm a little concerned that these may be overutilized once they're available. Yeah. What's very important for endoscopic therapy is EUS guided rendezvous, which I'm proud to say was first reported by my colleague, Dr. Mallory, and first done by him 20 years ago. The idea being you pass the wire antegrade through the stomach, through the pancreas into the duodenum, so that, or through the anastomosis, so you can do endoscopic ERCP therapy. But the newest development, which we have just reported with Dr. Hyatt and other colleagues, is transgastric drainage of the pancreas directly. And the variant that we reported is using a tiny 018 wire through a 21 gauge needle, using angioplasty balloons and placing tiny multiple 3 French stents. The idea being small puncture is less risk. If you fail, less risk of leakage and long-term drainage. Now, S-wall is the long-standing mainstay of treating pancreatic duct stones that cannot be removed by ERCP, which is the majority. It certainly works for single large stones by fragmenting the stones and allowing passage. But the future is now, I think, with direct peroral pancreatoscopy. Now that we have 4-way steerable digital pancreatoscopes, at least fairly widely available. I'm not sure how available they are in Pakistan, but what they do is, and I'm sure at major centers this is available, but what they do is allow direct visualization, as you see in this video, with a very high quality image. And this is of a very large pancreatic stone that failed to fragment with ESWL. And under direct vision, you keep applying electrohydraulic lithotripsy over and over again until it's fully fragmented and you have direct feedback. Here you can see that with time, it's totally fragmented. It's very safe. And you can just keep going up the duct with serial stones so that sometimes in a single session, you can clear the entire pancreatic duct of multiple stones, whereas standard techniques fail and ESWL can only treat a single stone. So let's see if I can advance this now. So none of the published trials comparing endoscopic therapy with surgery have used pancreatoscopy with these techniques. There are ongoing studies, or at least planned studies, comparing pancreatoscopy with ESWL, but it's going to be a long time before they're available. And to me, it's a little like comparing map navigation with a GPS. Traditional surgical options have included Pusto and Fry procedure for large duct disease, but for small duct disease, very mixed bag of Whipple, Bager, Fry, total pancreatectomy or Whipple without islet autotransplant, and then distal pancreatectomy. And these are quite morbid operations with very limited effectiveness in small duct disease. So what do we know about conventional surgery? It's effective in well-selected subset of patients. Earlier surgery has better outcome, but it eventually fails in many patients. It's not suitable for diffuse small duct disease. It's not ideal for early onset hereditary progressive disease or patients with comorbidity, and it impairs yield of islet autotransplant if that's to be done. There are two older published prospective randomized trials that both show better results with Pusto than endoscopy, but they included only large duct patients, neither used optimal technique for endotherapy, whereas surgery really hasn't changed in 20, 30 years. They didn't target total duct clearance with endoscopy, and they didn't include marginal candidates for surgery, which in our practice is about 90%. They have something that makes them poor candidates. Now, there's a recent study called the ESCAPE trial from the Netherlands, which is very well done, randomized trial comparing immediate drainage surgery with step-up via ERCP S-wall, but they didn't use pancreatoscopy. And with that, for pancreatic stones, they only got 62% stone clearance, even though this was done by experts. But in the endoscopic step-up group, if they got complete stone group clearance, they had equal results to surgery, which I think we can now achieve with pancreatoscopy. So it's really apples and oranges when you compare traditional surgery with endoscopy. What about TPIAT? Well, it was invented at the University of Minnesota fully 40 years ago. The idea being you remove the entire pancreas to relieve pain, the whole pancreas, not part of it, and then isolate the islets, infuse them into the portal vein, and then they set up shop in the liver and actually function just like they would originally in the pancreas. It does not involve immunosuppression, or using anybody else's organ. And there's really robust data, mostly from our center, but this is prospective quality of life in children undergoing total pancreatectomy out of transplant for hereditary disease. Start out with terrible quality of life in physical and mental component scores. 2 standards of deviation below normal is miserable. And after 2 years, they are at the 50th percentile, which is normal quality of life for a unaffected child. And you can see here newer data showing that both adults and children start out with very poor component mental and physical scores. But in 5 years after follow-up, the children maintain normal quality of life. The adults have markedly improved, but not normal quality of life. And there's very long-term follow-up, including more than 10 years follow-up for 215 patients at the University of Minnesota who were out more than 10 years. They had 85 to 90% pain relief, and at least half of them had sustained islet function, including 20% who were insulin independent. And again, this is their auto transplant, so it's their own islet cells reimplanted. What we really know about this is long-term is thanks to a very large NIH grant led by our Dr. Melina Bellin, and including all of the major US centers doing total pancreatectomy, islet auto transplant. They've already entered over 200 patients into this study. So what I'd like to do is, if I'm not running too long here, show you some individual case presentations that show how we use anatomy, etiology, and disease trajectory to develop logical, personalized management strategies. And I think the major mistake here in guidelines and practice that I see is standard sort of universal knee-jerk recommendations. Here's a 37-year-old professional female with a history of heavy alcohol abuse and intractable pain, frequent hospitalizations, but she's already insulin-dependent diabetic. Failed ERCP outside facility referred to us. Now we do all the fanciest techniques there are to remove pancreatic stones, but even we took one look at this CT that you'll see and said, there is no way. This is massive calcification in the main duct, side branches of the head, body, and tail. And she cannot have a total pancreatectomy with islet auto transplant because she's already diabetic. So this is a patient that we would send directly for Fry procedure. If you I can summarize here if you want, but I have 2 more quick cases and a summary. Another patient that I had the privilege of taking care of 14 years ago and ever since, hereditary pancreatitis, age 7, frequent hospitalizations, miserable, but had multiple small pancreatic stones with no strictures. And with a couple of ERCPs, we were able to clear her duct completely without any residual stricturing disease, which is usually a poor prognostic sign in young onset hereditary disease. And she did fabulously. I have permission from the patient and her family to show you this card. And notice the date. This was 14 years ago. She did terrifically. Actually was able to go through childhood, adolescence with minimal symptoms, just clearing out more stones every few years, and has in fact enrolled in nursing school. But now, as a young adult, she has developed refractory pain with no more strictures or stones, so nothing treatable endoscopically. But now she's going to undergo a total pancreatectomy with islet autotransplant, and the outcome of that is not compromised. Had we done a drainage operation or a resection in childhood, she would have had a poor outcome of this operation, and there would be no other option. So I really believe this is the future. And then just show you one more case from a number of years ago, but this is not an exaggeration. 32-year-old, very active aerobics instructor, recurrent pancreatitis, intractable pain, pancreas divison, had a total of, believe it or not, 84 ERCPs at a major medical center in the United States, and told there was nothing to offer, but her mother found the TPIAT option through internet search. And this is the patient on the left, our coordinator in the center, and patient's mother on the right. And really dramatically good outcome. It's very unusual to get this good an outcome that late in the pain process of 8 to 10 years of chronic pain, but she was very fortunate. And this is, again, no insulin, no diabetes, no pain medicine, just taking pancreatic enzymes. So, and then I just want to finish up by showing you some guidelines, which I must say I don't agree with some of them, and I'll show you why. And again, it harks back to relying on old, out-of-date randomized trials in a population that isn't applicable. So I'll just take you very quickly through these. Just published American College of Gastroenterology guidelines. So they do suggest CT MRCP, but if it's equivocal, secretin MRCP. But they did not cite the only high quality study to actually examine that accuracy of MRCP, which tells me the literature search wasn't very rigorously done. They suggest histological examination as a gold standard, yet they didn't quote the study that used MRCP with a histologic standard. And I do not recommend endoscopic ultrasound biopsy of normal looking pancreases or mildly abnormal, because you will cause more pancreatitis than you have any treatment options for curing. Can be disastrous. Do agree with genetic testing. Obviously, alcohol cessation, smoking cessation. Again, just emphasize that if the blanket recommendation for surgery by traditional methods over endoscopic therapy, I think, is outdated based on old studies with poorly done endoscopic therapy, and does not incorporate total pancreatectomy, islet autotransplant, which they dismissed with a single reference. There's actually 384 references. I showed you three of the high quality prospective quality of life studies. This represents, I believe, bias, institutional bias on the part of the guidelines. So the other thing that's stunning to me is recommending antioxidant therapy when it's very weak evidence and experience doesn't hold up much efficacy, but suggesting that they don't use pancreatic enzyme supplementation, which are harmless, which you can tell if they're going to work in a few weeks or not. And if they work, you continue them. If you don't, stop them. And they also recommend celiac plexus blocks, which are almost universally ineffective beyond a few weeks, if that. And this is a lifetime condition. So I just end with a guideline that I think is actually really spot on, and that is the a JAMA publication from 2019 by 3 noted authors that I think follows a much more logical pathway. So let me end with that. It's basically taking you through the logic that I already presented. So I want to thank you for your time and attention. This is the state bird of Minnesota, the loon. We're a little loony, if you will, sometimes in our treatments of chronic pancreatitis, but hoping to pass on some wisdom that I've gained by spending 20, 30 years treating patients with chronic pancreatitis. Thanks again for your invitation. Apologize to run over. I'll stop there.
Thank you, Dr. Freeman, for such a wonderful talk on role of total pancreatectomy in chronic pancreatitis when everything fails. Obviously, it's a new direction toward the management of chronic pancreatitis. Our last talk of the session is by Dr. Mumtaz Hayat. He is consultant gastroenterologist at UK, and he has special interest in management of colorectal carcinoma, and he is actively involved in the bowel cancer screening at UK. And he is going to talk about colorectal cancer and new developments.
Thank you very much. I'm really sorry I'm a bit late. I was having problem with my internet this morning, and thank you to Pakistan Society of Gastroenterology for giving me this opportunity. So I'm going to share my screen. If you just give me 2. Can you see the screen
yes,
now?
Sir, yes, sir, we can see now.
Brilliant. Thank you very much. So as I said, thank you very much for giving me this opportunity. I'm going to talk about endoscopic full thickness resection of colonic polyps and early colorectal cancer, which is a fairly new technique developed by the German group. And we have adopted that in our trust for the last 2 years or so. And I just wanted to share the experience and show a video also. This is the hospital where I work, which is our Northumbria Specialist Emergency Care Hospital, based in Northumbria. And I'm working there as a consultant gastroenterologist. We all know that colonic polyps are precursors of colon cancer. And I don't need to go into the detail for that. The adenoma carcinoma sequence is well established, and all of us are fully aware of that. There are several ways we deal with these colonic polyps, and the 2 established techniques are, one is endoscopic mucosal dissection, or EMR, standard snare polypectomy, and then ESD, which is endoscopic submucosal dissection. And as I said, these techniques are well established and widely available and widely used in several centers across the UK and the world. Now, EMR and ESD are established procedures for endoscopic resection of large colonic lesions, but both of these techniques have got limitations which make endoscopic full thickness resection a very desirable and alternative procedural option. And the benefits are that endoscopic full thickness resection provides a diagnostic modality. So because you are taking the full thickness resection bite, it provides the integral wall specimen, and you can stage these lesions properly. It also provides a therapeutic option whereby you can resect early cancers, T1 cancers, or even T2 cancers, and avoid a more invasive surgical intervention, resulting in less time in hospital and less pain for the patient. The full thickness dissection device, or the full thickness dissection system, in short, FTDRT system, consists of an applicator cap with a ready-to-use mounted clip and a snare at the tip. It also includes a hand wheel, a thread retrieval, and endoscopic sleeve. And the hand wheel and the thread retrieval is basically based on the varicose banding design. The applicator cap is mounted on the endoscope with the snare running on the outside of the scope, and the sleeve prevents any entrapment of the tissue between the scope and the snare. And by turning the wheel, the clip is released through the thread and through the thread and new release ring. The target tissue is firmly immobilized and then cut by snare. And that's what it looks like. As I said, it's a very simple and a very novel system whereby you can use this on a standard colonoscope. This is the applicator cap. This is the Ovesco clip. This is the biopsy forceps, which is used to trap the or to grasp the polyp or the early cancer. This is the endoscopic sleeve, which is put on the endoscope. And this is the snare, which runs outside the scope, which resects the lesion once the lesion is trapped in this cap, if that makes sense. That's just the endoscopic picture showing that how it works. And when I'll show you the video, it will make a bit more sense in terms of how this kit works. So basically what you do is identify the lesion which is suitable for endoscopic full thickness dissection. You mark the lesion, you load the device onto your colonoscope, you go in, grasp the lesion, and then resect it and leave this Ovesco clip there. And in simple terms, what I tell to my patients is, and other colleagues, is that basically you're perforating the colon, but before perforating the colon, you are closing the perforation with this Ovesco clip and then causing the perforation. Now, I became interested in this technique about 2 years ago, and I went for the training. And soon after that, we found our first case at Northumbria. And it was an 81-year-old gentleman who had atrial fibrillation and was taking rivaroxaban for his atrial fibrillation. He had a colonoscopy for iron deficiency anemia, and he had a colonoscopy by one of our colleagues who found a pedunculated polyp 18 centimeters from the anus, and he resected the polyp, but the resection was incomplete. The histology came back as a tubulovillous adenoma with areas of low and high-grade dysplasia, and appearances would be in keeping with an infiltrating moderately differentiated adenocarcinoma. The tumor was present at the deep resection margin, and therefore the excision was not complete. And that was the initial polypectomy which was performed by our colleague. We did a CT scan and MRI scan, which was clear. We discussed this case in our multidisciplinary team meeting with the colorectal surgeons, and I've been very fortunate to have very cooperative colorectal surgeons on board. The patient was not fit for any sort of invasive surgery. So we had a chat with the patient and explained to the patient that the option we have got is either to leave this alone or to go for major invasive surgery with major morbidity and mortality. Or the third option would be to use this new technique, what we call endoscopic full thickness section. The patient was very keen and was very pleased to have this procedure. So I performed this procedure on 7th of August 2018, which was our first case. We had Dr. Bodger from Southampton, who have already done few cases. So I asked him, and he came down to Northumbria and was my mentor for the first case. And it took me about 2.5 hours to resect this lesion endoscopically. It was done under general anesthetic, but had a successful outcome. It was a moderately differentiated adenocarcinoma PT2 NXMX, which was excised with the clearance of 0.3 millimeters to the deep margin and 1 millimeter to the peripheral margin in the plane of the section. So good outcome for the patient. Since it was our first case, we kept the patient in overnight for observations. There was no complication and the patient was discharged home. We did a sigmoidoscopy, follow-up sigmoidoscopy 3 months down the line to look at the resection site. And that's what it looked like 3 months down the line post-resection. We took some biopsies and the histology appearance is consistent with inflamed reactive large bowel mucosa with no evidence of residual epithelial dysplasia or invasive malignancy. So obviously a good outcome for the patient. Patient has been cancer-free since his resection in 2018, but unfortunately, 3 months ago, sustained a massive stroke and is going through rehab at the present moment. The second case was very similar, was an 83-year-old lady, again with atrial fibrillation under rivaroxaban. She had a flexible sigmoidoscopy which showed a 15 millimeter cancer at the rectosigmoid, and you can see the cancer picture there. And the biopsies showed appearances suspicious of an adenocarcinoma. Again, we did the CT scan, which was clear, discussed in our multidisciplinary colorectal meeting and discussion with the patient, and we opted for endoscopic full thickness resection on this lady. This resection was performed on 8th of November 2018 and took about half an hour. The second case, histology came back as a moderately differentiated adenocarcinoma PT1 SM1. There was vascular invasion. Invasive tumor was 1.6 millimeter from the suture deep margin, and the dysplastic lesion was completely excised. Post-resection, we spoke to the patient, the colorectal surgeon spoke to the patient, and since there was vascular invasion, which is one of the poor prognostic histological features, we gave her the option for surgery, although again, surgery was very high risk in her case, but she elected to go for just wait and watch approach. And again, she has been cancer-free 2 years down the line without any issues. So I looked at my experience at Northumbria of endoscopic full thickness resection from August 2018 to February 2021 in a single center. We looked at the demographic data, technical success, procedure time, specimen size, achievement of the RO resection, and adverse complications. The indications basically were non-lifting polyp and or recurrence of the polyp. There was one case where the polyp high-grade dysplasia was involving the appendix, and obviously conventional endoscopic resection was not possible. So the option was either to go for full thickness resection or for surgical intervention. Then there was a polyp with low-grade, high-grade dysplasia. There was a lot of tumors, T1 cancers, which we resected with this technique in the last 2 years, about 10, and three T2 tumors. The Paris classification is mentioned in this table. And as far as the location is concerned, the lesions were located at several places, including cecum, ascending colon, and in the rectosigmoid and the rectum. The cecal lesions pose quite a challenge because obviously you need to go in with a colonoscope to go and see the lesion, mark the lesion, come out, load the device, and then go in again. And once the device is loaded, in our population, majority of the patients have got quite significant diverticular disease in the left colon, which makes negotiation of that quite difficult with the device loaded on. So as I said, in 2 years, we have done 20 cases. The target lesion was reached with the device loaded on in 100% of the time cases. All of these cases were done under GA. We administer antibiotics as a routine to our patients before the resection. The first patient, which I mentioned, was kept in for 1 night, and then there was another patient which was kept in for observations for 2 nights. But majority of these cases are done as day cases, and they are discharged on the same day. The mean procedural time was about 55 minutes, varying from 25 to 120 minutes. FTDRD insertion to the target lesion took about 6.5 minutes, varying from 1 to 100 minutes, and that was our first case, which I mentioned. And the resection took 20 minutes, varying from 9 to 60 minutes. Majority of these lesions were around sort of 2 to 3 centimeters in size. The target lesion was resected in 95% of the cases, and our technical success was 95%. What about the complications? One patient had minor bleeding from the resection site, which settled with conservative management. No blood transfusion and no intervention was required. 6 patients stayed for 1 day, 1 patient stayed for 2 days, and 13 patients were discharged on the same day. This compared very favorably to the German EFTR's case series, where they reported a complication rate of 9.9%, of which 3.3% were perforations, and 2% of the patients required surgery for procedure-related complications. We did not have a single perforation in our series. In the German series, they reported an 8.8% risk of acute appendicitis following FTR resection of the appendix-based adenoma, with 2 patients managed conservatively with antibiotics and 1 patient needing laparoscopic appendectomy. How does full thickness resection compares with surgery? We know that invasive surgery for colorectal polyps and colorectal cancer carries a morbidity of 20 to 40% and a mortality of 1.6 to 2.6%. So endoscopic full thickness section is the new kid on the block, and it gives us further options of treating these difficult lesions in addition to established techniques of snare polypectomies, EMR, and ESD. I would like to show this video now. Hopefully I've got time for that. Is that all right?
Yes.
Oh, brilliant.
Yes, sir.
Yeah, I'm just loading the video now.
Yes, okay, sir. You can carry on, please.
Okay, thank you. Can you see the video?
Yes, sir.
This is a full thickness endoscopic colonic resection for malignant polyp in a patient's 83-year-old lady who had a flexible endoscopy for PR bleeding, confirmed 15 millimeter size polyp, 15 centimeter from the anal verge, moderate differentiated adenocarcinoma, and opting for full thickness colonic resection. We use the kit of Physico, where the plastic kit mounted on the top of the endoscopy with a special clip and a snare, as shown in this diagram, the forceps pulling the lesion inside the kit. We start with doing endoscopy. Once we identify the lesion, we position it in a favorite situation and position, as you can see, and start marking the lateral margin of the polyp. We start by marking the distal border of the lesion, then proximal, then lateral, as you can see. The aim of that is to include this lateral margin in the resection. This lesion is located at 15 centimeter from the anal verge. Once we're happy that we are marked, then we will introduce the mounted endoscopy with the plastic kits of Physico. As you can see in the kit, there is preloaded clip called OHC. And then there is preloaded snare as well. Once we deploy the clip, then we apply the snare and detach the polyp. Forceps introduced via the endoscopy. The idea is to have a good bite of the lesion and pull it through this plastic end without suction. Sometimes grasp is slipped and you have to re-grasp it again with a good bite of tissue and gently pull the lesion inside the plastic tube. Without applying suction to avoid suck any adjacent bowel or organ. Once we are happy that the whole polyp is included in the plastic tube and we are at the lateral margin of the lesion, we will deploy the clip. Now the lesion is completely inside. We are deploying the clip and then applying the snare and retrieve the polyp with the endoscopy. Once we retrieve the polyp, we'll reintroduce the endoscopy. As you can see, the base, the full thickness with the clip is deployed completely, no bleeding, no thermal injury. This is the lesion is about 15 millimeter in size. And the histology shows that a clear resection margin, patient discharged on second day.
That's brilliant. Thank you.
Thank you, sir.
No, thank you. Thank you very much.
Thank you, Dr. Mumtaz Hayat, for excellent demonstration of endoscopic full thickness resection for tumors or early cancers who have deeper invasion. We are going to have a short question answer session. Audience, if you have any question, please raise the hand and we will deliver the mic. Any question?
I am Dr. Mughis, sir. My question to Dr. Mehnaz that what is the technique of doing endoscopic detorsion in the cases of mechanical obstruction causing intestinal obstruction?
Thank you. So the important thing is to not do extensive dilation, insufflation of air while the decompression is being done. Typically, the patient, of course, is not prepped. It's done in an unprepped colon. You can use a regular colonoscope. It does not have to be a pediatric one. And a lot of times what has been shown to be beneficial is to use water technique rather than air technique to enter the colon. And to use vigorous suction to, you're trying to get not just fluid, but air, gas out. And it's really a very low risk procedure to do. The other point to make is that you do not always have to go to the end of the cecum, but you can suction air continually as you're advancing, and you would like to go up to the right colon.
I'm Dr. Abdul Qadir Khan from Mohammed Medical College, Mirpukhas. My question is from Dr. Ayub Mali. If he's not here, so any senior can give the answer. So the question is about the hemorrhoidal rubber band ligation. He said they do the procedure in 3 settings with 3 months difference. So we cannot do in 2 sessions or in 1 session hemorrhoidal band ligation. Rubber band ligation.
Yes, we are doing hemorrhoidal band ligation for many years, and we tend not to band all the hemorrhoidal stubs in one session. The reason is after the band ligation, patient tend to have edema, and it will be very painful for next 4 to 5 days for the patient to defecate. So it's better to band ligate the larger one, the larger lesion, or if you can do the two stubs in one go, but never ever try to band all of the 3 in one go, because of post procedure edema. It will be very painful for the patient to defecate. Any other question? I have one question from Dr. Mumtaz Hayat. How are you sure that whole of the lesion is inside the cab before applying the full thickness resection, or before you apply the clip? Dr. Mumtaz Hayat?
Yeah, hi. So basically, as I said, what we tend to do is we assess these lesions very carefully before we book them on for the full thickness section. As far as the size of the lesion is concerned, as I've mentioned, there's a limit. The largest lesion which I've resected endoscopically was about 3.5 centimeters. You can go up to 4 centimeters, but then beyond 4 centimeters, it gets really difficult. All of these patients get pre-op staging. Then when they come for the full thickness section, at the time of that, I again have a look at the lesion and mark the lesion with diathermy, the margins of the lesion. And then when we get the lesion into the cap, obviously, that's how you make sure that the whole of the lesion is in the cap before you resect it, looking at those diathermy margins. I mean, it wasn't very clear in that video, but that's one of the most important things, is to mark the lesion pre-resection to make sure that you've got the whole lesion in the cap.
But you see, once you pull the lesion inside the cap, it becomes very difficult because of the hemorrhage to see the those marks endoscopically, because the lesion is very closer to the scope, and you at times get confused whether we should be applying the clip or we should release the polyp and reinsert it.
Exactly. No, I totally agree with that. I think it comes with experience, though. As I said, the first case took me about 1.5 hours to resect that lesion. But once we became a bit more sort of confident, and trained in resecting the lesions, once you do it, it sort of becomes relatively more straightforward. But the important thing is assessment of the lesion and marking of the lesion.
Any other question, Mike?
Can I just make a comment, please, on this from Dr. Menaz? I had a recent case with the Ogilvy syndrome. The patient had it. And to be honest, I found it very challenging doing the colonoscopy. The CT scan showed that the colonic wall was very thin. And when we went in, it was really messy. There was a lot of stools, liquids. And I wasn't entirely satisfied that I was, sucking more in air than pumping in. And then just a practical point, when we decided to put a flatus tube in, we didn't want to put it blindly. And the ones that we have here are designed to be put blindly. So we had to cut an eye from the top end, put a wire through, and put a Seldinger technique and put the flatus tube over it. I'm not sure what your experience has been with that.
You can use neostigmine first and then use the decompression. And I agree, some cases are more challenging than others. We have a decompression tube that you can feed through the biopsy channel and load it over a wire, and then it's a little bit stiff, so you can actually leave it there for fairly proximally. So it varies what you're using. But many times I've used neostigmine first and then done colonic decompression. Again, the challenge also is to see how durable it is, because sometimes, you know, it can revert back, or it can be a very temporary gain and not sustained. So they may need a second dose of neostigmine. There have been cases where if it's, you know, if it requires that, like a you know, surgical maneuver.
Can I ask? I have two questions. First from for Dr. Mumtaz and second for Madam. First, Dr. Mumtaz, I found applying poly loop easier and then resecting the polyp a lot easier, that you can actually see the base and resect the polyp with the snare. It is really difficult, like you demonstrated there. We are unable to see the base, and we cannot see the margins that we can resect and applying that. This is the first. And second for the Madam. Madam, I want you to please tell us, we knew that the role of cecostomy in patients with Ogilvy syndromes, but I haven't read about PEG tube placement or PEG-J in the patients with Ogilvy syndrome. So I want you to elaborate on this.
Okay, thank you. So I think it's more used in chronic pseudocolonic obstruction, where you have dilation which is exceeding 12 centimeters. Of course, you know, a lot of nutritional problems come into play along with, it's not just discomfort or altered bowel habits. So if you will, you're thinking of like a sustained venting option. So they have generally a peg hedge place, so peg to peg, for basically decompression purposes. So you're doing a continuous decompression to alleviate, because you know there's no mechanical obstruction, and this is a chronic situation. So you're putting in a way of venting, if you will, tube in place.
Well, I have tried using by taping an NG tube alongside the pediatric colonoscope and passing it to it for decompression. Hence has very good results for decompression in this case. It's an easy method when you tape a NG tube on your colonoscope using a pediatric one, and then have a suction on that and have a clear outcome. I've used this technique in acute GI bleed also, upper GI bleed, when there's a lot of blood and clot, you don't get a clear view. You can put an NG tube and tape it around upper GI scope, and then suck it out and do a rescope, and then have a better view of doing a definitive procedure, especially if they are bleeding ulcers or any bleeders inside the stomach and duodenum. Thank you.
Yes, thank you. Yeah.
So, Riaz, can I answer?
Yes, sir, you can answer the second question.
Yeah, so regarding smear polypectomy, I mean, as I said before, this technique of endoscopic full thickness dissection is for polyps or cancers, early cancers, T1 and T2 cancers, and polyps which have got high-grade dysplasia. We don't use this technique for standard polyps like tubulovillous adenomas or tubular adenomas with low-grade dysplasia, where we obviously use the snare polypectomy. So this is different from standard snare polypectomy. And as I said before, that the aim of using full thickness dissection is that you get an integral wall specimen and you can grade these lesions, because if you resect early cancer or a polyp with the high-grade dysplasia with standard snare polypectomy, those patients would require further treatment, be it surgical intervention or endoscopic full thickness dissection. So that's the difference.
Thank you, sir. Thank you. Any other question?
I am Dr. Najmus Seher from Gangaram Hospital, Lahore. My question again from Dr. Mumtaz Ziad, sir. You are doing a wonderful job. and it was a very nice elaboration by you. It looks like as if this technique is more of to master the intubation with the cap on. As you said that when the cap is on, it is just like a bending cap. So how long did it take for you to master this technique? And does it fall off or disintegrate during the procedure, this capping device?
So it doesn't, we haven't had any incidents for that. I mean, it's a pretty sturdy apparatus, and we have got assistants who are trained. So far in these 20 cases, the company which makes this kit, we have had their rep in theater with us who helps the nurses to load the device on. So we need to make sure, and I think it's a very important question, we need to make sure that the device is properly loaded on. And once it's loaded and properly assembled, there has not been a single case of device falling off. As far as mastering the technique, I won't say that I'm a master of the technique. I've done 20 cases, and all of them have been successful without any complications, touch wood. But I think there is a learning curve. But I would say that about 10 to 20 cases, about 20 cases, I think after 20 cases, you feel quite comfortable in doing it. So there's no hard and fast rule, but I would have thought so that 20 cases should be enough.
Okay, so with this, sir, thank you very much. And with this, we conclude this session. And to have the concluding remarks, I will request the chairs to please give the concluding remarks.
So thank you very much all for attending. And with this, we will conclude our session. Thank you.
Okay. There are two announcements from the management. Number one, because of prevailing COVID situation, two workshops which are supposed to be there in lunchtime, they have been cancelled. And secondly, this registration batch is mandatory for someone who is going for the lunch and entering the hall. Thank you very much.
सब लोग जो बाहर हैं, आप सब लोग अंदर आ जाएं. We are going to start the session. Good morning, ladies and gentlemen. I am Dr. Salan. I am assistant professor at Pakistan Air Force Hospital. So I am pleased to be the moderator of your session. So to start with this session, I would like to invite the chairperson of this session. I am pleased and honored to have Vice Chancellor Rawalpindi Medical University, Professor Muhammad Umar, Chief of Allied Hospitals Rawalpindi. He is the past president of Pakistan Society of Gastroenterology. His contributions in the field of gastroenterology is commendable. He has built a state-of-art GI liver center where almost 40 basic, advanced, and basic GI procedures are done on daily basis. I would like to invite sir, please, on stage. I would like to invite Professor General Tasawwur to come on stage. He is the Professor of Medicine, Foundation Medical College. Lastly, Professor Najam to please come on stage. Our first speaker is Dr. Shanil Kadir. He is consultant gastroenterologist at Liaquat National Hospital, and he will talk about practical management of benign and malignant biliary stricture. So Dr. Shanil.
Thank you very much. I'm just going to share my screen. Can you all hear me? Hello, can you hear me? Can you hear me, please?
Yes, please, we can listen to you, Dr.
Okay.
Shanil.
Okay. My name is Dr. Shanil Kadir. I'm one of the gastroenterologists at Jharkhand National Hospital. Thank you to the organizing committee of PSG for the kind invitation to talk about practical management of benign and malignant biliary strictures. It's obviously a very big talk, but I will try to cover as much as I can within the next 20 minutes. I have no disclosures. We're just going to talk about causes of benign and malignant biliary strictures. Then we'll go through some diagnostic workups and then talk about individual management of benign and malignant biliary strictures. I just have one slide on indeterminate strictures, which I think is a separate talk in itself. And I'm not going to talk about PSC related stricture because I think that is a purely separate lecture on that. So just to go through some basic stuff, we all know the causes of benign biliary strictures. So they can be iatrogenic, they can be inflammatory, they can be ischemic, infectious, autoimmune, or miscellaneous like portal biliopathy or trauma. Or you can divide them into common or less common causes. So the common causes we see are post-surgical, liver transplant, obviously post-cholecystectomy, inflammatory chronic pancreatitis, and less common things like bile duct ischemia, vasculitis, portal bilopathy, parasitic infections, and tuberculosis. I'm sure all of you are aware of the Strasbourg classification for biliary ductal injuries. So I'm not going to go through it, but I just wanted to highlight for biliary ductal injury, obviously that's a classification used everywhere. With regards to malignant biliary stricture, we are talking mostly about cancers, so cholangiocarcinoma, carcinoma in the head of the pancreas, or ampullary malignancy or duodenal malignancy, gallbladder cancers, lymphomas, or metastatic lymph nodes which cause biliary compression, and intrahepatic metastasis. And again, everybody is aware of Bismuth classification for cholangiocarcinoma. So the diagnosis is usually threefold. So history taking is quite important, and then cross-sectional imaging, and if required, endoscopic procedure. We are all aware of the symptoms of jaundice, pruritus, dark stool, dark urine, pale stools, weight loss, sepsis, and some of these patients do have a history of alcohol abuse. Just a slide about CA19-9, which is usually done quite frequently. So it is a tumor marker. It's useful for pancreatobiliary cancer. However, in pancreatobiliary cancer, sensitivity is 70 to 80%. And in case of biliary tract cancer, the sensitivity is 50 to 80%. The important thing to note is that it can be increased in the presence of cholestasis and cholangitis. So if you're requesting a CA19-9, you need to look at the patient as a whole and not just look at the result of the test. The diagnosis is usually made ultrasound, most commonly used CT scan, then we have MRCP, endoscopic ultrasound, and in centers which have cholangioscopy, so it's one of the tools for diagnosis. Which diagnostic modality is better for detecting sensitivity of obstruction? Obviously, as you can see, ultrasound, CT, and MR are all similar. With regards to specificity for classification as benign and malignant, the CT and MR fare better than ultrasound. However, the length of the stricture or the extent of the stricture is more better appreciated in MRCP and in CT scan. This is just a slide for the trainees who are watching. So biliary stricture on MRCP, this is just a simple way of describing them. In benign, it's usually regular, symmetrical, short segment narrowing, and the wall thickness is less than 1.5 millimeter. Obviously, in malignant, it's irregular, asymmetrical, longer length, and then wall thickness is more than 1.5. What about tissue acquisition? So most of these strictures, we go for ERCP and breast cytology or transpapillary forceps biopsies. As you can see, the sensitivity of both of these tests is not very good, 45 and 48.1% respectively. There was a study which compared transpapillary tissue sampling versus EUS FNA. And obviously US FNA showed a better sensitivity compared to papillary tissue sampling. So what diagnostic workups modalities that we can think about? So ERCP, as we said, brush cytology, sensitivity is not good. Fish method, which is done on the brush cytology that you have taken. So it's not something that you've done during the ERCP. It's what your cytopathologist does later on, and increases the sensitivity from 35% to 62 to 66%. Intraductal fossa biopsies, obviously sensitivity is 60%, and US FNA, as we mentioned, is quite sensitive and specific. The important thing to note here is some centers, especially in US, will take patients off the transplant list if you've done any US FNA of cholangiocarcinoma because there's risk of pancreatic seeding. And in centers who have cholangioscopy, obviously it's best because you're visualizing it and it's got a great sensitivity and specificity. So as I said, FISH is a cytological test which is undertaken on the breast cytology after the specimen has been acquired, and it's not something which you can, which involves any maneuvers taken during the ERCP. And there's another one called DIA, which is another cytological technique which can improve detection and sensitivity of cholangiocarcinoma. So a simple algorithm, patient comes in with jaundice, you get an ultrasound abdomen, you find that they have a distal obstruction, consider CT scan, you find a mass, and you can discuss it in tumor board and MDT and think about surgery or FNA. If there is no mass, then you go on this pathway for FNA and ERCP and cholangioscopy if needed. Obviously, if they have a proximal obstruction, they go for MR or MRCP, and find a hilar mass, then ERCP with a cholangioscopy, and then you go on this pathway. So this is just a simple algorithm for trainees. What about antibiotics? So the Asia Pacific guidelines suggest that antibiotics should be given only in patients with complex hilar stricture, post-liver transplant stricture, and PSC patients. Also, if you anticipate that you're going to have an incomplete drainage, better to give antibiotics, which should cover Enterococci and Pseudomonas. So coming to our topic about benign biliary stricture, the main aim is drainage and long-term ductal patency, which is achieved by ERCP. If for some reason you can't achieve it through ERCP, the other option is either USBD or PTC. However, personal experience is that it's quite unlikely that you have a benign stricture and you can't get the wire through the stricture. It's usually the malignant stricture which are more tighter. And there are long-term studies about safety and efficacy of endoscopic treatment show that endoscopic therapy is quite safe, effective, less invasive, and obviously repeatable. So this is an consensus statement about benign biliary stricture. So ERCP, you get the guide wire, you dilate the stricture if needed, and then you can go for SAMs or multiple plastic stents. If you can't get through, then USBD or PTC. So recommendation for endoscopic treatment, as you can see, apart from PSC where you would want to dilate and try not to put a stent in all the other cases, you can either put a plastic stent or you can put a fully covered metal stent. Apart from IgG4 cholangiopathy, where plastic stent is preferred because once you start patients on steroids, most of these strictures resolve. So the stent is usually for only short term. Now, there's always a debate, plastic stent or metal stent. So there was this study which I'm going to tell you about, which shows that fully covered SAMs are not inferior to plastic stents. And obviously, they have understandably low mean ERCPs with fully covered stents versus plastic stent. And this is a study which was done in 2016. And you can see that the time to stricture resolution in SAMs is quite early compared to the plastic stent. However, if you look at this side of the graph, you can say that in the long term, maybe they are both the same, but initially the time to stricture resolution is quicker in SAMs, which is what you would expect. And regards to adverse events, so these are the total adverse events of plastic stents, multiple plastic stents, and these are for the metal stent, and there's not much of a difference with regards to adverse events between both the groups. The thing which comes out in our practice is what about the cost, because metal stents are most costly compared to plastic stent. There's this study which was done 15 years ago. It's a Korean study involving 100 patients, and basically they found that there was no difference between the cost comparing metal and plastic stent. Although you can say that this was an old study, 2007 maybe. At that time the stents were newer in the market, they were high cost, but we don't know. There have not been more studies like that recently, and certainly we need a study like that in a country like Pakistan to compare cost issues of both the stenting. There's a recent study in 2020 about plastic and metal stenting in hepatocellular carcinoma with obstructive jaundice. And again, it showed that the total direct and indirect cost of plastic stent was quite higher compared to metal stenting. What about multiple plastic stents versus fully covered stents for benign biliary strictures? So multiple, this is a randomized, this is a meta-analysis. So 7 studies, same number of patients in both the groups. Etiology was similar, post-transplant, chronic pancreatitis, post-operative. And in the plastic stent patients, the stent ranged from 2 to 17. And I was surprised that they could get a 17 stents in a biliary duct. And obviously they tried SEMS with a 10 millimeter stent. And the conclusion was that both plastic and metal stent are safe and effective in benign biliary stricture resolution with similar efficacy. However, as expected, SEMS are associated with short duration of treatment and the fewer number of ERCP procedures. So hence the international consensus statement for distal biliary stricture. You go ahead with the CT MR if you find a mass, then try to find out if it is resectable, non-resectable, and then go for surgery or USFNA. If you don't find a mass, go towards EUS and then see whether there's a mass or not, or consider doing an ERCP. What about post-transplant? So post-transplant, mostly plastic stents are used, 70 to 95% resolution. Some people recommend fully covered SEMS, especially in states, and they've shown that there's 81 to 95% resolution in post-transplant strictures. We mostly deal with this section of patients. So the risk factors for an ostomotic stricture after transplant in our population would be advanced donor age, multiple anastomosis, long, cold and warm ischemia time, hepatic artery thrombosis, and duct-to-duct reconstruction. Plastic stents versus metal stent for post-transplant patients. So again, a meta-analysis. What I wanted to highlight here was, see the number of patients they have in all these studies. So there are 4 studies. Latest was 2018, and look at the number of patients. A quite low number of patients. They compared plastic and metal stenting. And obviously, they showed that it had an equal anastomotic biliary stricture resolution and recurrence. And although there was a trend towards a higher recurrence rate in fully covered SEMS, which disappeared when they took the trials out with a shorter stent time, there was no difference overall in adverse event or stent migration rate. So you can use the plastic or metal stent according to that study. There's no difference. Meta-analysis, there's no difference. However, there is some another one study which was done in Brazil, which showed completely different results, and it showed that the plastic stent are first treatment option, and the SEMS were associated with increased risk of pancreatitis and higher recurrence rate. So that's all for the benign biliary stricture. We're just going to go through a few slides on malignant biliary stricture. So the ESGE recommends that in malignant biliary stricture, you should only consider ERCP in patients with cholangitis if they have a severe symptomatic jaundice, or they are having delayed surgery, or they want neoadjuvant chemotherapy before surgery. And if you are going towards the endoscopic placement for a stent, then consider doing SEMS for preoperative biliary drainage of malignant biliary strictures. So things to note for malignant biliary strictures, should we put a single stent, bilateral stent? Is ERCP better or PTBD better? Is plastic stent better or metal stent better? Should we be putting the stent suprapupillary or we should be putting it transpapillary? So we're just going to talk about each of these in the next few slides. So single versus bilateral. So multiple studies, and most of these studies prefer bilateral stenting. So dual metal stent is preferred for palliation for inoperable malignant hilar biliary stricture. Preferably, you would want more than 50% of liver volume should be drained, and this comes from this study by Vian in 2010, I think, which showed that the main factor associated with drainage of effectiveness was a liver volume drained of more than 50%, especially in bismuth-free strictures. And if you're intubating an atrophic sector, which is less than 30%, it was useless, and there was increased risk of cholangitis with that. So their conclusion was drainage of more than 50% was associated with longer median survival. What about ERCP versus PTBD? Most of the studies for PTBD are old studies where when the ERCP or endoscopic therapy was not as good as it is now. And obviously it all showed that PTBD was technically more superior and to endoscopic therapy. However, the recent advances in stent and accessories, the endoscopic palliation is preferred. And this study, which was done in 2016, showed that endoscopic drainage is not inferior to PTBD in the long term. Hence, obviously, we prefer most of endoscopic therapy rather than PTBD. To talk about should we be putting plastic stents or metal stents? So this is, I'm talking about malignant biliary strictures, not the benign strictures. And as it was with the benign biliary strictures, most of the studies show that there is not much of a difference. However, with the SEMS, you have a longer stent patency, lower complication rates, fewer reintervention rates, and survival benefits in selected subgroup of patients. Again, another study which showed SAMs had a longer function time, and although initially it was thought to be more expensive than placement of plastic stent, the total cost after 1 year did not differ significantly. And lastly, most studies show that STEMS is most cost effective than plastic stent in malignant biliary strictures. So as the studies show, SAMS has a high patency in those, especially in those who are likely to survive more than 4 to 6 months. Metal stents are superior to plastic stent in the terms of palliation of the symptoms and survival of patients with hilar obstruction, which is independent of the disease severity, bismuth type, or drainage quality. And SAMS had a higher technical and clinical success rate. What about suprapapillary versus transpapillary? I don't think it matters. There's one study done a while ago which showed there was similar effectiveness and no significant difference in adverse events. What they found was that if it was a plastic stent and you are putting a plastic stent suprapapillary, so over this side you're putting a plastic stent here, the patient had increased risk of cholangitis. However, metal stent, it didn't make a difference. However, the numbers and the were so small that you can't comment on it. What about stent occlusion? We all see these patients with malignant biliary stricture who get stent occluded. So if you have a stent occlusion, which is usually 22 to 50%, then you can think about other measures for it. So the most common reason for stent occlusion is tumor ingrowth, sludge or debris, or tumor extension. So if they have a plastic stent, you can change it to a SAMS. If they have a SAMS, you can put another SAMS inside it, or you can consider doing a balloon sweep and then put a plastic stent in the SAMS. Distal malignant biliary obstruction, if the patient is expected to survive less than 4 months, the suggestion or the evidence is that you could put a plastic biliary stent, or if the patient is an operative candidate and you just need to decompress them. Patients who are expected to survive more than 4 months, SAMs are more cost effective, especially those who are planning to receive neoadjuvant chemotherapy prior to surgical resection. So this is a fully covered SAMS, which obviously you can remove later on. And uncovered SAMS, non-operative patients with poor expected survival, or in patients, who are planning to receive neoadjuvant chemotherapy, but you are not sure whether they would, even after chemotherapy, they would be a surgical candidate. So you can put a uncovered SAMS in those. This is my last slide, and I think I'm already up for the time. So indeterminate biliary strictures. So it's a very busy slide. As I said, it's a talk in itself. So I'm not going to go through it. Just important points. Important points are, look at the location of the biliary stricture, and according to that, you may want to proceed further. Things to look out for are, IgG4 markers, CA19-9. US has a very important role, whether whichever type of stricture it is, and then you can consider ERCP for biliary drainage. So I think that's my talk finished. I think I'm probably just a bit above over time. So thank you very much to everybody for listening to my talk.
Thank you, Dr. Shanil, for telling us in detail regarding the use of latest endoscopic modalities like endoscopic ultrasound, and telling us in detail the use of plastic stent and self-expandable metallic stent in different biliary diseases. Our next speaker is Colonel Rafiuddin, and he's consultant gastroenterologist and hepatologist in MH Hospital, Quetta, and he will talk about management of cystic liver disease.
Assalamu alaikum and good afternoon. I'll be talking about cystic liver diseases. Can we have the first slide on, please? So cystic liver disease is quite a vast topic. I'll try to cover at least the main aspects of all the cystic lesions. Liver cysts are found in about 5% of the population, and they're found incidentally. Most of them are asymptomatic, and they remain asymptomatic throughout the lifespan. But sometimes when they do become bigger and more than 4 or 5 centimeters in size, they can give rise to some certain symptoms. But the symptoms again are usually due to their mass effect, and sometimes they can develop complications like rupture of the cyst, intracystic hemorrhages, and rupture into the peritoneum and biliary channels. So how can we classify liver cysts? There are several ways we can classify liver cysts. One of the ways is to classify them according to their etiopathogenesis. The developmental cysts are simple cyst, Caroli disease, polycystic liver disease, and ciliated foregut duplication cyst. Inflammatory ones are hydatid cyst, amoebic abscess, pyogenic abscess, and intrahepatic pseudocyst. Then there are neoplastic ones, which can be primary or secondary. The primary ones include cystadenoma and cystadenocarcinoma and cystic hepatocellular carcinoma. Then the secondaries can come from anywhere apart from the liver. So the most common sites for the secondary cystic lesions are ovary, pancreas, colon, and neuroendocrine tumors. Sometimes patients can develop cystic lesions after a traumatic episode, and these are either biomas, seromas, or hematomas. As we discussed earlier, most of these cysts are asymptomatic, and they remain asymptomatic for life. Most of them are picked up only on an abdominal imaging procedure, which is being carried out for an otherwise unrelated reason. Because we are using ultrasound and now CT scan more and more frequently. So we are picking these lesions up more frequently as well. How to proceed? So that's the question. When we find a cystic lesion in a given patient liver, we need to decide whether to do something for that particular cyst or just leave it alone. Now we need to have a full clinical picture of that patient, and then we need to assess the cyst imaging characteristics. And these two will then decide whether we need to do an intervention for that cyst or we can just leave it alone. So that the two questions that we need to answer on the imaging is how many cysts are we dealing with? If there are more than 10 cysts, we consider a different set of diagnoses. And if we are dealing with less than 10 cysts, then we consider a different set of diagnoses. Then on imaging, we also need to know whether the cyst has a simple cyst morphology or a complex morphology. A simple cyst morphology means that the cyst is a unilocular fluid-filled anechoic structure with imperceptible walls, and there is posterior acoustic enhancement. Simple cysts do not need any further investigation. Ultrasound is a reliable and cost-effective investigation to confidently diagnose these simple cysts, and we do not need to do any further investigations. However, in case of complex cysts, the complex cyst morphology means that either the walls of the cyst are thick and irregular, there are internal septations, internal solid component, there may be fluid level or calcifications. In these cysts, we need to go further and do further investigations. If these have been found out on an ultrasound examination, we need to do a CT scan or MRI and some lab tests. So this is what a simple cyst would look like on an ultrasound image. You can see this is a totally black anechoic structure without any perceptible walls, and there is posterior acoustic enhancement, and there are no internal echoes. It's coming on to the diagnostic algorithm. When we are dealing with less than 10 cysts in a patient, we need to find out whether the cyst morphology is simple or complex. If the cyst morphology is simple and the patient has a history of trauma, the most likely diagnoses are biloma, seroma, or hematoma. In case that the patient has a history of pancreatitis and developed these cysts, we consider intrahepatic pseudocyst as the diagnosis. And if the cysts are subcapsular in location and are present in the left lobe of liver, the most likely diagnosis is ciliated foregut cyst, although these are very rare. And if none of the above is present, the diagnosis is a simple hepatic cyst. On the other hand, if we have less than 10 cysts in the liver and the cyst morphology is complex, then we need to see if there is any extrahepatic malignancy. If there is an extrahepatic malignancy, the cystic lesion or lesions are most likely metastases from those extrahepatic malignancies. If the patient has a cirrhotic liver and the cysts are enhancing, it is most likely a cystic hepatocellular carcinoma. If the patient belongs to an endemic area and the clinical picture is consistent, the cyst is most likely to be amoebic or hydrated cyst. In case of evidence of clinical infection and sepsis, pyogenic abscesses, and if none of the above is present and the patient is a middle-aged woman, mucinous cystic neoplasm should be ruled out. When we are dealing with more than 10 cysts, we need to see whether the cysts are enhancing on a contrast-enhanced imaging procedure. If they are, the diagnosis is Caroli disease. If they do not enhance and the patient is immunocompromised for some reason, the most likely diagnosis is fungal abscesses. If the cysts are large with or without renal cysts at the same time, the diagnosis is polycystic liver disease. In case of small irregular cysts, these are biliary hematomas. And for periportal distribution of these cysts, peribiliary cysts should be considered. Biliary hematomas and peribiliary cysts, they do not need any further investigation. They're benign conditions and should be left alone. Symptoms when they are due to cystic lesions, they are either due to the mass effect or complications of these cysts. Mass effect means patients can have a feeling of mass in the right hypochondrium or a discomfort in abdomen on the right hand side. Then sometimes they can compress upon to the surrounding biliary channels and can cause obstructive jaundice. Then sometimes they can develop complications like intracystic hemorrhages, in which case the patient will present as an acute abdomen and acute pain with rapid increase in the size of the cystic lesion, and then biliary compression as well. Sometimes they can rupture into the biliary channels and cause cholangitis. Now, I'll briefly discuss the individual cystic lesions as well. Simple cysts, they are found in about 2.5% of the general population, mostly incidentally. They're biliary in origin. They contain clear fluids and they do not communicate with the biliary channels. We've already discussed the symptoms and the complications. We've already seen this picture. This is what a simple cyst would look like on an ultrasound image. And this is how it looks on the CT scan. A hypodense, uniform hypodense lesion without any perceptible walls and without any internal septations. How do we manage simple cysts? If they are asymptomatic, we do not need to do anything, and they're best left alone, and they do not need any follow-up either. They do not have any malignant potential, and they should only be considered for management when they do develop any symptoms. However, when a patient with a cystic liver lesion, simple liver cyst, develops symptoms, we need to confirm that the symptoms are, of course, due to that cystic lesion, because some patients can have symptoms due to other coexisting pathologies like polylithiasis. So it's only the cysts which are more than 4 centimeters in size which can develop symptoms. If the cyst is rapidly increasing in size, then we must rule out mucinous cystic neoplasm as well. So when we do have to intervene, the available options for simple hepatic cysts are needle aspiration. Needle aspiration can be carried out either with or without a sclerosing agent. Without any sclerosing agent, the failure rate is very high and recurrence is the rule. Whereas when we use alcohol or minocycline as a sclerosing agent, it is generally effective and safe as well. Then other options are cystojejunostomy, unroofing with a laparoscopic approach, and marsupialization has also been carried out. Sometimes liver resection has to be performed. Now, which of these options is the best for a given patient? And we do not have any comparative studies to guide us as to which one is the best. So the decision has to be based on local experience and expertise, and as well as the patient and cyst characteristics. Caroli disease is saccular dilatation of large intrahepatic bile ducts. It's an autosomal recessive condition. When associated with hepatic fibrosis, it is called Caroli syndrome. Presentation is usually with recurrent cholangitis, secondary biliary cirrhosis, abscesses, or stone formation. And on the lab, we see that the alkaline phosphatase and direct bilirubin are high. On imaging, we will find multiple intrahepatic cysts of varying sizes. They communicate with the biliary system, and the common bile duct is of normal size. The biliary communication is better shown on CT scan or MRCP or MRI with hepatobiliary contrast, and sometimes ERCP as well. Lesions typically have a central enhancing component, which is called a central dot, which in fact is due to presence of portal radicle. How do we manage? The management is mainly supportive, fat-soluble vitamin supplementation, ursodeoxycholic acid, management of portal hypertension, and when the disease is advanced, we need to treat that with patients may need liver transplantation. Only if the disease is limited to a very small part of the liver, liver resection can also be performed in some of these patients. Polycystic liver disease. It's an autosomal dominant condition. Multiple simple cysts are found in the liver. It may be associated with polycystic kidney disease as well. And it is usually asymptomatic till the disease is fairly advanced. Complications can develop as with any other cysts, like hemorrhage, rupture, or infection. Mucinous cystic neoplasm, previously called cystadenomas, they are rare tumors. They're more commonly seen in women and present with upper abdominal fullness, discomfort, or anorexia, may be asymptomatic. They have a complex cyst morphology on imaging, and the treatment is with surgery. So the choice of treatment is resection. If they are not resected, there is about a 15% potential for malignant transformation. MCN with invasive carcinoma, it occurs in older adults. Many patients may be asymptomatic or have symptoms just as the MCN. They are suspected only on imaging. It is difficult to differentiate them with MCN without invasive carcinoma, and treatment again is surgery. Liver resection is the treatment of choice, and if complete excision is performed, they are curable. Next is echinococcal or hydrated liver cysts. Two organisms, Echinococcus granulosus and Echinococcus multilocularis, are the culprit agents. Pakistan is one of the countries where disease is present. Cystic echinococcosis looks something like that, and alveolar echinococcosis looks something like that. So the disease is, let's go on to the next slide. So disease is acquired by ingesting eggs, which are excreted by the canines, dogs and other canines. Then humans are accidental hosts. The normal life cycle is that the eggs are eaten up by the sheep, goat, or other animals, and they develop hydrated cysts in their organs. And when these organs are eaten up by the canines, they develop adult worms in their intestines, which then shed eggs. They can be frequently asymptomatic until they are fairly large. And when they are large enough, they can give rise to symptoms due to their mass, and sometimes complications as well. The diagnosis of echinococcal cysts is with when we consider that the patient belongs to an endemic area and the clinical picture is consistent. The imaging features favor the diagnosis, and the patient is serologically positive for Echinococcus granulosus. On imaging, echinococcal cysts can have a variable morphology. We are going to discuss that on the coming slides, but it's usually a complex cyst morphology. What are the treatment options for echinococcal cysts? There are percutaneous treatments available, like pair or modified catheterization, surgery, drug therapy, or observation. Now, which one of these to employ? The WHO has given us a classification of these cysts from CE1 to CE5. CE stands for cystic echinococosis. The CE1 and CE3A category, they are unilocular lesions, and they can be treated, if they're less than 5 centimeters in size, they can be treated with albendazole alone. However, when the size of the cyst is more than 5 centimeters, they should be treated with albendazole as well as pair. The CE2 and CE3B category, they have multiple loculations and multiple chambers inside the cystic lesions, and therefore pair alone is not enough to completely cure the disease. So that's why they have to be treated with albendazole as well as modified catheterization or surgery. CE4 and CE5, they are inactive forms of the disease and do not need any treatment. They are best observed and monitored. This is the water lily sign that is the hallmark of a CE3A lesion on ultrasound. And this is how the hydrated cyst would look like in a CE2 category. So multiple daughter cysts inside, filling up the main cavity of the cyst. Alveolar echinococosis is caused by E. multilocularis. It is acquired by ingestion of eggs excreted by foxes, and it presents as alveolar structure with numerous small vesicles. And the vesicles can grow up to the size of 15 to 20 centimeters. If the disease is extensive enough, it can fill up the whole liver and cause liver failure. These patients can have hypergammaglobulinemia, raised IgE levels, and Echinococcus multilocularis antigen is very highly sensitive and specific for the disease. Then on imaging, we can have, again, a variable picture, but multiple cystic lesions, which can sometimes be confused with malignancy, can be seen on imaging modalities. The WHO again has given a classification system for Echinococcus multilocularis disease as well. This is called P&M classification. P, where P stands for the location of cystic lesions inside the liver, N is involvement of neighboring organs, and M is for distant metastatic lesions. And according to the stage of the disease, drug therapies, treatment modalities have also been recommended, but mainly it is to be treated with surgery. And as an adjunct therapy, benzimidazole treatment like albendazole should also be given, and the treatment has to be extended for 2 years. So that's the coming on to the conclusion or summary. Most liver cysts are benign and do not need any intervention. We need to consider further evaluation and intervention. Thank you very much for your patient listening.
Thank you, Colonel Rafi, for explaining different type of liver cyst and their management. Now I would like to invite Dr. Wahab Dogar. He's Program Director, Liver Transplant Program, Government Institute of Medical Science, and he will talk about liver transplant as a management tool in biliary cancer.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Pakistan Society of Gastroenterology. Bismillah ar-Rahman ar-Rahim. Thank you very much, Pakistan Society of Gastroenterology, for inviting me here to present a talk on indications of liver transplant in various hepatobiliary malignancies. This is my hospital, Gambart Institute of Medical Sciences, 500 bedded teaching hospital located in district Khairpur, Miras. So the objectives of this talk would be to define or to Bismillahir Rahmanir Rahim. Thank you very much, Pakistan Society of Gastroenterology, for inviting me here to present a talk on indications of liver transplant in various hepatobiliary malignancies. This is my hospital, Gambart Institute of Medical Sciences, 500 bedded teaching hospital located in district Khairpur, Miras. So the objectives of this talk would be to define or to describe the various indications of liver transplant for various hepatobiliary malignancy. Those includes primary liver tumors like hepatocellular carcinoma, hepatoblastoma, hepatic endothelite hemangioendothelioma, then cholangiocarcinoma, and followed by secondary liver cancer, including colorectal liver metastasis and neuroendocrine tumors. Coming to the hepatocellular carcinoma, in non-cirrhotic hepatocellular carcinoma is a rare phenomena, and in majority of the cases, liver resection is feasible with very good outcome. However, in 80 to 90% of the cases, hepatocellular carcinoma develops in the background of cirrhosis, and in these patients, the liver resection is rarely possible because of various limitations. So liver transplant remains an ideal treatment for HCC in the presence of liver cirrhosis, as it not only removes the liver cancer, but also the underlying oncogenic potential for future development of HCC. So far, the HCC is the most common indication of liver transplantation, and the question arises here. From the audience, I would like to know, is every patient with HCC in the presence of decompensated cirrhosis is a candidate for liver resection? This is a very difficult scenario. The answer would be no. In the initial history of the liver transplantation, liver transplant was offered to various HCC that were not resectable, regardless of their size, numbers, tumor markers, and very poor 5-year survival were achieved. This was the reality. The early outcome of liver transplant, 82% recurrence with 5-year survival less than 5%. So the need to develop some guidelines was realized, and first time in 1996, a criteria was introduced known as Milan criteria, which shows that if you do transplant within certain limitations, then a very good 5-year survival can be achieved. This was the Milan criteria, that single tumor less than 5 centimeter or up to 3 tumors, each having diameter of less than or equal to 3 centimeter. When the transplants were done within this criteria, the 5-year survival of more than 75% was achieved. So within this criteria, very good survival was achieved, but many of the patients who were accepted for transplants, they were deferred once this criteria became universally acceptable. So the need for the expansion of the criteria was realized, and pushing the boundaries was realized. And then in 2007, UCSF developed some expansion of the Milan criteria, where tumor size was increased to 6.5 centimeter, and less than 3 tumors with the largest diameter of the single tumor less than 4.5 centimeter. And with this criteria, although there was some expansion, 5-year survival of more than 75% was achieved, which was as good as Milan criteria. With further development, further criterias were developed. So look at this slide, Milan, UCSF, ASAN criteria, up to 7 criteria. Here, the number of the tumors were increased and size was also increased with very good outcome. You can see here, 5-year survival in all of these criteria was equal or more than 70%. So, in all of these criteria, the one thing which was lacking, the biological behavior of the disease, because all of these criteria, they were based on tumor size and tumor number. However, it is observed that biological behavior of HCC varies among different patients regardless of their size and number. In recent years, conventional morphological parameters have been combined with other surrogate markers of military potential. These includes alpha fetoprotein and DCP. Alpha fetoprotein itself as an independent predictor of recurrence after liver transplantation. A value of more than 1,000 is associated with very high recurrence despite the fact that the tumor is within the size and number, but the more than 1,000 AFP is associated with very high recurrence rate in post-transplant period. Then pre-transplant liver biopsy. As the tumor differentiation can only be achieved, can only be seen on liver biopsy, so the tumor, those who were well differentiated, if they were transplanted, even in the large size and large numbers, they do very well after transplant. So pre-transplant biopsy sometimes has a crucial role to define the transplant criteria. Then PET-CT was also incorporated because the liver biopsy was not possible or not gained popularity in majority of the centers. Then FGD PET scan was introduced. The basic concept of PET scan was that the poor differentiated hepatocellular carcinoma, they lack the glycolytic enzyme pathway, as they lack glucose 6-phosphatase enzyme. So when the tumor is well differentiated, they show a little or minimal uptake of the FGD, and those who were poor differentiated, they show very high uptake of FGD. So the tumor showing high uptake, they are called as PET positive, while showing very low or no uptake, they are known as PET negative. Here we can see the various studies, they comparing the outcome of liver transplants in PET positive and PET negative patients. You can see very well here the overall survival in patient with PET positive and PET negative is significantly different. Here you can see 5-year survival of 21% as compared to 76% when the tumor is PET positive and PET negative respectively. So combining these biological markers with the morphological markers, the tumor of the tumor had led to expand the criteria further without increasing the risk of recurrence. These are the various criteria where the biological markers were added with the morphological markers of the tumor. Here you can see here any tumor number of diameter less than 5 centimeter or any tumor number of diameter less than 3 centimeter. These along with DCP level of less than 300 or AFP level or less than 300, they have achieved 77 and 87% of 5-year survival. So incorporation of the biological marker with the tumor size and number has led to increase the transplant boundaries, which was not studied previously. Here again you can see this slide will demonstrate again the 5-year survival of the various criteria. The first is the Milan criteria, in which tumor size was less than 5 centimeter and tumor number less than 3 centimeter. 5-year survival of 75%. Then this criteria, as we discussed early, was further expanded by UCSF group, and same 5-year survival was achieved. This criteria was further expanded by another group that called 500 criteria, that the tumor number less than 5, size of each tumor less than 5 centimeter, and alpha fetoprotein level of less than 500, that has achieved the similar 5-year outcome. Then another group defined that the number of tumor up to 10 with all having diameter of less than or equal to 5 centimeter, called Kyoto criteria. They achieved the same or rather a little increased 5-year survival. Then much more expanded criteria called Toronto criteria, in which any size, any number, but incorporation of the tumor differentiation on biopsy was incorporated, and very good 5-year survival was achieved. The next indication of liver transplant is hepatoblastoma, which is the most common primary liver malignancy of the children, and liver transplant has a very good outcome in unresectable or borderline resectable diseases. Patients with extrahepatic disease and vascular invasion are still liver transplant candidate, provided they are chemoresponsive or potentially resectable. Long-term disease-free survival of liver transplant in these patients is more than 80%. Then is hepatic endothelioid hemangioendothelemia, is a rare tumor. Transplant is indicated in unresectable patients having diffuse disease pattern and with good 5-year survival. Now coming to the cholangiocarcinoma, which is the second most common malignancy of liver after HCC. It can be intrahepatic or it can be hilar cholangiocarcinoma. The initial experience of liver transplant for cholangiocarcinoma was very disappointing. In 1988, a group from King's College published a paper where they performed 26 transplants for hepatic hilar and intrahepatic cholangiocarcinoma, but the 5-year survival was of this group was less than 10%. So then further protocols were developed by Mayo Clinic to achieve a good outcome in hilar cholangiocarcinoma. These protocols were that they defined the criteria that hilar cholangiocarcinoma should be transplanted within this criteria. That is tumor size less than 3 centimeter, no transperitoneal biopsy, no lymph node involvement, no intra or extrahepatic metastasis. The patient following these criteria were given external beam radiotherapy, then brachytherapy and capecitabine, and then transplant was done. This group of patients achieved very good 5-year survival of 60 to 68%. Role of liver transplant for intrahepatic cholangiocarcinoma is still unclear and so far not recommended. However, good results have been achieved in selected patients with early intrahepatic cholangiocarcinoma, those who were less than 2 centimeter. they had very good outcome and low risk of recurrence over the period of 5 years. Now coming to indication of liver transplant for colorectal mets, the colorectal mets is the colorectal carcinoma third most common malignancy worldwide. 50% patient develop metastasis, and liver is the most commonly involved organ for metastasis. Initial outcome of liver transplant for non-resectable colorectal mets were very poor. SICA-1 study provided encouraging evidence in favor of liver transplant, showing 5-year survival of 56%. Then SICA-3 and TRANSMIT trials are in progress and hopefully will provide best evidence by comparing liver transplants versus alternate treatments for unresectable colorectal metastasis. Results are expected to be published in 2025. However, various positive and negative predictive factors have been identified for colorectal liver metastasis to perform liver transplant. They show early that help to define the early or late recurrence of the disease. Of these, Oslo and Funk's scoring system is in practice right now. Oslo scoring system is from 1 to 4. This is tumor diameter, time from primary surgery, carcinoma embryonic antigen level, and then progression of the disease. Then Fong score same has 0 to 4, 1, 2, 3, 4. Greater the score, the higher the risk of recurrence. These are the positive and negative predictors of liver transplantation for colorectal liver metastasis. Positive predictor includes Oslo score of 0 to 2, metabolic tumor volume less than 17 centimeter cube, Fong score of 0 to 2, time diagnosis to transplant more than 3 years. Then the negative predictors include right-sided primary disease, excessive primary tumor load, progressive disease, positive nodal state, easy fatigability, weight loss, and appetite loss. These are the negative predictors of liver transplantation for colorectal liver metastasis. Now coming to liver transplant for neuroendocrine metastasis, small bowel and pancreas neuroendocrine tumors, they are common sites for liver metastasis. Patient with unresectable neuroendocrine liver mets can be considered for liver transplantation, fulfilling the following criteria, that is the primary tumor removed before transplant, stable disease for at least 6 months, no extrahepatic disease, up to 70% of the liver involvement, well-differentiated neuroendocrine tumor, Chi index of less than 10%, and age of less than 55 years, which is a relative criteria. The patient transplanted within this criteria, they had very good outcome and 5-year patient survival rate of 50 to 70% and 5-year disease survival, disease-free interval of 30% can be achieved in neuroendocrine mets. Now, this is how the liver transplant was developed for various liver malignancies. First in 1996, Milan criteria, then followed by UCSF, then Mayo Group, they introduced criteria for hilar cholangiocarcinoma, then for neuroendocrine mets, then for colorectal mets, and recently in intrahepatic cholangiocarcinoma as well. So in Gumbert, so far 371 transplants have been performed for various indications. Hepatitis B, B, D, and C are the most common indications. And out of 371, 54 patients were transplanted for HCC. All of them, they were within the UCSF criteria, but we incorporated alpha-fetoprotein in all the patients, and we have not transplanted any patient beyond 1000 of AFP value. No recurrence has been observed so far in any of the patient. And last, the take-home message is that the field of liver transplant is evolving rapidly to expand the indications. Biological markers incorporated in various expansion criteria are crucial and they play a very important role. Colorectal and neuroendocrine mets can be cured with liver transplantation. The role of PET-CT is increasing to define the tumor aggressiveness. And the recurrence of HCC is a rare phenomena if performed within some guidelines. Finally, national guidelines should be established to standardized transplant practice in Pakistan. Thank you very much.
Thank you very much, Dr. Wahab Dogar, for a wonderful work you are doing, especially 371 transplant in Pakistan. It's amazing. So this was our last presentation. So now this session is open for questions.
Very good presentation by Dr. Wahab Dogar. My question is from Dr. Wahab Dogar that which criteria do you follow in your center strictly? If not Toronto, what is the reason?
Dr. Wahab, you are there, please?
Yeah, I can hear. I have not mentioned that which criteria we are following. I don't deny from Toronto criteria. I said we are following some criteria, but we are incorporating alpha fetoprotein level. So far, we have not gone beyond UCSF criteria with incorporation of alpha fetoprotein in it. And the second point, which you mentioned about Toronto criteria, the drawback of Toronto criteria is that you need to perform liver biopsy before that. The liver biopsy before transplant in a cirrhotic patients, it's not a very good idea. The reason being, most of the time, multiple tumors, you don't know which tumor is more aggressive. You cannot get the true representative of the tissue. Number two is the risk of bleeding because of liver cirrhosis. And number three is the risk of tumor seedling. So far, the biopsy has not gained popularity. So we are not following that. As I mentioned, the PET-CT should be incorporated in advanced diseases if you want to go for a liver transplant in those patients, particularly very high volume and very high number without vascular invasion or extrahepatic disease.
Can you please give comment, Professor Vice Chancellor Mohammad Umar, regarding this question, please?
My name is Dr. Hafs Mughis from Faistabad. My question to Dr. Abdul Wahab Dogar, that how many patients and what is your 5-year survival for these patients, and have you done patients for extrahepatic malignancies as well?
As I mentioned earlier, so far, we have not performed any transplant for extrahepatic diseases, extrahepatic malignancy, like we are talking about neuroendocrine or colorectal met. We have scheduled one patient for liver transplant for a colorectal mets in the coming week. But so far, we have not performed any transplant for extrahepatic malignancy. All the patients we performed were HCC, or one patient was with hepatic endothelioid hemangioendothelioma. And the second point, you are talking about the long-term follow-up. So far, our program has started just 3 years back. So I have the follow-up of 3 years only. And in these 3 years, as I mentioned earlier, we performed liver transplant in HCC. Our data is 14% of our transplant candidates, they are having HCC. None of them had recurrence so far.
I'm Dr. Zubair Khan from Multan. Congratulations to Dr. Wahab Dogar on excellent talk and excellent work in Gambit. My question is regarding cholangiocarcinoma. What's your results in your center of experience, especially intraductal cholangiocarcinoma invading the liver?
So coming to the cholangiocarcinoma, so far we have not performed any transplant for cholangiocarcinoma. However, we have performed some liver resections, but again, most of the time, the cholangiocarcinoma patients, they comes to us, they are usually resectable, but I would say our number so far for resection of hepatocellular for cholangiocarcinoma is less than 10. It's not very commonly done. Reason being usually late diagnosis. Yes, a late diagnosis mostly.
I'm Professor Dr. Zafar Hayat from Peshawar, Hebrew Medical College. I would just share with you a little experience of neuroendocrine tumor like the carcinoid syndrome. What's your experience or know-how about the octreotide tagged test therapy in these tumors? Because they are very a lot of immunity for octreotide, and it has been found that if you tag the chemotherapeutic agents with octreotide, inject it, and there is a lot of remission. We got 2 patients treated in the United States, and they're still surviving after even 10 years. Thank you.
Again, for neuroendocrine tumor, our center data is very limited. We have not performed liver transplant so far in any of neuroendocrine tumor. The reason, again, most of the time, so far, whatever the patient presented to us with neuroendocrine tumor, they usually have extrahepatic metastasis as well, which is not a good indication for liver transplant. We don't offer any therapy for these patients. We usually refer them to some oncology center so far. So far, we just, if some comes which is not resectable and which is not transplantable, we just refer them to some oncology center.
I have one question from Dr. Wahab Dogar. Dr. Wahab, I need to ask, in patients with colonic cancer and METs, so are you doing transplant for them other than resection, or what's your views regarding?
Yes, a very good question. As I mentioned earlier, currently we have admitted one patient. She is, I could not share the scenario. Initially, I decided to share the scenario. She is 41 years old lady. She was diagnosed with sigmoid colon cancer 2 years back, along with liver metastasis. So her chemotherapy, neoadjuvant chemotherapy was done. Then she had the resection of the primary tumor. And next week, we are planning to do transplant on her. As right now, the disease is confined to the liver only. There is no extrahepatic or primary disease. So yes, in the next week, we are planning to do that. I don't know the long-term results, but yes, clear guidelines are not available. Some trials are going on, and the definitive data will be published in 2025 in SICA-3 and Transmit trial.
My name is Dr. Faisal, and I want to ask you, sir, that as you mentioned that you are excluding patients from liver transplantation who have high alpha-fetoprotein levels of more than 1,000. So, sir, I want to ask that what were the worst prognostic factors associated with the post-transplant survival so that you exclude these patients from transplant?
Yes. So far, we are excluding those patients with high alpha-fetoprotein because the literature shows the high recurrence in those having a high alpha-fetoprotein level. I also mentioned in my talk, the reference was also there. As you know, we are a public sector hospital. We are relying on public sources. So we are following the guidelines or some criteria where the resources should be utilized where they are much more fruitful. This is the only reason that we are having a strict policy regarding tumor size, number, alpha-fetoprotein. as well as the other factors like severe cardiopulmonary issues. So we are offering transplants only where we think the survival benefits, they are very high as compared to poor outcome.
I have one question
And
from.
in those patients where the alpha fetoprotein is very high, we usually offer them transarterial chemoembolization or some sort of downstaging. So far, there were 2 patients in our data where alpha fetoprotein was very high, more than 1,000. We referred them for transarterial chemoembolization. After chemoembolization, their level reduced to around 400, 500. Then we transplanted both of these, and so far they are recurrence free.
Sir, I have one question from you. As a PGR, I would like to know, first of all, it's really appreciable managing 371 patients and having no recurrence. What's the cost of liver transplantation? I mean, what are the charges? Is a PGRV, there are lots of poor patients who come to us. And secondly, is there any relaxation for the poor patients, sir?
Yes. So far, it's a government funded hospital. All the expenses are being borne by the Sindh government, total free of cost. But there are few limitations. There are certain rare tests which right now we are not performing. That patient has to do from other labs, and there are few medications. Sometimes you lack those medicine. So I would say is a transplant is free here, and the maximum expenditures, if somebody wants to know, is around 300,000 so far. In 300,000, most of the things they are managed.
My name is Dr. Sakhavat Abbas, working as assistant professor in King Edward Medical University. First of all, Dr. Wahab Dogar, you are doing very commendable job in this part of the world. And before start of the Gumbert Institute, we have to refer our patients to other countries, including India and China, and that was very costly as well. So you are doing very commendable job. My question is, first question was about the cost of the liver transplant, which you have very well explained. Second is, I have sent a patient to you with the diagnosis of hepatoblastoma. And I want to know how many cases of hepatoblastoma you have performed the liver transplant in your institute. Thank you.
Yes, we do receive 2-3 patients with hepatoblastoma. So far, we have not performed any transplant for hepatoblastoma. 2-3 weeks back, we received a patient which was having very high tumor burden. So we referred him for neoadjuvant chemotherapy. Then definitely we will do a transplant on him. Hello. I cannot hear.
Dr. Dogar, I'm Dr. Sharbat Khan, Professor Dr. Sharbat Khan from Bolan Medical College, Quetta.
Right.
You said that this is Gumbert is a government funded hospital, and all the charges are paid by the government of Sindh. But you signed an MOU with government of Balochistan recently, and you have signed an MOU for 30 lakh for one patient. What is the reason? If this is funded by the government of Sindh, then they should be done free also for the people of Balochistan.
Yes, very good question, Dr. Sharbat Khan. So I will clearly clear this point. As I mentioned already, that there are some few tests, those are not being done here, number one. And number two is a few medicines they need to purchase by the patient. And number three is the patient have to stay out of the hospital. They have to buy some house for 2-3 months. And most importantly, as we are increasing our number rapidly, this year we are planning to do 300 transplants, but there are certain limitations by the government. So now we are trying to dig out the other funding sources. And we recently did a MOU with the Balochistan Benevolent. There is some Balochistan Benevolent Fund. We did MOU with them. The purpose was that we will do transplant on priority to them. And number two, these extra charges will also be borne by the hospital. And number three, yes, medications, and also post-transplant medications and post-transplant labs. They were also done free for them. This was the reason to incorporate this Balochistan government. And one more thing, we are not deferring the other Balochistan patients, those who are not being sent by the Balochistan Benevolent Fund. We are also doing transplant to them, but those who are getting funds, we have some priority list for them, because we are also doing some private transplants as well now. So those who will get the funds, though definitely they will be on priority list, or you can say on a private list as well.
No, what do you think?
Otherwise we have a long waiting list. So far we are booked till August. So if some private patient comes to us, there is a separate arrangement for that. So we can cater them and we can do transplant on a little, you can say, priority base.
No, I said that still 30 lakhs are too much amount. No?
No, it's not 30 lakhs, it's 2.4 million. You have not read that MOU, I think.
No, 2.4 million means 24 lakh.
Yes, yes.
That is still too high cost, no?
It also includes post-transplant follow-up medication for 6 months at least, and post-transplant labs as well.
Thank you, Professor Sharbat. I think you can talk to about this issue of cost later on. So
Yes,
this
sir,
is all.
please. Yes, sir, please. Can you conclude?
Bismillah ar-Rahman ar-Rahim. It is indeed an honor and pleasure to chair this session with legend Professor General Sabar Hussain. And I'm really grateful to the organizer for this invitation. I think we have a wonderful session and very knowledgeable, experienced speakers. If I look back, the first talk was benign versus malignant strictures, their diagnosis and management. I think Dr. Sneel Kader from Karachi has a wonderful talk on that. I think the take-home message was that these strictures must be diagnosed earlier. Once you have malignant strictures and try to manage them quite late, I think the outcomes are always poor. And mostly you need a symptomatic treatment. He alluded that the fully covered stents are better than the plastic stent if there's a long-term survival according to the classification and imaging criteria and liver function test. Otherwise, the plastic stents are better and cost-effective with the short-term survival of 4 to 6 months. So congratulations, Dr. Kader, for this wonderful talk and PSG meeting. My personal opinion is that I'm not sure when the system of screening will be there in Pakistan, so we can detect early malignant stricture. This is the only solution to the problems of malignant stricture all over the world. If I go to the second talk, which was regarding the hepatic cyst, I think the hepatic cyst diagnoses are becoming more popular and more common as long as the images are available. With the better imaging facility, we are diagnosing even incidental hepatic cyst. But we should be very clear that where to intervene. I think the cyst, the speaker mentions, which are complex, more than 5 centimeters. Imaging shows the involvement of the irregular margins. I think they need to refer to the surgeon earlier. The third speaker, the legend in the noble mission of liver transplant in Pakistan. And I must say he's writing history by providing free services to these poor population in a distant area of Sindh. I think he and these services need to be appreciated at PSG level and government levels. I think out of his 41 cases which he done for the liver transplant for hepatocellular carcinoma, and if I rightly understood Dr. Wahab, it was 3-year survival with no recurrence. I appreciate possibly these patients were screened very well. That the experience from our center is usually patient recur within 1 to 2 years. And we see advanced patient of hepatocellular carcinoma according to BCLC and Hong Kong stage. So I think the take-home message for the juniors is the early screening. If you want to avoid liver transplant in hepatocellular carcinoma, please do screen your patient with ultrasound and CT scan according to the guidelines, and then only you can deal with these problems. I'm happy that the center is making a good sort of records regarding the no recurrence, but I still think that these patients we see may need adjuvant therapy. I'm sure he has not done any case of cholangiocarcinoma. I think the next in line is the expertise to deal with the cholangiocarcinoma. The intervention gastroenterologist will agree with me that we day in and day out see obstructed jaundice, and that turn out to be malignant strictures and cholangiocarcinoma. So I think we need expertise to deal with these strictures also. And unfortunately, these strictures are more common with the young patient. With this, I'm once again grateful to the organizers. I'm also thankful to the participants, the media team, and speaker once again for this wonderful session. May I request Professor General Savar, the mentor of the mentors, just few concluding remarks. Thank you very much indeed.
I'd just like to thank the speakers for their wonderful talks and educating us on these very important subjects. Thank you very much.
Thank you very much.
Thank you very much. It's lunch time now. There is an announcement. So the next session will start by 2:20. Thank you.
Next scientific session is very important. We are dealing with the corona pandemic. So to start with this session, first I would like to call Professor Sharbat Khan. He's a professor of medicine and gastroenterology at Bolan Medical College, to come and take the chair of the chairman. I would also request Dr. Huma Qureshi, ex-chairperson, Medical Research Council, Pakistan, and she had a lot of research on her credit regarding the hepatitis survey of Pakistan, and she is also doing some work in the hepatitis E vaccination. So, ladies and gentlemen, as you know, for the last 1 year, the COVID pandemic had affected whole of the world, and we as medical professionals has been affected in the double edge. On one side, we are facing this COVID problem, and the other hand, COVID is affecting the bodies of our patients. So we will start with a lecture from Professor Wasim Jafri. He is my mentor and professor of many of the professors, the fatherly figure for all of gastroenterologists, and he will be talking about the COVID-19 and liver diseases.
Sir, you can start your sharing your screen, sir.
Thank you very much. I'm most obliged and honored to have been asked to give a talk from the platform of Pakistan Society of Gastroenterology and GI Endoscopy which is currently held in Islamabad under this tumultuous times of COVID pandemic affecting the entire world. The topic that I selected for myself is related to the current pandemic, COVID-19 and the liver. I have nothing to disclose from my disclosures related to this talk. And let's start with certain general considerations and then build on that to know what exactly goes wrong with the liver if it does with the COVID infection. So COVID-19, as we know, it belongs to the SARS-CoV-2. This is a positive sense single-stranded RNA virus, and it belongs to the genus beta coronavirus, and which includes SARS and MERS. The genome is about 79% similar to SARS and 50% to MERS. It binds to ACE2 receptor via receptor binding domain on the spike protein and spreads predominantly by respiratory droplets. And here we see, which all universe is now familiar with these spikes. And certainly this is an electron microscopy, and the viral particle is in alveolar type 2 cells. Of course, it's an emerging infectious disease. We know a lot about it, but still we are students when we come to COVID-19 because almost every single day we are learning something new about it. Presented mainly as viral pneumonia, the respiratory bone illness, and easily spreads from person to person. It has got an insidious and treacherous onset. Asymptomatic infected people can spread the disease. There is a high degree of morbidity and mortality. The seasonal influenza has got a mortality of 0.1%, whereas the COVID-19 goes between 1 and 3, and of course, with comorbidities such as the elderly population with heart disease, lung disease, diabetes, obesity, and liver disease, this 1 to 3% will go beyond 10%, beyond 20%. We all know that the disease severity increases with the age. So as we get older and older, we know that we have got more of critical illness, which certainly in the age bracket 30s and 40s is not all that commonly seen. Again, with the same result, the proportion of deaths in different age groups, as we climb the ladders and become more and more old, there is more mortality related to this infection. What happens, what brings on all this morbidity and mortality, especially with the diseased patients? There are respiratory complications, the lungs become really solidified, the ARDS phenomena is almost 100%. There is cardiovascular injury, and of course, sepsis is a known entity for lots and lots of reasons when it comes to the diseased patients. Hypoxic encephalopathy, acidosis, alkalosis, hyperkalemia, shock, all these things are not rare in patients who are managed in the ICU setting. Of course, there is shock resulting from many factors, acute kidney injury, the liver injury. It's not only 9%, it goes beyond that in cohort of patients who have got, other morbidities related to liver ailment and the DIC. We have become very, very familiar with the cytokine release syndrome in this infection. And of course, we know there is elevated levels of cytokines in patients experiencing cytokine storm. The main one involved are the TNF alpha, interferon gamma, and we know that most of the management currently relates to dealing with the elevated cytokines for those seriously sick patients. 81% mild status, 14% severe, and 5% critical illness. It all depends where you are studying this population and what sort of patients you are getting in your profile. So this is not a universal experience as from Zhenyao But yes, I think more or less one can take the figure down to 60% or make it 91%, depending on where you are working and what cohort you are seeing. Liver involvement in ICU patients is a universal entity. All patients ICU care and no ICU care, and we see that the p-values were significant. What happens to those who could not make it? We see massive portal vein dilatation, CD438 staining, decorating endothelium of dilated and proliferating portal veins. Sclerotic portal vein wall, look at that. And abnormal CD34 staining in sinusoids. So all this results in major liver catastrophic findings for those patients who could not make it and are deceased. So these are autopsy studies. Diffuse thrombotic phenomena in liver intraparenchymal vessels, the sinusoidal thrombosis, extensive hemorrhagic necrosis with sinusoidal thrombosis. Look at that. Subtotal thrombosis of an enormously dilated portal vein. This is portal vein, and see the dilatation and of course thrombosis, portal vein, subtotal recent thrombosis. So what we have coined the term as viral sepsis in this kind of multi-organ dysfunction: pneumonia, respiratory failure, acute respiratory distress syndrome, metabolic acidosis, and internal environment disorders, acute liver injury, acute cardiac injury, and acute kidney problems. So we did not want to lag behind. The Asian Pacific Association for the Study of the Liver developed a COVID-19 task force in February, March last year. We were supposed to produce guidelines immediately for our hepatologists, internists, everybody who were involved with liver patients, and I was luckily part of this task force. So we produced this guidelines as early as May 2020. So from this spectrum of liver injury in COVID-19, abnormal LFTs in COVID-19, frequency and patterns of liver injury. And one can see the abnormal bilirubin from non-severe to severe. It just goes on. And of course, the drug treatment also brings in more morbidity for the liver. Studies that specifically looked for liver injury in COVID-19, and we saw this definition of liver injury: hepatocellular, ductular, and mixed, both hepatocellular and ductular, with or without NAFLD. And I'll come to it. NAFLD produces quite a bit of morbidity, and certainly, you know, when it comes to critically ill patients, it has a role to play as well. So enzyme profile gets altered with the transaminases, the ALK-phos, the GGT, both ALK-phos and GGT, and the total bilirubin. Higher odds for severe COVID-19. After adjustment for age, sex, epidemiological history, liver comorbidities, and initial symptoms, the odds ratio in severe COVID-19, the hepatocyte type of injury, 3.19, and the mixed type odds ratio, 11.22. And we should not really forget DILI and COVID-19, drug-induced liver injury. These patients are on experimental medicines. They are also on all kinds of herbal medicines and everything else that we can think about, the antibiotic cover and whatnot. So antipyretics, antivirals, antibiotics, antifungal, they're all commonly used. Fatty liver can sensitize liver to hepatotoxicants, such as the acetoaminophene, and they have a problem there. Link may exist between COVID-19 and liver steatosis. Recent post-mortem study, as I've already shown you the slides, found microvesicular liver steatosis and thrombosis, producing in more and more morbidity. So patients with spectrum of liver disease who already have one or the other liver problem. So that's the outline. Are CLD patients more susceptible to COVID-19? Do they have severe COVID-19 if infected? Outcome of CLD and cirrhosis after COVID-19, and care of uninfected CLD during COVID-19 time. So let's really take care of all these things. So once again, immediately after those guidelines, we set up a group called the APCOLIS study, and that is a partial COVID-19 liver injury spectrum study. And being part of it, we in fact, put in a lot of data of whatever we could get at that time. And the conclusions from it, SARS-CoV-2 infection causes significant liver injury in CLD patients, decompensating 1/5, 20% of cirrhotics, and worsening the clinical status of already decompensated. The CLD patients with diabetes and obesity are more vulnerable and should be closely monitored. Why is this all happening? Are liver disease patients at high risk? Gut liver have second highest COVID-19 virus, the enterocytes from the gut and the cholangiocytes in the liver. And not known was initially what happens to those who have HBV or HCV. These are universal phenomena. We needed to address that. Advanced cirrhosis, HCC, autoimmune hepatitis, and post-transplant susceptible as are immunocompromised, and the data really has evolved and is evolving to address all that. From the HBV CLD, and the data came initially, of course, everything was reported from China. We know that with previous HBV, without previous HBV, look at the p-values, significant. Total severe disease, so total bilirubin and death. So there were more deaths when we see with previously HBV infection and without HBV infections. So HBV definitely had a negative role in CLD patients. Undiagnosed MAFLD and diabetes more susceptible. IS2 expression has been shown to increase in liver damage. Higher uptake of COVID-19. MAFLD patients may have enhanced risk. Why? Effect of NAFLD on COVID-19 course. So this is the pattern of liver injury, and we know that patients with 37.6% with or without 62.2%. Severity, mild 2.5%, moderate 83.2%, severe 13.9%. So that's how the MAFLD has a negative impact. And the pattern was again the same with transaminases, ALK, FOS, and mixed. Effect of NAFLD on COVID-19 patients at the admission, hospitalization, and discharge. And we all see that liver dysfunction is still present when they were discharged from the hospital. By multivariate analysis, independent risk factors for severe progressive COVID-19. And the variables are very well known now. Age beyond 60, males, BMI, comorbidities. Look at NAFLD. It has got a negative impact as an independent risk factors for severe progressive disease. And we should not really, why? There is a higher risk of disease progression, abnormal LFTs, and longer viral shedding in NAFLD patients, as demonstrated by these p-values significantly compared with COVID-19 patients without NAFLD, and those with NAFLD had higher risk of disease progression, 6.6% versus 44.7%, and longer viral shedding. Higher likelihood of abnormal liver function from admission to discharge from 70 versus 11.31%. Longer viral shedding from 17.5 days versus 4.4 days. So NAFLD or MAFLD have got a negative impact when it comes to liver disease and COVID-19 together. Why NAFLD can lead to progressive COVID-19? The liver has the largest number of macrophages, the Kupffer cells. With NAFLD, there is a heightened pro-inflammatory cytokines, the TNF-alpha, impaired innate immunity with increase of pro-inflammatory M1 macrophages. So this is resulting in progression of COVID-19. Are HCC patients at high risk for severe disease if infected with COVID-19? In general, we do not have a lot of data of HCC, but from what we know about the cancer patients, patients without cancer and with cancer, hazard ratio 3.56, patients with cancer were observed to have a higher risk of severe events. Patients with cancer deteriorated more rapidly than those without cancer. Median time to severe events 13 days versus 43 days. And of course, the hazard ratio is significant after adjusting for age. So the proposal is continue monitoring on and off therapy for HCC, continue surveillance in those at risk for HCC, close to schedule, delay of 2 months may be reasonable, but you are taking risk there and one has to be conscious of this fact. Discuss risks and benefits of delaying surveillance. Postponing of elective surgery, TACE, RT, or immunotherapy for uninfected stable HCC be considered. There is not a significant level of evidence there. Patients on TKI to continue. Ongoing immunotherapy schedules to 4 to 6 weeks from 2 weeks may be considered. Again, we do not have the classical data about it, and it's a level C recommendation. So let's come to the reality of cirrhosis already there due to multiple etiologies and outcome. So patients with cirrhosis, death 40%, invasive ventilation 16, intensive care 23. Chronic liver disease without cirrhosis, intensive care 30, invasive 27, but the death from 40 is 12%. There is an international registry, and we are all contributing and on regular basis to get more and more data on COVID, SARS-CoV-2 infection in patients with pre-existing chronic liver disease and cirrhosis. And one can have, you know, the p-values, as you can see from all what we know about the child, Pew, etc. And briefly, let me introduce that case fatality rate and decompensation. So as we go from just the CLD, chronic liver disease, to CPA, Child's Pew A class, B class, and C, we know that there is a significant case fatality going on to above 70% with child C. And decompensation from CPA to B, and with COV infection, we can see that there is more chances of decompensating, almost 50%. What about the liver transplant recipient and the infection? So with SARS and MERS, this was a rare entity. There is some data evolving. There are 3 patient recipients died of severe COVID-19. All were male, older than 65, receiving antihypertensive drugs, overweight, BMI more than 28, hyperlipidemic, diabetes, immunosuppressive regimen had been gradually tapered off with very low tough concentrations. So yes, these may be some of the factors, but certainly, you know, all of us sitting in Islamabad, myself and others who have looked after these patients for years and continue to do the same in this thing, we are very lucky to report that there is not, you know, very high risk of mortality if we look after these patients as good as we were doing before. So post-liver transplant and COVID-19, immunosuppression may prolong viral shedding in post-transplant patients with COVID-19. Reducing the dosage or stopping immunosuppression may precipitate acute rejection, so we have to keep that in mind. So post-liver transplant, do not reduce, if they do not have COVID-19, do not reduce immunosuppression. With the positive COVID-19 PCR, reduce high-dose prednisone, but maintain sufficient to avoid adrenal insufficiency. Consider reducing MFF and CNI dosages, especially in the setting of lymphopenia, fever, or worsening pneumonia. Again, the specialist concerned has to decide on the spot. So COVID-19 and diseases requiring immunosuppression. Patients on immunosuppressant, there's a whole list of IBD patients, asthmas, and of course, patients who have got other ailments. So without COVID-19, same dose immunosuppression. With positivity, one has to really take into consideration several factors with transplant and other. So initiate immunosuppressive therapy in patients with liver disease, with or without COVID-19 who have strong indications for treatment like autoimmune hepatitis and graft rejection. In patients with COVID-19, use caution in initiating immunosuppressive treatment, where benefit might be outweighed by risk, alcohol-associated hepatitis. What about the cholestatic liver diseases, the PBC and the PSC, as multiply, because we already know that there is the cholangiocytes have the receptors for this thing, and are they more susceptible? Yes, they are. Continue the URSO treatment or the new treatment that one may have, but no new investigational drug should be started in this current time. Let's start with the other aspect, the DILI aspect of the COVID-19. SARS-CoV-2 life cycle and the drug targets. And we know that there are lots of things are happening with the entry inhibitors, fusion inhibitors, endocytosis inhibitors, protease inhibitors, and the well-known remdesivir as the RNA polymerase inhibitors, and of course the IL-6 inhibitor, the tocilizumab. So all these are in experimental stages, but remdesivir and tocilizumab are currently used quite a bit, as and when anybody has got them, they are using it for patients to reduce morbidity and mortality. So safety and drug-drug interactions of COVID-19 patients has to be borne in mind with severe interactions with CNIs when the AST and ALT climbs above 5 times the upper limit of normal, and one has to see that tocilizumab can also get into that problem, and sarilumab and others. How would COVID change hepatology practice? Currently, deferred care is something that was, introduced last year, but lots of negatives happened as a result of varicose screening, which was postponed, or HCC screening. I think we are coming to terms with lots of data that is available that we should really get into that care of providing care. And if we are deferring care, then we should have very strong reasons for that and to modify and tailor-made according to the patient that you have just seen. Teleconsultation is still going on and certainly has improved from its initial hiccups. From whatever I've told you this afternoon, chronic HBV, NAFLD, and cirrhosis, possible risk factors for severe COVID-19 and a bad outcome. Stable chronic hepatitis C, not at risk, and that's basically coming in pretty strongly. But I have put a question mark because lots and lots of data is not available. But those patients that I've seen and you have seen last year from hepatitis C, I think they were offered treatment, and I can certainly say that they have done good. Patients with liver cirrhosis, HCC on immunosuppressant, the autoimmune hepatitis or post-liver transplant might be more susceptible to COVID-19 infection because of their systemic immunocompromised status. So that should be borne in mind, although the results coming across the globe are not tragic, but certainly one can look into it from individual cases and look at the best possible management that we can give to this cohort of our patients. So in conclusion, ladies and gentlemen, COVID-19 has emerged as a pandemic with catastrophic negative impact on health and economic resources across the world. The disease is still spreading like a wildfire. The only successful story comes from China due to the strict prolonged lockdown, which the rest of the world finds very, very difficult to continue. There is still no satisfactory treatment. Remdesivir is only approved FDA drug, which is not available to most of the world. However, the generic brand may be available soon. Effective vaccine programs have enormous contributions to limit the spread of the disease. It needs to be implemented globally without discriminations. With global efforts, we should be able to overcome the negative impacts of this pandemic. So I would end my talk by this great note: do the best you can until you know better. Then when you know better, do better. Thank you very much for listening to my talk. Thank you.
Thank you very much, Professor Jaffrey, for this excellent talk about the effect of COVID on the liver diseases. So ladies and gentlemen, as Professor Dr. Joffrey has said, that in the last 1 year, there was a lot of data coming about this COVID. And in the start, there was a lot of confusion, but with every coming day, we were getting much better knowledge. And then the effects of this COVID on the different parts of the body has come where we are now much better knowledgeable than the last 1 year. So the next talk will be about the effect of COVID and on the pancreas. And this will be delivered by Dr. Waqar Ahmed, who is a consultant gastroenterologist at the North Manchester General Hospital, England.
Acute pancreatitis, as you all know, there are several etiological factors involved in causing acute pancreatitis. The most common causes for acute pancreatitis are gallstone and heavy alcohol consumption. Depending on where you are, in US, alcohol is the commonest cause, whereas in UK, gallstones are the commonest causes. However, in 10 to 20% of cases, an etiological factor cannot be identified. In addition, a number of infectious agents, including viruses, parasites, and bacteria, are known to infect the pancreas. Viral pancreatitis has been extensively described in literature to be most commonly caused by mumps, Coxsackie B virus, and hepatitis A viruses. One of the interesting mnemonics that we used here for etiological factors of acute pancreatitis is I get smashed. And as you can see from the cartoon, it pretty much covers most of the causative factors like idiopathic, gallstones, ethanol, trauma, steroids, mumps, malignancy, autoimmune causes, scorpion stings, hypertriglyceridemia or hypercalcemia. Interestingly, in England, in the common language, getting smashed or getting hammered means getting drunk out of your senses. So it's a well thought out mnemonic. As you all know, we have all been afflicted by COVID-19, which has spread like wildfire from China. It has caused a worldwide pandemic since December of 2019. Although it is a respiratory pathogen, however, there have been extra pulmonary effects as well. The virus have multi-organ tropism, has been shown to affect a host of other organs beyond the lungs, including the pancreas. Interestingly, most of the management of acute pancreatitis is supportive care. However, it would be interesting to note whether the treatments that are used for COVID-19, such as steroid, also mitigate COVID-19 acute pancreatitis. The other question to ask is COVID-19 a cofactor for acute pancreatitis caused by alcohol or ERCP? We all wait further information and data from an active area of research. We all know coronavirus is a severe infectious disease. It's caused by the severe acute respiratory syndrome coronavirus 2, or what's known as SARS-CoV-2. It has led to increased mortality worldwide. Most of the reports have been published citing that GI symptoms are common in patients with COVID-19. The pathophysiology of pancreatic injury. COVID-19 normally uses angiotensin converting enzyme 2, also known as ACE2, as a receptor, which is very similar mechanism of action to SARS-CoV-1. The lung injury is caused by attachment of the virus to ACE2 receptor on the lung type 2 alveolar cells. Once the spike protein attaches to the alveolar cells, it leads to a cytokine storm, which results in alveolar flooding and denudation of the lining epithelium, hampering oxygen exchange and manifesting clinically as ARDS. The ACE2 receptor expression is not only present in the lungs, but it is also in abundance in other tissues extrapulmonary, especially esophageal epithelial cells, absorptive enterocytes of the ileum and colon. It is found in the cardiovascular and renal tissues, the pancreas. Interestingly, according to the study by Liu, messenger RNA levels of ACE2 were found to be higher in pancreas than the lungs. This would certainly explain the multi-organ tropism of the virus. ACE2 expression is noted both in the exocrine pancreatic glands as well as on the islets. Similar to the mechanism of action in the lungs, the spike protein S engages ACE2 as the entry receptor for the virus. Additionally, the cell entry is facilitated by priming of the S protein by the transmembrane protease serine 2, also known as TMPRSS2, and some other proteases. A combined expression of both ACE2 and TMPRSS2 is needed for the successful virus entry into the cell. Binding of the virus to ACE2 receptor mediates pancreatic injury, dysregulated immune response, and cytokine burst have been seen in severe COVID-19 infection with higher levels of interleukin-6 found to be associated with worse prognosis. Reflecting on all that, acute pancreatitis in COVID-19 patients could occur due to the direct cytopathic effect of the COVID-19 virus replication, indirectly by harmful immune response induced by the virus, which is also the cytokine storm. And as a result of given to patients with COVID-19, we'll discuss that in a short while. As we come across more and more cases, our understanding of the clinical manifestation of COVID-19 continues to improve. As we all know, acute pancreatitis is a fairly common gastrointestinal emergency. It is one of the commonest cause for acute hospitalization, especially in the gastroenterology department. The coronavirus disease, as we mentioned earlier, has been rampant since its onset in December of 2019, and so far has affected 119 million people and caused over 2.6 million deaths worldwide. This is in spite of the fact that the Western countries, including US, UK, and most of the European countries, have some of the best medical care facilities, but they have been pretty much helpless in the face of COVID-19 pandemic. There are case reports describing patients with COVID-19 and acute pancreatitis without a clear etiology for the acute pancreatitis. That means whether we should discuss whether COVID-19 is considered as a new cause of acute pancreatitis, or it's a consequence of some of the other factors, including treatment and some of the immune responses secondary to the COVID-19 infection. This question is not very easy to answer. To establish an etiological link between COVID-19 and pancreatitis cannot be easily explained. Cox postulates, as it's not a straightforward correlation. We do come across lots of patients with COVID-19 as a confirmed infection, and acute pancreatitis might be an infrequent complication of the viral infection. To establish a correlation between COVID-19 infection and increased risk for development of acute pancreatitis, we have applied the Bradford-Hill causality criteria framework to critically appraise the link between COVID-19 and acute pancreatitis. This criteria makes up the following headings, and we take up the various criteria like plausibility, coherence, specificity, biological gradient, experimental evidence, the strength of evidence, temporality or the timing, analogy, and consistency. The virus can be easily isolated in stools. Pancreatic ductal, acinar, and islet cells also express ACE2 receptors. So it is plausible to conclude that infection and its various consequences can be observed in pancreatic tissue as well. And the possible the COVID-19 virus is able to cause diffuse severe endotheliitis of the submucosal blood vessels in several anatomical sites. This is typically seen in the lung tissue, and these changes in turn can cause diffuse microischemic disease. Similar ischemic damage can occur in pancreas. Viral causes of acute pancreatitis are well described. However, interestingly, the predecessors of COVID-19, SARS-CoV virus, which was detected in beginning of the 21st century in 2003, it has been isolated from pancreatic tissues from autopsies, but it was not associated with acute pancreatitis or its complications. Now, going on to the strength of evidence, strong associations are obviously more likely to be causal than weak association with a condition. Acute pancreatitis seems to be a very infrequent complication of COVID-19. If COVID-19 is associated with acute pancreatitis, an increase in otherwise idiopathic acute pancreatitis incidence would be reported in patients in pandemics. Furthermore, looking at a retrospective cohort study analyzing nearly 12,000 hospitalized patients with COVID-19 from 12 hospitals in the USA, only 32 cases of acute pancreatitis were seen, yielding a point prevalence of 0.27%, 69% of them idiopathic. This was from Inamdar in New York. From a Spanish study looking at nearly 63,000 patients in the accident emergency department or emergency rooms in Spanish hospitals, they reported a frequency of acute pancreatitis of 0.07%. Although the etiology was not analyzed in this study, COVID-19 was associated with a reduced risk of acute pancreatitis. An increase in the incidence of acute pancreatitis during the COVID-19 pandemic has not been firmly demonstrated. Cases of otherwise idiopathic acute pancreatitis in patients with COVID-19 were first observed and published in China, and then throughout the rest of the world. There have been several case reports and retrospective cohort studies. However, it has been difficult to make any form of conclusion that there's a strong association or link between COVID-19 infection and pancreatitis. Coming to the criteria of specificity, as we all know, acute pancreatitis is not specifically caused by COVID-19 infection. It is a common disease with many causes, as we saw at the beginning of the presentation. The etiology remains unknown in spite of intensive investigation in 15 to 25% of cases. And retrospective cohort studies and case control studies have detected a higher proportion of idiopathic acute pancreatitis among patients with COVID-19 infections. A multi-center international study, the COVID-PAN, which compared 149 patients with acute pancreatitis and COVID-19 and 1,600 patients with COVID-19 negative acute pancreatitis, showed a rate of idiopathic acute pancreatitis of 24% versus 14%. That is more, there was more frequency of acute pancreatitis in the COVID-19 positive patients. Regarding specificity, unfortunately, all factors and biases cannot be totally ruled out in the case setting. Some studies defined acute pancreatitis only by an increase in blood levels of pancreatic enzymes. However, patients with COVID-19 can present with several complications that are associated with elevated blood levels of amylase and lipase. Those conditions like acidosis, renal failure, and diabetes. Again, because of the virulent nature of the virus, patients who are diagnosed with COVID-19 and acute pancreatitis might not have undergone full evaluation for cause of the pancreatitis, including ERCP or EUS or MRI, because they are considered infectious, and one tends to avoid investigating those patients unnecessarily. Therefore, the incidence of idiopathic acute pancreatitis probably could be higher because of this very reason. And as a result of this, the opportunity to diagnose conditions like microlithiasis, which is a frequent cause of initial idiopathic acute pancreatitis, as well as cystic lesions of the pancreas, might therefore be missed. Therefore, this would create the proportion of cases of unknown origin attributed to COVID-19 itself. The next criteria to evaluate is temporality or the timing of infection. The timing of COVID-19 infection and the development of acute pancreatitis is heterogeneous. Some patients develop COVID-19 symptoms and abdominal pain at the beginning of the infection. Others have acute pancreatitis days after COVID-19 is diagnosed. Biological gradient or the viral load. It has not been consistently reported that acute pancreatitis is more frequent in patients with a higher viral load or severity of disease, which is linked to. The COVID-PAN study have suggested that acute pancreatitis in patients with COVID-19 is more frequently severe than in patients who are negative of COVID-19, but this aspect would be expected owing to the aggressive behavior of COVID-19 infection itself, which is associated with multi-organ failure regardless of the presence of acute pancreatitis. In a study from New York, Inamdar and colleagues reviewed charts from over 48,000 patients who were hospitalized between March and June of 2020. While pancreatitis is usually diagnosed on the basis of 2 out of 3 criteria, in their particular study, they used all 3 criteria to be present before pancreatitis was diagnosed. And these are characteristic upper abdominal pain upon admission, lipase greater than 3 times the upper limit of normal, and evidence of pancreatitis on cross-sectional imaging like CT scan. Out of the over 48,000 patients studied, nearly 12,000 tested positive for COVID-19, which was about 25%. Across the entire population, only 189 patients had pancreatitis, which is 0.39%. And of these, 32 also had COVID-19, which is so the incidence of COVID-19 patients with pancreatitis was very low. Elevated pancreatic enzymes or acute pancreatitis can also be secondary to cytokine storm and multi-organ dysfunction leading to pancreatic injury rather than the direct cytopathic effect of the virus. Mechanical ventilation or shock can also lead to hypoxic pancreatic damage. This corroborates evidence that pancreatic injury was higher among patients with more severe disease. Very important, the role of medication. Multiple drugs such as corticosteroids and NSAIDs used during management of COVID-19 can precipitate pancreatitis in their own right. Many of the case series and reports highlighted above had antecedent history of these drugs, which may account for the rise of pancreatic enzymes, rather than it being the effect of the virus. Tocilizumab and lopinavir-ritonavir combination can lead to hypertriglyceridemia. This in turn can result in pancreatitis as well. Morrison et al. Have reported one case of tocilizumab-induced hypertriglyceridemia related acute pancreatitis. Likewise, baricitinib, a drug used for COVID-19 treatment, can lead to acute pancreatitis as well, which has been reported. Therefore, drugs are an important contributor for pancreatic injury among COVID-19 patients. Interestingly, high doses of steroids used for conditions like autoimmune pancreatitis can theoretically pose a high risk for poor outcomes in COVID-19 infection. However, on the other hand, favorable outcome of COVID-19 infection in the case of autoimmune pancreatitis treated with steroids has also been reported. And in fact, nowadays, dexamethasone is given earlier during the course of COVID-19 infection. I would conclude my talk here, and I would like to thank you all for your attention. Many thanks, and have a lovely conference.
Thank you very much, Dr. Waqar, for a comprehensive review of the COVID on the pancreas. Ladies and gentlemen, with the coming frequent waves of the COVID-19, it looks we have to live with this virus for quite a time. While we were struggling with this COVID-19, a breaking news came from our friendly neighbor country, China, about the development of a much needed vaccine about another virus, which is hepatitis E virus. Hepatitis E virus is a cause of significant morbidity and mortality in our part of the world, and a vaccine for hepatitis E is needed for last many years. So our next presentations will be about the vaccine of the hepatitis E. But before the next presentation, I would request our chairperson, Dr. Huma Qureshi, we want to say some words about the hepatitis C vaccine.
Thank you very much. Actually, I just thought that before we go to the hepatitis E vaccine, the audience should have some update on the endemicity of hepatitis E in Pakistan. The hepatitis E, which is a waterborne disease, is endemic in Pakistan, and the exposure rate is about 34% in the general population. Generally, there is no mortality, but there's a high mortality of about 30 to 40% in pregnant women or their unborn children. So it's the pregnant women and their unborn children who become victim to this hepatitis E infection. So the vaccine for hepatitis E is important for the reproductive age women, and this vaccination needs to come through the gynecologist and the obstetricians and not through the gastroenterologist, because the population that needs it is the reproductive age women. So I have a good news to share with you that this hepatitis E vaccine has been produced by China and is now available in Pakistan. So let's hear from them, because I think we have been really pushing them very hard to produce a vaccine for Pakistan. And I'm very happy to let you know that this has been produced. Over to.
Thank you very much,
Thank
Dr.
you.
Huma,
Thank you.
for your very relevant point. So our next presentation will be about the indication and the efficacy of hepatitis E vaccine. And this will be delivered by Professor Ting Wu. And she is working in the National Institute of Diagnostic and the Vaccine Development in Infectious Diseases in China.
So good afternoon. So first, I would thank the organizer for inviting me to give this talk. Today, I will introduce the indication and the efficacy of hepatitis E vaccine. So hepatitis E virus is a leading cause of acute viral hepatitis globally, especially in South Asia. Almost more than half of the acute viral hepatitis were caused by hepatitis E virus infection. And based on the information from WHO website, so every year there are an estimated 20 million HIV infections worldwide, leading to an estimated 3.3 million symptomatic cases of hepatitis E and 44,000 hepatitis E related deaths. And there were several global outbreaks of hepatitis E. And the first largest hepatitis E outbreaks occurred in New Delhi, India, in the 1950s last century. So there was 97,000 cases. And the largest hepatitis E outbreaks occurred in China, Xinjiang, with about 119,000 cases, 700 deaths, and among which 414 were pregnant women. And even in recent 10 years, there were several large outbreaks of hepatitis E. And the most recent one occurred in Namibia, and with more than 10,000 cases, and 66 people died. So here's research from Pakistan. There were 65 acute viral hepatitis patients. Among them, more than 80% were caused by HIV infection, and the circulating genotype is genotype 1. And here is a report of hepatitis E outbreaks in Pakistan. There were around 300 patients diagnosed with hepatitis E every day in Lahore and in Punjab. And the exact total cases in this outbreak were not reported. And here is a research from Dr. Said Hamid. And they concluded the superinfection with HIV in patients with underlying chronic liver disease can cause severe hepatic decompensation, leading to increased morbidity and mortality. And the large majority of adult CLD patients were vulnerable to infection with HIV because the seroprevalence in this cohort were, the seroprevalence of HIV IgG in this cohort were 17.5%, and the seroprevalence of HAV IgG were 97% in this whole cohort. So most of them were vulnerable to HIV infection, but they have already been protected against hepatitis A. So they are ideal candidates for HCV vaccine. Here is a systemic review of the mortality of symptomatic HIV infected pregnant women. So most of the studies came from South Asia, from India, Pakistan, and Nepal. So the maternal case fatality rates were 26% in symptomatic hepatitis E infected pregnant women from endemic countries. So all these studies were hospital-based. So the case fatality rates were in those who have symptoms, clinical symptoms after HIV infection in pregnant women. HIV is a non-membrane RNA virus, 7.2 kilobytes in length, and contains 3 open reading frames. OF2 encodes a single structure protein of 660 amino acid containing neutralizing epitopes and is the target for vaccines. So the HCV vaccine, Hecalim, is a recombinant vaccine, contains 239 amino acids of ORF2 derived from HCV genotype 1 absorbed to aluminum adjuvant. And those who can infect human beings include 4 genotypes of HCV genotype 1, 2, 3, and 4. Genotype 1 and 2 are human specific, can only infect human being, while genotypes 3 and 4 are zoonotic, with swine as the main natural host. And the 4 genotypes of HEV have only one serotype. So the hepatitis C vaccine were based on genotype 1, HEV1. However, theoretically, it can protect against all the 4 genotypes infection. So the hepatitis E vaccine were licensed in China in 2011 and launched in 2012 in China. Now it has launched in Pakistan. Before the licensure of this vaccine in China, we have conducted several clinical trials. The phase 1 include 44 participants, and mainly to test the safety of this vaccine. And phase 2A enrolled 155 participants and to test the safety, and it's a dose escalation study. And finally, the 30 microgram dose was selected for further evaluation. And the phase 2B were designed to test the immunogenicity and safety of different dose regimen. So finally, the 3 doses regimen of 0, 1, and 6 months were selected for further evaluation. And the phase 3 was a very large efficacy study and enrolled 112,000 participants. And the phase 3 lasted for 1 and adverse reactions. And for the rest of the participants, they were trained they were trained to report any adverse events they occurred. So, and we have set up a very sensitive surveillance system for the acute hepatitis cases. And the surveillance system covered all the 11 townships of the site, around 412,000 people. And totally there were 205 sentinels, including 162 community clinic centers and 11 hospitals, township hospitals, and 30 private clinics, and 2 central hospitals in the city. And all the doctors there were trained. And any participants who, or any people who have fatigue or loss of appetite for more than 3 days, they will donate some serum. And the collected serum will be sent to CDC, to CDC, the Center for Disease Control and Prevention, to the CDC lab and tested for the ALT. If they have abnormal ALT, and this is before the 2009, and after that, because too many samples, so only those who have ALT higher than 2.5 upper limit of normal, and the sample will be typed for hepatitis, will be tested for hepatitis A, hepatitis B, hepatitis C, and HEV IgM indicators. So if the sample has positive HEV IG, if the sample has positive HEV IgM, and the people will be followed up in 2 to 3 weeks, and they will be followed up every 2 to 6 weeks, and the serial serum sample will be tested for ALT, and until the ALT became normal, returned to normal. So all the serial serum samples of the suspected hepatitis cases will be sent to Xiamen University lab, and for detection of HEV IgM, HEV IgG, and quantitatively test for IgG level, and also tested for HEV RNA. So based on all this data, we can sensitively capture all the hepatitis E cases. So the case definition for hepatitis E is ALT higher than 2.5 upper limit of normal. And at the same time, he should have at least 2 of the below 3 indicators, and positive HEV IgM, and 4 times increase of HEV IgG level, and positive HEV RNA. So if he has 2 of the 3 indicators, and also he has ALT higher than 2.5 upper limit of normal, he can be diagnosed as a hepatitis E cases. And also we use the fingerprint system for identity confirmation. So all the participants will be collected the fingerprint, and both the fingerprint and his image during the first visit of phase 3 at the enrollment. So after that, at each visit, and after and we also at each follow-up visit, we will confirm the identity of these participants through his or her fingerprint or image. And we also use this system to confirm the identity of the hepatitis E cases. So the phase 3, in the phase 3, we followed the participants for 19 months. 19 months. The per protocol set include those who received 3 doses of vaccine, and the case counting starts from month 7, one month after the full vaccination. Now from month 7 to month 19, there were 15 cases in the placebo group and no cases in the vaccine group. So the efficacy is 100%. And start from 1.5 months. That is 2 weeks after the first 2 doses. The first 2 doses is at 0 and 1 month. So 1.5 months is 2 weeks after the first 2 doses until before the third dose. Before the third dose, from 1.5 months to month 5, there were 5 cases in the placebo group and no case in the vaccine group. So the efficacy for 2 doses vaccination is also 100%. And we have followed up all the participants for 10 years. Data of the follow-up until 4.5 years has been published in New England Journal of Medicine in 2015. So in a per protocol set, those who received 3 doses of the vaccine from month 7 to month 54, there were 45 cases in the control group and 3 cases in the vaccine group. So the efficacy is 93.3%. And in the intention to treat those who received at least 1 dose of the vaccine from month 0 to month 54, there were 53 cases in the control group and 7 cases in the vaccine group. So the vaccine efficacy is 86.8%. So the vaccine efficacy remained highly for at least 4.5 years. And we have finished the sample test for the 7.5 years, and the data has not published yet. 7.5 years after the first vaccination in a per protocol set from month 7 to month 97%. And in a modified intention to treat cohort from T, the efficacy is 87.2%. So the vaccine efficacy still remained very high. The efficacy during year 4.5 to 7.5 did not decline. And we have also quality control of our hepatitis surveillance system in the first year, second year, and third year of the surveillance of the phase 3 clinical trial. So in each year, those suspected cases, those fatigue and anorexia for more than 3 days, the number of cases is similar during the 3 years. And the ratio of patients with abnormal ALT is also similar. The first year, 13%, second year, 16%, and third year, 17%. And the follow-up rate for those who have abnormal ALT higher than 2.5 upper limit of normal. It's 84%, and 86% is also very stable. So the number of confirmed hepatitis cases in the 3 years, and also the hepatitis cases in the out-control cohort. Out-control cohort means those live covered by the surveillance system, but they did not participate our phase 3 clinical trial. They did not receive the vaccine. Also, the number is stable, 64, 54, and 58. So our hepatitis surveillance system worked stable and reliable. And for the safety, my colleague, Dr. James Shi, will talk more about the safety of this vaccine. The vaccine is well tolerated, and the serious adverse events occurred at similar rates between the vaccine group and the placebo group. And then no SAE was considered to be related to vaccination. So in summary, the recombinant HEV vaccine heckling is safe and highly efficacious. It could substantially decrease the infection risk and effectively protect the vaccine receivers against hepatitis E. The vaccine is suitable for a susceptible population aged 16 years and above. It's recommended for individuals at high risk of hepatitis E virus infection, such as those engaged in animal husbandry or catering, students, military officers and soldiers, women of childbearing age, travelers to endemic areas, and so on. So that's all. Thank you for your attention.
Thank you, Professor Chengho. And the next presentation will be by the Professor James Waiko, and he will be talking about the effectiveness of the hepatitis E virus vaccine.
Person, and I'm very happy to have the opportunity to present our result. And I want to thank the Pakistan Society of Gastroenterology and Endoscopy for the invitation. Of course, we would like much happier if we were, if I'm in presentation in Islamabad, but because of that, the COVID-19, we have to go through this via the video. Here, my presentation, the title is Post-Marketing Study and Pharmacovigilance Program for Hepatitis E Vaccine, the HICOLING. HICOLING should give you a little bit overview. The HICOLING is right now so worldwide the only vaccine against hepatitis E, and it went through a lot of earlier pre-marketing studies, as Dr. Wu presented, and the product was launched in China in 2012. And ever since we had launched the product, we have working very hard to register in Pakistan. And the Drug Regulatory Authority of Pakistan came by in 2018 and inspected our facility, and we finally got approved market in Pakistan in the later part of the 2020. And the product itself is a genotype 1 sequence, and yet you may know this is only one serotype of this hepatitis E. And it's expressed protein from E. coli, and it's for the target population of 16 years and older. And it's in pre-filled syringe, has a shelf life of 36 months. And the schedule is 016 months. It is an alum preservative. And we should talk a little bit about the safety. One of the important safety is the pharmacovigilance program. We have this pharmacovigilance system set up along with the human papillomavirus and with the help of PATH, because it is a very tedious and very important program. And it's, as part of the WHO pre-qualification program, we set up this program and they inspect it and they can accept it. So along with our human papillomavirus vaccine. And even before the PV system set up, we already have a post-marketing monitoring system, which is required by the Chinese drug authority as well. And we have to do the routinely report to the provincial regulators. And here I'll show you some of the safety profile on the HICOLING. Even before the pre-marketing study of the study, we went through the investigational studies, phase 1, 2, 3. We monitoring their adverse reaction actively, and as well as the post-marketing study, and the number is around 30 to 40%. And after the marketing, we are also collecting individual case report, which is the number here is seems to relatively low, but this is because it's actually passively collected by reporting to our system, and either because the cultural background, nobody really actively reports things, or even when we look into Merck, they have also conducted a similar type of monitoring system with their HPV vaccine, and they got is 259 cases reported per million, and we had 89 cases per 600,000. It's about the same number, because in Dr. Wu's study, the talk, she mentioned a very important issue of the HPV infection among pregnant women. So I think the safety of this vaccine among pregnant women is a major concern. And here I present to you some of the minimum data we have collected. Here shows you in a phase 3 study of the Dr. Wu's presentation of the large number study, and the pregnancy was a exclusion criteria. So we can only collect some of the data or inadvertently immunize a person. And here show you that either the vaccinated or in the single placebo control, they happen to be very close. And then we also including the non-pregnant control of the same age women. And that they also, all these shows either in between the studies or in between the study versus the pregnant one versus the pregnant one within the study, or the pregnant without a non-pregnant woman, their adverse reaction is all identical and very low. And in this study, we also monitoring the baby, and none of the baby had any abnormalities. And so I think the result have been published in the Hepatology. And here again, we show you another study, also in the phase 3 study, but this is this was actually conducted in the human papilloma vaccine study. In this study, the control group, the vaccinated group is the human papilloma virus vaccine. The control group is actually hepatitis E vaccine, is this particular Hippolyte. As you can see, these have a much larger number of pregnancy events, but their adverse reaction basically is identical. So it's not any worse than the other case controls, but the other way around. So we also, after we marketing these product, when we are exporting to Pakistan, we also have a data safety exchange agreement between Ferozens and our company, and this is required. And yet at the same time, these are following specifically monitoring information, and any major results we have to report. Any issues that we report on based on the seriousness of the event. Any major event we should be reporting within 24 hours, and otherwise they have their own schedule. They're here also show you the informed tables. Now, next I shall share with you more on the clinical studies now. The post-marketing study, we has quite a few number of studies, and some of the studies were required, suggested, recommended by the WHO SAGE group, because at that time we were trying to go through the pre-qualification. I should talk a little bit more about pre-qualification later. And so some of the studies were suggested by them, and some of the studies were initiated at the Innovax. And the major ones I should tell you more details. Here, just a list of all the studies we had intended or finished, are ongoing, such as the ongoing one will be like evaluating the value of it, or the more important ones we need to study is among pregnant women, but we also need to expand the age. I'll tell you details now. And here, this slides just show you, as I said, leading slide to show you the long-term efficacy that was one of the required, and that's reported by Dr. Wu earlier, and it's very effective even after a long time, close to 9 years now. And the study here, we also want to present to you individually 4 studies. First one I want to tell you is the age expanding because earlier the study originally was designed up to 65, and later we conducted an open label control study and to expand the year beyond 65. And we primarily monitoring the safety and immune response. Here to show you that their immune response, either among the using the same number of controls population or the same age, or the different of the 16 to 65 age versus above 65. In the red line or the above 65, as you can see, either they have previously they have or doesn't have the pre-exposure. All the response after immunization, basically all have very high response, and they 100% of the recipient seroconverted, and even though some of them the older age has a less higher titers, but their the titer itself are far above the minimum required protection. And so the conclusion of that would be the immunogenic and well tolerated in the population above 65 years old. And the next study I want to share with you is the simultaneously immunization of pickling and hepatitis B vaccine. And this was conducted in as just a open label study. And basically, again, we're looking at the safety as well as immunity. Again, the simultaneously immunization, we find out the safety, there's no difference, and the immunogenicity basically is, again, is the same. The third study will be another open label study, and that this one was looking into the safety among the person who has been infected with hepatitis E. And this study was done among hepatitis C population of 235 patients, and we using the then hepatitis B infected 200 similar numbers, and we use a standard immunization schedule, 0-1-6 months. And when we look at the personal safety among these two populations, either they were infected longer, or they were actively being treated, or they were in the hepatitis E, HBV antigen positive or negative, or their DNA content at a different level. There's no difference, and in terms of immune response, and also in terms of the adverse reaction. So, and this result has been summarized and published in the submitted to the AASLD meeting, and we're still in the process of reorganizing the data for final publication. And the more interesting studies we have conducted is a so-called accelerated schedules, because there's a need of the this kind of fast immunization schedule in the emergency cases. So what we did was instead of regular 0-1-6 months, we use a 0-7-21 days schedule. And we did this with about an equal number of 60 number of person. And the immune response in terms of the accelerated group versus the routine immunization, the seroconversion rate is basically is the same, and their extent of the response is also the same, as is shown in here. At the end of their immunization, a month after the immunization, when you measure the immunity, it basically is the same at day 50, or versus longer terms. And we also monitoring these people over about 200 days. They're basically their immunity at that time is almost also very similar. And we have also have another 2 studies, ongoing studies, as a phase 4 study, also post-marketing study. One is being conducted in US at Emory University, and which is sponsored by NIH. We have to go through FDA's pre-IND as well as IND. We file an IND and then get the agreement to conduct this study. It's a very small number of patients, but basically, I think the value of the study itself is the IND. And there's another phase 4 study is being conducted at the ICDRB in Bangladesh. And this study is among the childbearing age women, and the numbers very relatively large. It's almost 20,000 population. And Dr. Zaman, the PI of the study, also published a protocol. And we have another phase 4 study. We are in the discussion with Dr. Velleman in Germany. And their interest is to see, can they prevent the transmission of hepatitis E among blood donors. And the genotype of hepatitis E, I want to just clarify that, because many people had concern of that. We wanted to, because there are the four genotypes, as Dr. Wu have already alluded earlier, but they only had one serotype. And the hepatitis E, we have done the study. The clinical study was done in the population. 93% are hepatitis or HEV type 4, but yet there are still 7% type 1. And yet we do not see any of the infection. And also the sequence of this vaccine is type 1, identical to the GSK's earlier study in Nepal, which was a type 1 environment and using a type 1 vaccine. So they also show the safety and the effectiveness there. And also we have done many across genotyping protection studies in the in vitro study in animals as well as in vitro. We actually monitoring very carefully of the epitopes in the structure basis, and again demonstrate they all cross react. So I don't think the genotype will be an issue. So how do we going to use this? I think the most important part of using this vaccine will be among the childbearing age women, most effective one. And of course, we also want to protect the pregnant women. However, the study has not been done. And because we just don't have the condition, we don't have enough cases in China to do this. And also, I think the protection of the chronic liver disease population is become more and more important because they have been observed both in many areas, both in China, in Europe, and as well as in Pakistan by Dr. Saeed. And the importance of protecting the chronic liver disease patient, and also the immune in Europe, and it shown many times the organ transplant recipient has been transmitted. Again, that population should be protected, and elderlies, as well as the emergent outbreaks. The emergent outbreaks are a big issue in the refugee camps and in Africa, throughout the continent, has been repeatedly, and we are working with the MSF on that. And also, I think this vaccine should be used among the healthcare personnel as well as travelers. If any of the area, endemic area, the general population, eventually, I think, should also be used. So anyhow, this should be my presentation. Thank you for your attention.
Thank you, Professor James, for these two very good presentations about the hepatitis C vaccine and a good news that it's going to be available in Pakistan. Let's change the topic, and we will be discussing about the quality and the future of GI practices in Pakistan in the next presentations. So I will request Dr. Ramna Subhan, who is a consultant gastroenterologist at Aga Khan University Hospital, and she will be talking about the quality standards in upper and lower GI endoscopy report. Dr. Ramna.
So thank you very much. So I would just like to confirm, am I audible and my screen is visible to everyone?
Yes, we can hear you and screen is visible.
Thank you very much. So Assalamu alaikum, ladies and gentlemen. So let's change the gear. And before moving to my presentation, I would like to show my gratitude, and I would like to thank Professor Masood Siddiq and the scientific committee for PSG for inviting me and giving me this opportunity to speak on this forum. So let's have a different topic as compared to liver and COVID-related issues. So for the next couple of minutes, I'll be talking about the quality standards in upper GI endoscopy reporting, a consensus statement by Pakistan Society of Gastroenterology and GI Endoscopy. I deliberately omitted the colonoscopy one because of the time constraints, and I thought that I should be emphasizing for this first new initiative, which has been taken from the platform of Pakistan Society of Pakistan Society of Gastroenterology and GI Endoscopy. So I don't have anything to declare as a conflict of interest. So ladies and gentlemen, we all are well aware of that upper GI endoscopy is now considered as a gold standard method for confirmation, surveillance, and the therapeutic intervention for the variety of upper GI gastrointestinal diseases. So a high quality endoscopy report will not only provide an extensive information regarding the findings, formulating a differential diagnosis to guide the plans of care and recommendation for the subsequent surveillance, it also provides an information about the interventions performed, the complication experience, and the modalities used to control, and with an achieved outcome. It also provides a roadmap to other endoscopists or the treating physician to develop an efficient plan of care if needed. It also facilitates the acquisition of data for the clinical research as well as the quality improvement. And nonetheless, the well-composed endoscopy report reflects a lot about the quality of work of an endoscopist. So there's so many benefits and so many pros of a good quality endoscopy reporting. However, what is the why factor? Why we thought about it? Because Yes, the wide variability has been observed in GI reports generated from the various areas in Pakistan, and we all see reports generated for upper GI endoscopy from the different people with the different formats. So it could be because of the multiple factors, including the non-availability of a computerized endoscopy reporting system, the lack of facilities for the record keeping, time constraints, and the variability in the skills and the training of endoscopists. Developing the standards with acceptable quality of EGD reporting that could be practiced across the country. This will not only facilitate the transfers of concise and accurate information to the people, but it also will help to also help the administrative and procuring agencies during the planning for equipment selection and procurement for the various institutions. So what was the purpose in the scope? So it includes to define the quality standards for a clear, concise endoscopy reporting that could be easy to follow even in a very resource limited setup. So here we aim to reduce the variation in reporting standards between individual endoscopists as well as between various endoscopy centers across the country. Hence, the recommendations are intended for the upper GI endoscopists, gastroenterologists, and the GI trainees across the Pakistan. So now the question was, how can we do that? So we selected the platform of Pakistan Society of Gastroenterology and the GI endoscopy for this important task. And the formation of these guidelines were commissioned by the Guideline Committee of PSG. So this guideline committee of the PSG is actually consists of an advisory group with very senior members, with a core group from the different chapters, with experts, gastroenterologists and endoscopists from the various areas of Pakistan, chaired by a PSG guideline committee. So this group is actually comprised of 20 experienced practicing gastroenterologists and endoscopies representing the different cities and the different institutions from all over the countries. So how we proceeded? So the idea was discussed and shared as an initiative and PhD Executive Committee and General Body meeting in 2018. The feasibility was evaluated, and in 2019 the idea was approved and the committee was formed. So the first face-to-face meeting was actually conducted in 2019, where we met face-to-face. We formulated the study questions, we defined our aims and scope, and the research question was identified based upon the literature search. And the literature search was again done by using the PubMed and the Google Scholars. The need analysis was done, and then the question was refined. After the literature review and all, what we did is we reviewed the various guidelines and papers, and from there, the common variables which appear to be needed as a quality variables for a good endoscopy reports were extracted, and all of them was reviewed by the committee members, and this was done between September to December 2019. Further that, we received a Delphi technique. The common variables were sent to the members via emails. The variables finalized in January 2020, and that the consensus was developed that after the feedback from the all committee members, those variable where there will be an expert agreement will be of more than 80% or equal to 80%, they will be included in the final recommendation. Then there was a face-to-face meeting and the presentation of all variables selected and the questionnaire. And this meeting was conducted during the annual meeting of PSG, February 2020. And during this meeting, all of these 20 experts, gastroenterologists, endoscopists, they participated and they voted for each variable. So each variable was discussed and the key points were noted. So the consensus was developed based upon their agreement to include those variables where the experts' agreement was more than 80% or equal to 80%. Based upon that, the draft of recommendation in the consensus statement was prepared. It was shared within email with the consensus committee members, and their suggestions and comments were incorporated. The final draft was again prepared and recirculated before the submission to Journal of JCPSP in January 2021. And after again having an additional comments, the final manuscript was prepared, which was ready for the submission and the submitted. So with the literature search, what we found that a total number of 22 variables were identified, and these variables were divided into 3 categories. Number 1, pre-procedure, inter-procedure, and the post-procedure reporting standards. The consensus was again developed, as I said, that more those variables which achieved like more than 80% of agreement were included. So these are the variable again considered that a good quality endoscopy reporting, which is relatively feasible for different settings in our country, what information should be included in that report. So the pre-procedural, so it was decided that there should be 2 unique identifiers be used for the generation of the report, which includes the patient name and the hospital record number. So where the hospital record number is not available, then the serial number or the NIC number could be used. But most of the experts thought that the patient name as well as the hospital record number, these are the most important variable one can actually keep as an identification parameter. So the report should include date, time, location, and the names of the doctor and or his assistant who has performed the procedure. It should be included in the name. So the patient age and gender should be mentioned, and almost 100% of everybody agreed on that. So the statement about a written informed consent should be included in the report, and 91% of the participant agreed on this. The indication for endoscopy should be specified, including whether this is an emergency or an elective procedure. So related to the intra-procedure, the type of endoscope should be mentioned, the method of sedation, for example, whether this was a local anesthesia, it was a conscious sedation, it was modified anesthesia care, or it was a general anesthesia, and the name of the drug should be mentioned in the report. So the dose and the route of the administration of the drug for the sedation used during the procedure would be an additional information, but at least the method of sedation and the drug which was used for the sedation, it should be mentioned. So the relevant findings and the pertinent negatives should be elaborated for the all areas, including the esophagus, J junction, stomach, and whether the stomach was operated or not, as well as the duodenum. Any lesion identified during the procedure should be described according to the specific classification. For example, if there is a Barrett esophagus, so it should be defined according to the Los Angeles classification, as well as if there is a duodenal ulcer, for example, then according to the Forrest classification, it should be described. So what about the photographs? You remember the photographs are very important the piece of information, because sometimes if the findings are not mentioned accurately in the words, one can have an idea by looking at the picture whether these findings are consistent with the abnormality reported or not. So the pictures are always useful. So the most of the guideline they recommended that at least 8 pictures should be taken, but definitely it will be very difficult for the people to practice this. So in resource limited setting, everybody agreed that the minimum of 6 pictures will be acceptable. And what are these areas could be? It could be distal it will include distal esophagus, J junction, stomach, antrum, body, fundus, first part of the duodenum, and the second part of the duodenum. So if you have taken the biopsies, the number and the site should be mentioned. The details of the therapeutic intervention, if this is performed, it should be reported. Again, the completeness of the procedure should be commented on with the justification provided if the procedure was left incomplete. A complication happened during the procedure should be acknowledged in the report. So the conclusion of endoscopy findings should be reported along with the most likely diagnosis, as well as if you will add a management plan, for example, the medication prescribed and a follow-up in a clinic, that will make your report perfect. So these were the variable where the agreement was not 80% or more than that. So hence they were not included. For example, mentioning the comorbidities of the patient, risk assessment according to the ASA classification, known allergies, and the vital before the procedure. And again, after the procedure, the vitals and post the management plan, including, for example, the medication could be provided to the patients, and any abbreviation used in endoscopy report. These are the variables that people think that we can omit, but if these are mentioned, definitely this will be an additional advantage of your report. So in summary, ladies and gentlemen, the standardization of upper GI endoscopy reporting is essential to improve the quality of patient care by facilitating the accurate transfer of information among all physicians involved in the patient's management. This consensus statement by PSG is a first initiative which strives to standardize the quality of endoscopy reporting across the country in order to facilitate the quality patient management. The guidelines were developed based upon an evidence-based recommendation from international societies and adapted according to the need and the resources available in our setting. So what is the way forward? The way forward is this was a first step. Now we'll be moving, or now we are moving to make the similar consensus statement for the other endoscopies like colonoscopies and ERCPs and EUS. The dissemination of this information is a big challenge, and now we will start working on that. Once this will be published in JCP SP, the other ways of the dissemination will be looked for. More than that, the next important task for us is the development of a user-friendly, cost-effective software application for endoscopy reporting, which could be used by the different people, whether they are working in small cities, small center, and this could be developed from the platform of PSG and could be provided to the people to be used. And again, the audits of quality standards in endoscopy reporting could lead to an improvement in the quality of endoscopy reporting and definitely the benefit. So this is the first step, and I said that, but there are so many miles still waiting to be traveled for. But definitely the journey starts with the first step. So the second step is actually tomorrow, which is the second PSG consensus statement meeting for development of standard endoscopy reporting for colonoscopy, which will be held tomorrow. And definitely the findings could be shared in next annual meeting with you. Or if this will be published before that, then you will be able to read it. So I thank you all for your kind listening. And again, I would like to acknowledge the extreme tremendous support from Professor Masood Siddiq and Professor Saad Khalid Niyaz. And without their support, this thing was not possible. And again, I would show my gratitude, as well as I would be thankful to all of these 20 experts who participated and gave their valuable time and suggestions to develop this consensus statement. So thank you very much, everyone. Thank you very much.
Thank you very much, Amna. And kindly be available online. Maybe some audience want to have some questions from you. So it's the end of our session. And if there are some questions, most of the speakers are not available. But if you have some questions, it may be discussed over there. So I will request our chairman, chairpersons. Ji.
Thank you very much. My name is Dr. Naman. I'm a medical specialist. I have two queries. First of all, I would like to ask, what is the status of Hecoline vaccine so far in FDA? So this is my first question. Number two, I would like to ask, can we give this vaccination to the already pregnant ladies who have already been vaccinated with hepatitis B? So can we additionally give this? Thank you very much.
Dr. Uma, could you answer his questions?
Yep, sure. So there's another question there. आ रही है बस.
And that will include the questions asked by the gentleman.
Hello. Yeah. Okay. So I'll try to answer the questions. The first question was, what is the status of hecoline in Pakistan? So as I told you earlier, that this drug has been registered in Pakistan, it has been priced and is available in the market. So this is the status. You can buy it and give it to your patients. Generally, it is not recommended during pregnancy and especially in the first trimester. But after second trimester, if there's an outbreak and you fear that your patient Hello, yep. And if you think that there's a chance that the population, there's an outbreak and you have a feeling that the pregnant lady might have a fear of getting infected, then you can give it in the second and the third trimester. But the studies that were shown by our Chinese colleague, they showed that some women were accidentally vaccinated because they did not know their pregnant status. And when they were given, they had no side effects to the woman and to their newborn child. So I hope this has answered your two questions. Then for what they were trying to show, I'm sorry, because they have the accent issues, but they were showing that this vaccine has been produced in Pakistan, in China. There are 4 types. Of the 4 types, the 1 and 2 are human and 3 and 4 are animal. But the vaccine which has been produced with the type 1 covers all genotypes. So there's no fear that it would not cover the genotype 2. The vaccine has been found safe if you give it simultaneously with hepatitis B. You can give, they showed that you can even give it during pregnancy. But the 3 dose generally recommended, at, which is intramuscular 0.5 ml, which you give at day 0 and then day 1 and 1 month and then 6 months. And following the vaccination, the antibodies they have found doing serial titers that they remain in body for about 4.5 to 5 years. So the efficacy of the vaccine is stability, its use is there. And because Pakistan is one of the countries where we have this disease coming up all the year round, it's pandemic. So I think it's a very good, reason for us to include this vaccine into not only our EPI program, because although EPI generally covers in Pakistan the pediatric population less than 1 year of age, but Gavi recently has approved the human papilloma vaccine in the EPI, and human papilloma vaccine is again a female vaccine to prevent the cervical cancer. So if they're putting in a female adult vaccine into EPI, then we can always push this case for putting the hepatitis E vaccine also with it, because it's a life-saving vaccine. So, but then till the time that Gavi takes it up, I think it's our responsibility to try to save lives and by vaccinating whosoever can afford the vaccine. Thank you.
I'll just like to make one comment here. Vaccination with hepatitis E or A, I hope we get an A vaccine, is also good. But we should try and impress upon our patients that most of them living in cities in Pakistan, at least in the northern Pakistan that I know, rely upon filters for their water source. No matter how you filter the water, the viruses will get through. The only safe water is boiled water. The only safe water is boiled water, and I cannot stress that point strongly enough. So make sure that in your homes and in every home that you know, and to your patients, you also tell them that filters will not work for these viruses. The water needs to be boiled. Just one boil, even for a second. That is all that is required, although WHO recommends 1 minute of simmering, but even just a boil would be enough. Let it cool and then use that water for drinking.
I'm Dr. Mohammed Afzal, I'm a physician. I just have only want to add to the hepatitis E virus because it has been quite endemic in Lahore, and nowadays we are seeing patients even in periphery, and I have seen few patients in Gujarat. I think we should give a clear message to the gynecologists and to the general physicians. If the patients, pregnant patients are more worried during their first trimester, either they will get vaccine before or during first. Otherwise, when the first trimester is over, they think that now the things are quite settled. So I think if there is no contraindication, absolute contraindication, we should recommend them to give in first trimester or before pregnancy, because it will take some time to produce antibodies. But what are your comments?
Actually, I would not be the right person to kind of put the recommendation that you give it in first trimester of pregnancy, because by and large, all drugs are not recommended in pregnancy. It is only in the second and the third trimester that people are trying to, give in the drugs. But the best population to receive is the non-pregnant reproductive age women. So that's the priority group. But then if it's an epidemic, if there's an outbreak in an area and you fear that this pregnant women might get infected, then that is the time that you can probably push them in the second trimester, but not in the first, because to date, it is not put in the recommendation. So we can't go off the, thank you.
I am wonderful, excellent, and appreciable presentation by all the presenters. My question is from Professor Wasim Jafri sir. If he is online.
He is not online.
He is not online.
No, he's not online.
Thank you. हाँ पूछ लूं आपसे पूछ लूं is COVID-19, the entry point is the ACE inhibitors, and the ACE inhibitors are very prevalent, and they are 100 times more in the GI tract as well as the biliary tract, but it is more fatal and the incidence is very high in the lung. What is the reason? ACE receptors. ACE receptors are the entry point, but they are very common and 100 times more in the GI tract as well as the biliary tract. But the incidence as well as the fatality is very high in the lung. What's the reason? If anybody can answer.
So as the fatality is not a direct result of the viral infection. It is indirectly a result of the viral infection in that the virus causes CRS or multi-organ failure, and that leads to disseminated intravascular coagulation. And mainly the lungs are clogged with very small arteriolar clots, and that causes the damage in the lungs mainly. It's not a direct effect of the virus affecting the lungs. So basically the treatment at that stage would be that of cytokine release storm rather than that of the virus. The virus persists in the body in high dosages for in the first 7 to 10 days, whereas most deaths would occur in the second to third week of the illness, and that is because of the cytokine release syndrome. The treatment there would be tocilizumab to prevent the release of IL-6 or block the IL-6, and that is how we attempt to treat that. Plus, we give high doses of anticoagulants like the Clexane or heparin to decrease the effect of the coagulation. If you look at the D-dimers and the FTPs in those patients, they're way, way high.
No,
So it's
these
not that-
cytokines are also present in the liver as well as the biliary tract and the GI tract. So why there is no cytokine storms in these organs?
So there is a cytokine storm and there is the effect in the liver, but we don't know everything about this virus. There are things that we're still, that's what Wasim Saab said, and that is what anybody who's dealing with this virus will tell you. We're still learning about these things. There are derangements in the liver enzymes, and liver enzyme derangement is pretty common, but it's not very high. The ALT and AST are raised by a factor of about 2 to 3. But the drugs that we're using for example, remdesivir itself will cause rising of the ALTs. And if it rises more than 3 to 5 times, then remdesivir will be contraindicated in these patients. Similarly, tocilizumab can also cause rise in the ALT and AST. But somehow the other liver is not that affected. But Professor Wasim did show us the photographs of those livers in which the portal veins were all clotted up. There was clots within the portal veins, and the walls of the portal veins were fibrosed. So there is effect in the liver. Anything that has got to do with coagulation has to do with liver also. And this is basically a coagulation disorder which kills the person. And that coagulation disorder is caused by a cytokine storm. So liver is definitely involved. Maybe how exactly is it helping in the overall death causation, we don't know as yet.
Sir, I think this discussion, COVID discussion, will be too long and we are short of time. I will request the chairperson to wrap up the session.
So I think it's my duty now to wrap up. First of all, thank all the speakers for their excellent contributions to the GI Society's this meeting. The talk of COVID-19 and the liver disease from Professor Wasim Jafri especially showed that the people with the non-alcoholic fatty liver disease were more prone to get disease, COVID-related complications and deaths and morbidity in NAFLD patients. And apart from all other morbidities which are there in liver patients, if they were ever getting infected with the COVID-19. Then there was the talk about COVID-19 and the pancreas and by Dr. Bakar, and he showed that the Bradford Hill criteria can be used to assess the involvement of the pancreas with the COVID-19. And again, a very, very strong association was shown with the pancreatic disease and the COVID-19 in some Bradford criteria, but not in all. Then we had these two talks on hepatitis E vaccination vaccine, that how it was produced and then how it works. The clinical trials were shown from phase 1 to phase 3 from James and Ting Wo from China, and they showed that this vaccine has been developed and is undergoing the WHO approval. The vaccine has a pretty good efficacy of over 98-99% protection, with 3 doses of intramuscular vaccine being given at 0, 1, and 6 months. And it can be given to all age groups, but generally it's recommended to over 16 years of age. But the trial showed that when they gave it to people who were elderly, like over 65 years, even their response was very good. Once vaccinated, the protection lasts for over 5 years, and there are no major side effects. It can be given even if accidentally given in pregnancy, it has no side effects. Then we had the last talk from Dr. Amna from Khan. And that was on the quality standards in the endoscopy, in which they used a system of developing a consensus on the endoscopy reporting using consensus of the experts. And they have come up with the reporting of the upper GI endoscopy using this consensus statement. And that's a good start because they're trying to standardize the reporting of the upper GI endoscopy in Pakistan. And as of today, she says that tomorrow they'll develop the colonoscopy criteria and the consensus statement. So good wishes to Dr. Amna, and hope that we'll get another report next year. And that was all. And I would now like to thank the audience who have been very patient and very interactive, and had a lot of queries which hopefully have been answered. So thank you very much. You have been a wonderful audience. Thank you.
Ladies and gentlemen, please keep sitting. We have now a state-of-the-art lecture from Dr. Jimmy Limday. He has sent us a recording, but he's available online and will be available for question and answers later on.
So gastrinoma is gastrin secreting tumor that arise from pancreatic islet cell or sometime in the duodenum. They may present with hyper gastrin secretion leading to ulcers around the duodenum as well as severe ulceration in the stomach, what we call Zolliger-Ellison syndrome. Vipoma or vasoactive intestinal peptide tumors are primarily arising again from the pancreatic islet cell, may also occur in the lung or liver as a primary source of secretion. And they secrete VIP, a hormone, and glucagonoma is a glucagon secreting tumor. They also arise from the primary islet cell. And somatostatinoma secretes somatostatin that arise from small intestine, and majority of them arise from the pancreas, though they are very rare tumor. So coming to the diagnosis of neuroendocrine tumor, majority of the time they are diagnosed incidentally. Clinical symptoms sometimes may or may not be present, but an elevated 5-hydroxyindole acetic acid is associated with classical carcinoid syndrome, where the patient may present with flushing, diarrhea, and a mass, which may be diagnosed on imaging technique. So the important thing is measurement of chromogranin A or CGA, which is the gold standard for confirming a diagnosis of neuroendocrine tumor. So initial workup may include contrast-enhanced CT scan along with MRI or contrast-enhanced MRI or ultrasound. Octreoscan, or which is the centrostatin receptor scintigraphy, can be utilized in octreotide secreting tumor. Nowadays, we have endoscopic ultrasound facilities. So endoscopic ultrasound is helpful in diagnosing, making the diagnosis of tumor, and especially when this is metastasis. When we have metastasis, we can use elastography. There are some US machine where you have elastography. It depends on the ultrasound machine that you have purchased in your unit. So elastography can be utilized to delineate the tumor metastasis, and then you may get a tissue diagnosis with US guided fine needle aspiration or getting a biopsy with the EUS. Sometimes this can be diagnosed with capsule endoscopy, and midgut tumors and hindgut midgut tumors can be diagnosed with endoscopy. This is the octotide scan, which is showing active uptake of somatostatin, which is the hallmark of presence of somatostatin receptor in the liver. This another picture of endoscopic ultrasound where elastography is showing the metastatic deposits. So these modalities are very helpful in diagnosis of the tumor. WHO has given us a classification of gastrointestinal tumor. So well-differentiated tumor are grade 1 and grade 2. So by definition, grade 1 tumor is where Ki67 index is less than 3% and mitotic figure which we find is less than 2 per 10 high power field. Similarly, grade 2, 3 to 20 Ki index, 67 Ki index, and 2 to 20 mitotic figure in 10 high power field. When we have grade 3, this is poorly differentiated neuroendocrine tumor, which is defined as more than 20 Ki67 percent index, as well as mitotic figure of 20 or more than 20 per 10 high power field. Grade 3 are notorious tumor, and they grow rapidly, and most of the time these are the one which give symptoms, and they are usually metastasizing tumor. Grade 1 and grade 2 rarely metastasize, and they give minimal symptoms. So the treatment is roaming around debulking of the tumor, especially when we are dealing with the metastatic tumor. We need to, the principle of therapy is to debulk the tumor, which can be with the surgery as a primary treatment for the tumor. For a small tumors, neuroendocrine tumor, we can use endoscopic mucosal resection or endoscopic submucosal dissection to get rid of gastric, rectal, or duodenal neuroendocrine tumor. So if the tumor is localized, surgery is potentially curable, and 5-year survival is reaching up to 80 to 100%. In my experience, I have resected 4 or 5 neuroendocrine. 3 were from gastric, 1 was duodenum, and 1 was rectum. And they were all localized tumor through EMR. So when we are talking about metastatic neuroendocrine tumors, surgery, the principle of surgery is basically to reduce the tumor mass or tumor bulk. And if there is residual tumor is present after surgery, medicine may be needed as an adjuvant therapy. For liver metastasis, we can use transarterial embolization or transarterial chemoembolization, which is going to reduce your tumor bulk, and hence decrease the symptoms, as well as it may be helpful in increasing the survival. Most of the patients with metastatic disease are treated by debulking surgery and combination of medicinal management. So I'll take you around first endoscopic management, and then different therapies and chemotherapeutic trial. This is the recent article of experience of periampullary EMR. You can see in figure A that this is a large periampullary ulcerated area that we are seeing here, and this was resected with hexagonal snare utilizing EMR technique. And in this article, they have not mentioned about putting stents in the pancreatic and CBD. What I have resected 6-8 months ago, I had done ERCP with putting a stent in both area, and then resecting this periampullary and duodenal mass. What they have done in the section D is they have put a clip to control the rent, and that was done by us in resection. So in this figure E, with the, if you can see here, the arrowheads in the histological picture, this is a neuroendocrine cell that we are seeing with special staining. So there's another series of paper, the series of experience of 350 neuroendocrine rectal neuroendocrine tumor that were resected with EMR. So out of these 350, they have excluded 73 because they were 70 because they were done outside, and in gross examination, they were unable to do incomplete section in 3, so they have excluded these 73. And then they were left with 277 patients undergoing endoscopic complete section, and 1/3 lost to follow for 2 years. They have a follow-up of 2 years in 183 patients undergoing endoscopic follow-up. In this paper, they are talking about complete section, which was grossly or macroscopically given as en bloc resection, which was achieved with 99% of rectal neuroendocrine tumor, but histological complete resection rate with the positive margin were not seen in all patients. So complete resection or a histological resection was seen in 74 patients of those patients who were investigated with EMR. And complete histological resection may be associated with tumor size. So they have reported that a small tumor had 98% resection versus those tumors who were resected with more than 2 centimeters. They have incomplete section with positive tumor resection margin. So I'm taking you along different areas. So this is gastric neuroendocrine tumor, which is divided into 4 types, subtypes as type 1, type 2, type 3, and type 4. It is dependent. Type 1 is the most common. Nearly 75 to 80% of tumor belongs to type 1 gastric neuroendocrine tumor, where they are found in gastric body and fundus. This is associated with hypergastrinemia with atrophic gastritis. Endoscopically, they can be treated with polypectomy, EMR, and ESD. In my series, I have resected majority of them, like all of them were type 1. For type 3 and type 4, they are advanced tumor, and they are treated surgically with poor outcome. So gastric neuroendocrine tumor, this again, almost a repetition. I'm skipping this. If you have appendicular neuroendocrine tumor, it depends. Sometimes it is presented with simple appendectomy and histopathology. The patient comes to you with after histopathology, after he has gone through surgery. So if this is simple appendectomy and the tumor is not involving the base and the tumor is less than 1 centimeter, surgery is enough. For tumor which is between 1 to 2 centimeter, so periodic follow-up is needed with the contrast on CT scan, as well as endoscopic surveillance for 5 years. If you have tumor that is involving the base of the resection, we may need as a follow-up hemicolectomy to have a complete or you can complete section in a second session. If you have positive lymph nodes around the area, lymphovascular invasion, or KI index, which is more, then we have to go for right hemicolectomy. If the tumor is more than 2 centimeters, then it is recommended that the surgeon should go for right hemicolectomy. As a gastroenterologist, we should be in liaison with our GI surgeons because this is very important to have a safe wavelength as they are thinking, and we should be thinking on the same line. So this is important to have a teamwork, and MDT are basically the area where we should emphasize that every institute, especially in Pakistan, we should establish MDT culture, and we discuss these cases and help our patients in the management. Coming to the pancreatic neuroendocrine tumor, this was first described in 1869, and the majority of the tumor, 98 to 99% that we diagnose in pancreas are not neuroendocrine, but only 1 to 2% of the tumors are neuroendocrine tumor, and the incidence is very, very low. 1 case per 100,000 per year is diagnosis. So this is somatostatin, long-acting somatostatin trial and PROMET. So in PROMET, what they have done is they treated treatment naive patient with advanced gastrointestinal neuroendocrine tumor, be it gastric or any other area or pancreatic. So they randomized 42 patients in the treatment group with sandostatin LAR, and 43 patients received placebo with all supportive care. So the primary aim was time to progression. which was seen significant, very significant from placebo group of 6 months survival time to progression. It was taken to 14.3, and disease progression was reduced by 66%. It was also a pivotal trial in this that functional as well as non-functional, both tumor had response, and also we can use this sandostatin LAR or long-acting sandostatin in the dose of 30 milligram every 4 weeks to treat symptoms of vipoma, glaucoma, and gastrinoma, and it is also helpful in decreasing symptoms of diarrhea, severe diarrhea. So again, this is the PROMET trial where this is 66% reduction of risk of progression. And when we compare functional versus non-functional tumor, then there was no difference. So functional tumor reduction was 77% in progression versus 75%. So it was helpful in both functional and non-functional neuroendocrine tumors. So when we talk about tumor markers and progression, so biomarker chromogram A is the mostly studied biomarker and has a sensitivity and specificity of diagnosis as well as prognosis as 66 to 95%, and it's a very reliable marker in terms of prognosis as well as follow-up in the disease process. Then we have neuron-specific enolase, which is less sensitive, and then pancreatic polypeptide and pro-GRP are very, very non-specific. Coming to what is new or what is new in the horizon of research, there are phase 2 trial which are bevacizumab, sunitinib, as well as sorafenib and livertinib. This is a single-arm trial. They are comparing research molecule with the standard of care or best standard of care, and the survival with sunitinib was 10.2 months. Though the randomized controlled trial, they have 3 arms. This is one of the pivotal trial where they used octreotide along with bevacizumab versus octreotide and interferon versus pepazumab and placebo, and the survival benefit was 16.6 months in group 1 versus group 2, almost similar. There was no difference versus placebo. There was definitely big difference. Then we have lenalidomide in metastatic enteropancreatic neuroendocrine tumor. This was published recently in New England Journal of Medicine. And the primary endpoint as of other trial is progression-free survival, which was defined as the time to disease progression, which was evaluated on CT by RECIST criteria. And secondary endpoint were overall survival and quality of life. So lenalidomide 120 milligram was superior to placebo in this trial, and there was you can see here that all are on the left side of the midline. With only hindgut, there was no minimal response versus pancreatic, midgut tumor, and have a very good response. So at 48 weeks, this was 66% versus 96 weeks, which is 3 years. The response was lenalidomide was 52% versus placebo 25%. And also there was improvement in quality of life measures. So they concluded that lenalidomide was associated with significant and prolonged progression-free survival among patients with metastatic enteropancreatic neuroendocrine tumor. Coming to another trial of dotatate for midgut neuroendocrine tumor, because we know that midgut tumor in the previous here, you can see midgut tumor had response as well. So this was randomly assigned to 29 patient who had well-differentiated tumor, and the primary endpoint was again progression-free survival. An endpoint was response rate and overall survival along with safety and side effect profile. And you can see here that dotatate had a very good survival benefit and versus a placebo in this randomized controlled trial. So what they concluded that this has resulted in markedly longer progression-free survival and a significantly higher response rate than high-dose octreotide LAR among patients, because this was being compared. I missed that. This was being compared with the high-dose LAR. The usual dose is 60 milligram. They were using 60 milligram instead of 30 milligram octreotide LAR in advanced mid-gut neuroendocrine tumor. And preliminary evidence of overall survival benefit was also seen in the interim analysis, and this is an ongoing trial. So just to summarize, in terms of management, potential strategies for management of neuroendocrine tumor is associated with liver metastasis thereof, which is personalized medicine. So we have to target the molecule specifically. And as I said, MDT are the key here to discuss with your radiologist, with your oncologist and radiotherapist to have a best result and outcome for our patient. So neuroendocrine liver metastasis patient, when we are treating with them, it depends on how to treat it. Just like when we treat HCC, this is based on performance status. If the status is poor, we just give palliative therapy or symptomatic therapy. If the performance status is good, then it is dependent on whether the tumor is giving symptoms or not. If the symptoms are arising from the tumor, the primary aim is basically to treat the primary tumor. And then if there is, when we treat the symptoms, along with that, we give them therapy. So if this is oligometastasis, then we go for debulking or resection and try to resect as much as possible to control therapy. And then we may need to combine this with local control along with neoadjuvant chemotherapy with octreotide LAR. Especially the results are good in positive octreoscan tumor as compared to negative octreoscan tumor. Then we can use these new molecules as a systemic therapy and as an adjuvant therapy. So just to conclude, neuroendocrine tumors are a heterogeneous group of tumor with complicated outcome and treatment. Surgical and endoscopic resection are still the only curative therapy option for localized pancreatic, duodenal, gastric, or particular neuroendocrine tumor, along with the rectum. And great progress has been achieved in drug therapy, and combination with local control for advanced neuroendocrine tumor is being achieved, where we can see at least 3 year, we are talking about 3 year survival with these new molecule. And we expect that with the completion of this ongoing trial, they are looking for 5 year survival now. So the result is expected to be out in this ESCO. And I'm thankful to this patient listening. My apologies that I could not attend because of my family pressure, unfortunately. Thank you very much.
Thanks, Professor Dr. Zaid Azam, for a nice talk. Now the session is open for the question and answer. Any questions from the audience?
Just I want to ask one question. As far as upper J bleed is concerned, it has been told in the presentation that RBS is for rebleeding, but nowadays it has been validated in the literature that whether it is used in patients with in patients who have more comorbidities, and whether this is validated for inpatients risk of rebleeding. Whenever the patient has endoscopy, then after endoscopy, how much the risk is present in that particular patient to have rebleed. So in that particular status, ROCAL score is validated. So this is a thing which is ongoing, or whether it is applicable here in this part of the world. So this is one thing which need to be clear.
I think Dr. Javed Farooqi left the
Dr. Nazish will give the answer, please.
Sorry, sir is here. Dr. Jawad Farooqi is here.
Coming. Dr. Farooqi is coming. So you can repeat the question.
Please.
No, it's a well-established fact that ROCAL score is used for the to score the or to assess the mortality or morbidity during the endoscopy to assess. So I don't understand your question. It's already validated. No. Yes, yes.
Okay.
On the basis of the score, you can.
Yeah, you
Yeah.
see this especially for my junior colleagues, they're really confused where to use which one. The GBS or Glasgow scale score, this is basically when a patient comes to you with upper GI bleed, you calculate, is there any risk? Time maybe that you won't do the endoscopy, don't do hospitalize, just do some drugs at home when it is 1 or less than 1, okay? It has the clinicals as well as the lab parameters, lab is the hemoglobin as well as the urea. So that is the first one, okay? My PGs, they mostly go for the ROCAL. ROCAL is, all parameters are only when you do the endoscopy. So the first one is, the GBS is to decide whether my patient needs any intervention or not. What is intervention? It's the endoscopy. Okay? So you decided, yes, my patient needs intervention. You admitted the patient and stabilized. Okay, he's stable already. So you do the endoscopy, and on endoscopy, you see the ulcers if this peptic ulcer, what Forest classification is. And then what is the diagnosis? What was the reason? Diaphragm lesion, so just the ulcer bleeding. It was some stomach tumor bleeding. And what are the stigmata? Suppose the patient may be bleeding from peptic ulcer. The ulcer, it will be clean paste. Okay, so these two, they have got, without these two parameters, the ROCAL score is only 7 or 6, 7, and that is full 13. So you cannot apply the ROCAL score before endoscopy. So GBS, you selected by this patient needs endoscopy, this patient does not need endoscopy, and of course for endoscopy you will admit a patient stabilizing. Okay, then you did the endoscopy. No, it will be high risk, low risk. Then you apply this AIMS. AIMS tells you, okay, by this patient whom I did the endoscopy, you keep that for 24 hours, suppose, or 48 hours in general ward, or the patient needs ICU care. The AIMS 65 tells you what's the mortality and whether the patient really needs intensive care. The ROCAL doesn't tell you exactly. Yes, the both, you use the both. It's not that you put the patient in computer and tells you, this is the clinical sense yours, but these give you parameters that just give you the predictability. So the sequence is that GBS before, endoscopy at the presentation, ROCAL when you do the endoscopy, you calculate what's the risk, and then AIMS tells you further on whether in hospital the patient should be in the general gastro ward or in ITU or in ICU. That was the, I wanted to clarify that which score should be used at what stage. That was, yes, AIMS you can use because there are no endoscopic parameters. With the GBS you can use that as well. But ROCAL is always, the full parameters are with the after endoscopy. That's the reason. That nature. Jigbal.
Sir, my question is, sir, from Kamran,
Okay.
sir, as well you, for how much and for how long time we will use SSRIs or triglyceride and chronic dyspepsia or antidepressant as given in combination?
I think Dr. Kamran left
Kamran
the
Hassan.
session.
Yeah.
Any?
Yeah, you see for these dyspepsias, what you do that the thing is whether the patient you should do the endoscopy or not inhale on that. On average, 6 to 8 weeks, 4 to 6 to 8 weeks, these drugs we give that. And also it needs proper assessment as well. You see, though the FGID is the bread and butter of the gastroenterologist, I mean, but most of them, my colleagues will agree with me, they really don't have the organic cause for that. Yes, it may be gastroparesis, something like that, but the ulcer, malignancy, yes, if my patient is from your belt, Palestina or Afghanistan, there, I mean, we have seen yesterday, day before today, I saw colorectal cancer from Afghanistan, age was 21 years, with full liver mets. So yes, that is another story. But by and large, 4 to 6 weeks, maybe 8 weeks, you can do that. And there should be a good response of that. One thing is that if your patient has got some sorts of, with the gastroparesis, also the constipation, then go for this fluoxetine-like thing, SSRI. But if that patient has got the diarrhea component as well, go for this triptanol, the sensible acting, because the side effects of the triptanol is constipation, and side effects of the SSRI is diarrhea. So you counter that.
Thank you, sir.
There was a very landmark study published in NEJM regarding use of this SSRI citalopram, especially for the for the irritable bowel syndrome or functional GI dyspepsia. In that trial, they have given the SSRI for around 3 months in patients. Then in the follow-up, because you know the functional GI disorder is due to psychological issues. So sometimes when the patient is happy, all the symptoms gone. So you can ask them after certain duration, then if they have again developed symptoms, they can start the treatment, but not for the prolonged duration.
If the patient has resistant H. pylori, like if we come across in OPD, a patient who has stool for H. pylori is positive again and again, despite of giving sequential therapy and plus this antidepressant, then what is the strategy to manage these type of patients?
Sir, can I just add a couple of things, please? I think one of the things that is very important, and when you're managing these patients before you start SSRIs or amitriptyline or mirtazapine, I think it's very important to spend time. These patients, which in my experience have, by the time they come to see me, have had two or sometimes 3, 4 endoscopies. Absolutely unnecessary. Young patients clearly don't need endoscopy. You can sit down, spend time, and basically I feel when you do that, an incorrect endoscopy is haram income, period. We like to talk about corruption in every field. Corruption in our field is that the patient comes to you for an opinion, and when you do something which is not correct, then I'm sorry, but we are all accountable. And accountable in the court high up, yahan to koi puchne wala nahi. The point that you are making, H. pylori, is a very difficult issue. Firstly, in our population, what international literature is saying is based on the prevalence they have. The kind of prevalence we have here, I'm not too sure that everybody should be treated for H. pylori. The ones that in our practice respond most are the ones who responded to PPIs. But one thing is very important. Again, if you're going to treat H. pylori, you have to tell the patient that, look, there is a chance that you will respond and there's a chance you might not. And this H. pylori and ulcer thing we all keep hearing. I think if the patient has not responded to multiple therapies, really, in my experience, there is no point continuing with antibiotics after antibiotics. You just have to give up and wait for something better to come. And just reassure the patient that not everybody who's got H. pylori is going to end up having either ulcer or cancer. Thank you.
Well, I will second you, Saad, that very nicely said. But in H. pylori treatment, we have to reassure whether the patient was compliant or not. That's a very big issue in our society, that people are not compliant to correct dosage, correct duration. And that is and before prescription of H. pylori therapy, we need to consider whether the patient has taken any of these drugs which you are going to prescribe before 2 weeks prior to your therapy. That drug has not been. Very commonly used clarithromycin and metronidazole are the people are taking like candies, right? And if they have taken, it before 2 weeks, the chances of eradication go very low. So you have to be cautious when you are prescribed. And you see, the dosage is so high in this H. pylori treatment. The patient कहता है गरम कैप्सूल खा लिया सर, 4 कैप्सूल आप खिला रहे हो.
Because of the shortage of time,
okay.
No, may I request to honorable chair to conclude the session, please.
Okay, that's right.
Our first speaker was Dr. Kamran Hassan. He gave lecture on functional dyspepsia, very good lecture in which he highlights all possible causes and clinical presentation, investigation and management. Thank you, Dr. Kamran. Our second speaker was Professor Javed Iqbal Farooqi. He gives very comprehensive, knowledgeable presentation on non-racial bleeding. He talks about all important clinical findings, investigations, and management briefly, but cover all important aspects. Thank you, Dr. Professor Javed Iqbal Farooqi. Our third speaker was Professor Nazish Bhatt. Gives on very important presentation, CS stomach. She gives a very valuable talk and highlights all important clinical presentation of patient about diagnosis, staging of CA, differential diagnosis, investigations, and its management clinically. And our third speaker was Professor Hafiz. Gives very good, valuable talks on gastroparesis, in which he discusses all possible management in detail. And our last speaker was Professor Zahid. He also gives comprehensive talk on neuroendocrine tumors of GI tract. And Dr. Hafiz, Dr. Zahid Ashmi, Dr. Javed Iqbal Farooqi, thank you very much. I also thanks for audience for patient listening and request for my chair.
Thank you very much, sir. So very nice presenters, and they presented very nicely and explained every topic in a brief and summarized way, and almost covers all the aspects. So now we will conclude the section, and before conclusion of the section, I request we will start the general body meeting now, and that will be started very soon in 1 to 3 minutes. So I request all the members of the PSG, they should sit inside this hall so that we can start our general body meeting immediately. Thank you very much.